जुडाते हैं सर तो पहले लेक्चर चालू यस सर हाँ वही सेट कर रहा हूँ
Listen. You put the timer on today?
Timer. Oh.
Hello, hello.
പറഞ്ഞിട്ടുണ്ട് സാർ പറഞ്ഞു
Yeah, this is there's no problem. These are organizing secretary.
So we have combined all the three halls now, hall A, B, C. We have combined them together. And with this, we'll start the sessions.
Welcome to the second day of the Neuro Conference 2024. After a successful first day of insightful discussion and presentation, we are excited to continue advancement in neuroscience today. Our agenda is packed with sessions that delve deeper into cutting-edge research, innovative technologies, and emerging trends in the field. We encourage you to engage with the speakers, participate in discussion, and take this opportunity to network with fellow attendees who share your passion for neuroscience. Let's make most of this day as we continue to push the boundaries of knowledge and innovation in neuroscience. Thank you for joining us, and we look forward to an inspiring and productive day ahead. Let us start the second day of the NeuroCon 2024.
Now we are going to start our first session. Let me introduce the chairpersons of our first session. William Goodward, Dr. Prakash Nair, Dr. Anil Sharma. So I invite them to be seated in the chairs provided up front. Please join us, sirs. So our next speaker is Dr. Kuntal Kantidas, who has MS, MCH in neurosurgery and is an associate professor in neurosurgery in SGP-GIMS Lucknow. His special expertise are brain tumor surgery, cerebrovascular surgery, and cranial base surgery. Please join us, sir.
Good morning to everyone, respected chairpersons and audience. First and foremost, I'd like to thank Dr. Ayub Cherian and Dr. Devabrata for extending me this invitation. And I'm going to talk on the combined transcavernous anti-transpetrosal approach. Although the conference is themed on something new, I don't think this approach is anything new to all of us, but definitely it deserves a renewed interest in the contemporary times. So when we talk about pathologies involving the upper part of the clivus and the upper part of the cerebellopontine angle, as well as the retrocellular area, we have generally two kinds of approaches. The first one you see on the screen is an anterolateral approach, also called the pretemporal transcavernous approach. Here we take down the antroclinoid process. We peel the layers of the cavernous sinus lateral wall, and we access the pathologies either extradural or intradural, but we stay medial to the fifth cranial nerve. So when we have to go for a pathology which is more lateral, we choose another skull-based approach that is called Kawasai's approach. It is essentially an approach lateral to the fifth cranial nerve. But there are situations where we need to combine the two, which I'll show in the subsequent slides. And this is what my presentation is all about, combining these two classic approaches. Now, you all know this anatomy, and I don't think it requires any more reminding. But what I want to emphasize in the second image that you can see is in the transcavernous approach, our target area are antroclinoid process, the optic nerve, carotid, and the V1, V2, V3, as well as the fourth nerve. But when we talk about going more lateral, we have to consider the fifth cranial nerve and the structures lateral to it. We all know the Kawasai's rhomboid, the Glasgow's triangle. I just want to highlight two important things here. First and foremost is the internal auditory meatus cannot be seen. We have to imagine its position. And various landmarks have been given, but roughly what we can do is we can make a line of the arcuate eminence and the GSPN, which are easily seen. And if we can bifurcate that line at around 61 degrees, as described by Professor Roton, we get this internal auditory meatus. Another important thing is this angle that I've shown with the red color. This is exactly the area where the cochlea lies. So during anteropetrosectomies, we have to be careful in this area, otherwise we can induce a hearing deficit. So I'll show you in steps how we do it. This is a right-sided frontotemporal approach. The first step is division of the meningoorbital band. This is the beginning of the dural pilling, as you see. Sharp dissection is advisable. And we start the peeling here. And as you see, the sphenoparietal sinus. Management of this sinus is very, very important. to avoid an intradural brain swelling. So the peeling starts anteriorly and we go posteriorly and we expose the interclinical process completely. So exposure of the interclinical requires dural peeling. Now in our institution, we follow this technique where we release some CSF at the beginning. It relaxes the brain and we can see the optic nerve as we are deroofing the optic canal, as you see here. Once the optic canal is deroofed, the third structure which is adhering the interclinical process is the optic strut. We drill the optic strut end on, and when the interclinical process becomes mobile, we know that the disconnection has been done completely. The interclinoid is removed. This is the area of the optic strut. In tumor cases, we don't need flush drilling of the optic strut, but in aneurysms, we need. My colleague would be showing you that. Spinoparietal sinus drains between V1 and V2, as you see here. And sharp dissection here is very important to preserve this vein. The idea is to be able to put fibrin glue inside the cavernous sinus between V1 and V2 space. It stops the bleeding there, and we continue a dissection posteriorly. We see the V3, and around 5 to 6 millimeter behind V3, it is very easy to find the GSP, and as described by Professor Roten, we see the petrous apex coming into our view. We see the V3, the free edge of the petrous, the GSP and below, and posteriorly we have the arcuate eminence. This is the Michel's impression. So this is the petrous apex we are talking about, and the triangle, the IM and the line of the cochlea. We start drilling in this area, and the petrosectomy can be expanded both anteriorly as well as posteriorly when you have such wide exposure. The remnant of the interpetrous is removed. So we have the posterior cranial fossa, middle cranial fossa, and we have the superior petrosal sinus in between. So by division of the superior petrosal sinus, we can combine the posterior as well as the middle cranial fossa. As you see here, the fifth cranial nerve. We can see the fourth cranial nerve. The dura is opened horizontally at the base. The idea is to have the exposure of the target area only, while at the same time protecting the brain. So this is the kind of exposure we get right from the second cranial nerve right up to the seventh cranial nerve. And this kind of wide exposure is helpful in extensive pathologies in this area. So far I have done around 12 such cases over the last 2 years, and most of these cases have been petroclavial meningiomas or trigeminal schwannomas. Results have been mostly satisfactory. Sometimes these patients would develop CSF leak and transient cranial nerve paresis. I'll show you one more case, a case of right-sided petroclavial meningioma with both middle and posterior fossa extension. We did the same approach. The steps are more or less standardized in our institute so that if anybody has to join in the middle, he knows exactly what to do. The optic nerve area is open to let out some CSF. This allows the dural peeling to go smoothly. As we go posteriorly, we see that Michel's cave is full of tumor. The tumor had eroded the petrous partially, but we needed to drill the petrous more. The tent is cut open to join the two cavities. We see the tumor now. The tumor is debulked to an extent. Now we see the tentorium. Now we realize that we have to extend the petrosectomy. And as you see, once this petrosectomy was extended posteriorly, the exposure opened up quite a bit. We can see the fourth cranial nerve. And the tumor had actually extended inside the Michel's cave. So we had to open the dura over the Michel's cave and take this tumor out from there. We have seen that petroclavial meningiomas do have extension into this area, and it needs to be cleared if you want to have a gross total tumor resection. The fifth cranial nerve is seen draped over the tumor. And by careful dissection, the fifth nerve is set free. And this tumor is sharply divided. Now we focus our attention on the upper pole. You see the third cranial nerve and the posterior cerebral artery. They have been lifted superiorly by the tumor. So we need to dissect this area, and the adhesions were sharply divided. And using a traction counter traction method, this tumor is mobilized into the center. We can see the brainstem, the fourth cranial nerve. The fourth cranial nerve has been elongated by the tumor, the mass effect of the tumor, but it could be preserved still. The key is to protect the arachnoid around it and work on either side, avoiding stretch on the nerve. So by combination of decompression and debulking, which is necessary in very large tumors, we were able to visualize the brainstem. We saw an area of adhesion over there, which was left till the last. And as you see, we can see that the basilar artery and the posterocerebral artery and the basilar artery perforators here, they were compressed by the tumor, but those could be preserved. And this is the final picture. We can see the vertebrovascular and then the PCAs, and the dural defect was plugged with fat. Postoperatively, the patient did have some transient deficit, but improved in 3 months. We can see the tumor has been completely resected. So there are several advantages, like I've said, wide exposure. Distributed temporal lobe retraction is what I want to emphasize. It has multiple CSF release options, like we have shown, and this is very important in the extradural phase. And corridor expansion is another advantage, which I'll show you here. This is a case of acromegaly with cavernous sinus extension, previously operated endonasally. There was some tumor in the cavernous sinus, so we decided to go for this approach. The steps are pretty much standard, as I've shown in the previous videos. What I want to show you here is another advantage of having an extended pittress exposure. In this patient, we decided to have a pittress IC control. For that, we needed to divide the GSPN because we know the right beneath the GSPN is where the pittress carotid is. Sometimes this bone may be dehiscent, but in this patient, it was not. So this area was expanded. We can see the pittress carotid. Now, this kind of pittress carotid control may be handy, particularly in patients who have undergone a previous surgery. And if there was some previous arterial bleeding, then you should have some kind of proximal arterial control. Once we established that control, we went into the cavernous sinus. We can see the 4th cranial nerve. We can see the 5th cranial nerve, which was draped on the tumor. Using a sharp dissection around these cranial nerves, the corridors are expanded, and it allows us to go inside the cavernous sinus and take the tumor out from there. It completes the extradural part of the surgery. As the preoperative scan showed, there was some amount of tumor which was going inside the dura. So the dura is open like this, vertical incision on the sylvian fissure. Then we go horizontally on either side. We open the distal dural ring, and as the optic nerve has already been deroofed, it allows carotid optic space expansion. So with this extended exposure, we can take out the intradural tumor as well. We can see the fat of previous surgery. So we decided at this point that tumor resection was satisfactory from our point of view, and we closed it down there. So there could be several problems, like I've said, temporal lobe contusion, which can be lessened by the CSF release technique that we use. Venous infarction can be a deadly complication. Cranial nerve dysfunction generally improves with time. CSF leak should be anticipated and managed appropriately. So to sum up, this approach, although a time-tested and old one, needs a renewed focus at this point of time. It provides wide exposure with multi-angle visualization, and it is more brainly. And this is exactly what a skull-base surgery should be. It should be brain-friendly. And as I've showed you, it additionally allows better neurovascular mobilization, and it gives you more control on the pathology. Thank you.
Any questions, please?
Yeah.
Kuntal, very beautiful presentation. We loved your videos. Million petrochloromeningium large you showed. So I saw that you releasing the CSF before you open the dura. So do you practice of releasing the CSF from lumbar drain or something in the pre-op? Because I think you have to go quite behind. So if the brain is full. So is it easy to release the CSF the way you showed, or we need to use a lumbar drainage of CSF?
Thank you, Shiv Shankar. That is a very nice question. I've been asked this before as well. See, we have to realize that in the extradural phase, we need to have a lax brain. Otherwise, the temporal lobe can undergo contusion. So we have to consider what are the options for CSF release. Certain options are in the brain, some options are in the spine, like you have said. You have to see the preoperative radiology. If you see that the bulk of the tumor is located posteriorly, and you expect to have a relatively free area around the optic nerve and the carotid, we use this technique. Sometimes this tumor will be located more anteriorly. So in that situation, we'll peel it behind and release CSF from the Michel's cave. That is option number 2. Third option, if the lesion is more central, not much lateral, you can have a small incision over the sylvian fissure right on the dura, and you can release some CSF. If you think that none of these things are going to work in a very extensive tumor, only in these situations we'll go for a preoperative lumbar drain. In our practice, we do not require this. we are able to drain CSF from either of these techniques. And sometimes you're lucky that the patient also has a hydrocephalus. In this situation, all you have to do is tap the ventricle. But the point that I want to highlight is do relax the brain before you conduct this extensive extradural work. Otherwise, we have seen that the patients have postoperative temporal lobe contusion. Particularly on the left side, it can have consequences. Yeah. I think only in one patient so far have been lucky. Sometimes this infarction would not manifest clinically, but you see in the postoperative scans. But on the left side, it can be troublesome. So we emphasize that the brain should be lax. You should do sharp dissection, and you should avoid coagulation in that area. You can use gel form to stop the bleeding. At least some venous patency would be maintained.
One comment, would you like to change your craniotomy location or anything? Do you make any adjustments compared to a conventional thing we do for Petrus?
Sir, we generally do a frontotemporal incision. It depends on where the epicenter of the lesion is. If the lesion is more temporal and I need to access the sylvian fissure only, so my craniotomy would be temporal dominant frontotemporal. On the other hand, if the pathology is such that it is having extension into the anterocranial fossa, it would be more of a frontal with less temporal. So it is frontotemporal. Anterior and posterior extensions would depend on the epicenter of the pathology.
Thank you so much.
Thank
That
you,
was wonderful.
Thank you.
Can I have the next speaker, please?
Next talk is by Dr. Arun Srivastav, who unfortunately could not be here. So Dr. Kuntal himself would be presenting his recorded talk.
Actually, Dr. Arun has given a recorded presentation. So do you have some audio enhancer here? I can just play that. Can you put it here? So he has given his presentation and recorded form. I can take questions if you want. Then.
The advantages of introlateral approach.
It's not coming. Yes. Practice that. Yeah, it's better. Done. Yes. So we just do the zygoma lowering. We don't do orbitozygomatic anymore. So what we do is we reshape this zygoma here. We will drill it, make it thin, and we'll reflect the temporalis muscle depending on where we want to go. Suppose I want to go towards the petrous apex. So I'll push the temporalis muscle down anteriorly, right? And if I have to go for say paraclinoid aneurysm or maybe planum sphenoidal area where I need to look anteriorly, I'll pull the muscle down posteriorly. So we'll just reshape the zygoma, and yeah, we can take out, but we generally leave it because if you take it out, you have to reattach it again, and sometimes it can have cosmetic problems. And we have seen that with good brain relaxation by drainage of CSF and having a wider exposure, utilizing various crevices, you can still do your job. And I don't think we have done any orbitozygomatic in the last 5-7 years, not even zygotomy.
Yeah, I just wanted to make a comment. The congratulations on that work. It's terrific. And I think it was beautifully shown in that video, lifting up the lateral wall of the cavernous sinus. You were able to preserve the sphenoparietal sinus. I think that there's a trend. We did a study, actually, it was published a few years ago with a number of senior surgeons. And the more senior the surgeon, the more they're worried about veins. The young surgeons are all worried about the arteries. The senior surgeons are all worried about the veins because we've all lived with the complications. And Kawase showed me a case because, he obviously developed the anterior transpetrosal approach for aneurysms originally of the basilar artery.
Yes.
That was, but he showed me a case, a dreadful case. And one variant you can have of venous drainage. So if you come in subtemporally and epidurally, like in an anterior transpetrosal approach, there's a venous channel that can go on, a big one that can go down through foramen ovale. And if you embarrass that drainage, sometimes you can end up with a temporal lobe hematoma. He showed me a dreadful case that died from that. So that's one thing to be considerate of. And you can look at it on the MR studies and see if there's a large vein right there. Thank you.
Thank you, sir.
Thank you, Doctor. Our next speaker is Dr. R.N. Sahu, who is serving as the head of the Department of Neurology at prestigious institutions such as SCB Medical College and Hospital and VSS Medical College, Burla. Dr. Sahu played a pivotal role in shaping the academic and clinical landscape of neurology. So I invite him to speak on management of functioning pituitary edema AIMS Bhubaneswar experience. Please join us, sir.
Thank you for your kind words.
At the outset, I want to thank Dr. Raib Cherian and Debu for calling me. Okay. Okay. So we have a short experience of management of functioning pituitary adenomas in our institute. And there is no conflict of interest in class, and all the patients' video are consent taken for the clinical photographs. So to start with the functioning pituitary adenomas, it constitutes around 7 to 8% of all brain tumors. Around in our city also it's same. And most of the cases, the diagnostic is clinical, based on the lab finding and imaging modalities. And the medical management starts with most of the cases they attend endocrinology OPD. And the goal of the surgical treatment is an endocrinological cure or biochemical cure and relief of the symptoms. And we had around 83 cases operated for last 3 years, and amongst which the functional pituitary adenomas consist of around 17 cases, and which includes around GH, prolactin homage, and Cushing syndromes. And coming to the GH secreting pituitary adenomas, mostly the patients present with features of acromegaly features, and we measure mostly the IGF level is the prime investigations to diagnose those cases. And as you know, serum GH is non-specific. And some studies shows that even in patients who have acromegaly features or acral features, one is to go for a screening of IGF-1, which also we do. And there is a debate whether GH adenoma screening is required or not. And it is always recommended to measure the IGF-1 in patients with features of acromegaly, especially those with acral and facial features. And even more than that, they recommend also to measure the IGF-1 in patients without features of acromegaly, especially those who have obstructive sleep apneas and type 2 diabetes mellitus, which is very resistant to diabetes mellitus, and or patients even with some soft features of acropathy with carpal tunnel syndrome and other hypertensions. So from the symptoms, most of the cases we find headache is one of the most common symptoms, where around 100% patients that they do attend neurosurgical OPD with headache. And acromegaly is a feature in our setup around 86% cases, and most of the patients are also diabetic to start with. And we have also operated 2 cases of GH adenoma without acromegaly, and with non-specific headache and headache with vision loss in 1 cases. And we find also 2 patients with lactose-ameliotrope adenomas present with galactorrhea as a first symptom. So as I've told already, the patients, a few of the case example we have shown. Mostly, this is a case of a 45-year-old female who presented with vision loss, headache, and features of acromegaly. And on investigation, the IGH-1 is a little higher, 350 units, and which corrected. So the goal of the surgery is to remove the tumor as far as practicable, going to lateral. And these are very easy in cases of it's a large tumor, and or there is no extension to paracellular areas. And we always employ endoscopic two-hand techniques for removing this type of tumors. And going to every corner of the area, we have to explore the cavernous sinus laterally so that any functional tumor is not left out. We also go to the mostly the lateral cavernous sinus exposure is important in many cases to get into the tumor on lateral aspects. And then at the end of the surgery, a complete radiological clearance is important. When there is a residual left, one has to go for redo surgery also again. So these are the patients who have follow up how much the acromegaly features they improve. Usually because the economical features, which is both the static and dynamic components, and because of the fluid retention, most of the patients do have some features of discomfort and all these things, and they over a time, up to some extent, they improve also. So coming to the another variety of functional pituitary adenoma is Cushing's disease, and these are also specific type of pituitary tumor where the clinical features is most important because of the ACTH or cortisol hypersecretion. They present with classical symptoms of central obesity and all features of Cushing's syndrome. And in a few cases, those who have their diagnosis doubt, we do dexamethasone suppression test and dynamic contrast image MRI. And these are most of the cases done by the endocrinologist people. And especially in cases of small Cushing's disease, Cushing's adenomas, where during surgery, near navigation is important because these are not enlarged cellular and the pituitary gland is small in comparison to the big tumors in other cases. And there are also issues with poor inhaling and wound healing because of the high hormonal status, and chances of CSF leak somehow is higher in our cases because they are small adenomas sometimes. And this one case with a young 15-year-old boy who presented with progressive weight gain since 4 years, with a diabetic for the last 1 year, and all classical features of Cushing's disease. This is a small pituitary adenoma, and we took time to diagnose where the pituitary, localize the pituitary adenoma in the MRI. We did a contrast dynamic MRI, and then come to the conclusion it's having a pituitary adenoma. And the ACTH also was higher. And you can see the post-op and pre-op image following that the stria is improved and all the features of the Cushing and disease is gone. The patient had some complication during surgery because it's a small adenoma, and it developed CSF leaks 3 times because the fat, every time we put the fat and glue, these are not picking up with the things. And we repeatedly, at some point of time, we mobilized bilateral mucosal flap from both sides of the nostrils to have an overlap on the wound. And after a continuous LP drainage of more than 10 days, fortunately patient healed to the things. We did all types of repair within cartilage and everything. And ultimately, the patient did well at the end of 1 month. So these are sometimes difficult, although tumor is very small, but because of the wound healing problem, sometimes the CSF leak is a complications in cases. We have other cases also with Cushing syndrome. They also improve over time. They are most of the cases of Cushing syndrome we are we have done so far is small adenomas, and this is one case we did also navigation guided disease. You can see the on cutting is because the pituitary area is not large. As soon as you cut the tumor guided by navigation, you find the tumor. And more important is to leave the normal pituitary intact in those cases because patient will land in the hypopituitarism cases. So now coming to the next variety of functional pituitary adenomas is prolactinomas. Most of the cases, fortunately, are treated in these type tumors are with conjunctive treatment with carbaglin. But some cases where even carbaglin fails or there is involvement of optic apparatus and the endocrinologist is sent to us for surgery, we treat those patients with surgery. And this is one case where a 27-year-old man presented with prolactinoma, and he started on carbaglin, but after 1 month of starting, he developed visual blurring on 6 weeks of post-operative period. And the tumor was still large. We have gone, we did the surgery there, and then removed the tumor. It was a little more fibrotic because of the medical treatment. And somehow we could achieve whatever the tumor was there, we can remove it. And we went to the lateral area, also cleared the lateral sides and put the pattern and close the tumor. And the patient had third of paresis beforehand, and which in subsequently over a period of time, he improved of the cardinal palsy. So some cases, of course, it is not possible to remove all the tumors, and some cases have some residual tumor left. And we constitute a tumor board in most cases. We attend the tumor board with the medical radiation oncologist, and we also try to deal with the residual tumor over a SRS system. So to conclude, most of the functional pituitary adenomas are diagnosed clinically, and biochemical lab confirmation is essential for things. And patients of GS secretory adenoma with acral features sometimes needs to be screened, especially if the patient have OSA or severe type 2 diabetes with IGF-1. And of course, the fast surgery gives a fast best cure with experienced hands. With experience, we can gain more better tumor clearance. Of course, radiation surgery is helpful in residual or recurrent cases. Thank you for your time.
That was an excellent overview. We'll open it up for questions. We have time for 1 or 2 questions.
So what is your strategy of tumors that have cavernous cells not being used during first? Do you radiation straight away?
Sometimes if it's lateral to the carotid, we go transcranially also. Transcavernous approach we also do. But if it is very small tumor, and we know that it's around that there is no ophthalmic paresis, other things are there. And sometimes many times the patient do not prefer second surgery. That is another thing. In those cases, we offer them a SRS. And SRS also, it's important for the neurosurgeons to go to the planning room actually. Most of the centers, they do not allow. But fortunately, our centers, we go to the planning room and make the tumor connotations there in the planning room. We told them to attack those areas with SRS, which we know that it's difficult to surgically to achieve those things. Sometimes they also tell on a tumor board discussion, they told that it's more close to optic knob. In those cases, we go extraorally, remove the tumors nearby the optic knob so that the things are easier for them to put radiotherapy on the other side. So it is important, it's a teamwork. Once it go to their domain in the TPR system, to which area they can easily do and which area we can do easily during surgery. It's a planning process one needs to do. So all cases has to be individualized on the assessment.
Thank you very much. I think we'll move on with our next speaker.
As we are gathered in here in the conference, in the theme of neurosurgery of tomorrow, which includes new techniques, panel discussions, artificial intelligence, designs, and developments.
Now I'd like to call upon Dr. Ramesh Sigala, the MS, MCH in Neurosurgery, who currently works at the Department of Neurosurgery and Institute of Neuro and Cardiac Sciences, Vijayawada, India. And we would like to talk on the topic, the design and development of the cost-effective transnasal skull-base bone wax applicator.
Good morning, respected chairpersons, dear friends. Just small talk on a small device which I made it around a couple of years back, looking like it could be of some help in deep-seated skull-base approaches where your conventional instruments will have a little bit of difficulty in applying the bone wax. Whenever you have a bony bleeding, usually we used to use the bone wax to apply. If they are on the superficial area, it is easy to apply with a hand or some other instruments. But when it is in the deep-seated, either use a kind of bayonet forceps or some dissector to apply the bone wax onto the tip and go deep into apply on the bleeding surfaces. In few cases, you can control the bleeding with the help of a monopolar cautery also, but at times it will be difficult even to control with the monopolar cautery. When it comes to the skull base, the surface will be the flat and your instruments may not able to reach properly onto the surface. I thought that this small tool can be of little help in applying the bone wax effectively. Okay, so this is basically like a trocar cannula kind of system where you can load the bone wax onto this cannula like this. I made it on two different sizes, like one like applying tip will be either 0 degree or some kind of degrees like 30, 40, 45. Depending upon the requirement, you can able to customize this one. This is all in the R&D only initially. So we had the two needles. One was like a 0 degree tip and another was a 30 degrees tip, so that in even the slant bleeding surface also, you can use this tip to apply the bone wax effectively onto that surface. So suppose you take a small block of the bone wax, use the cannula to fill the bone wax into that cannulus, and you can use this piston mechanism to apply the trocar on that. Once it is there, and you can go on to the dot on the bleeding surface of the bone. You can just like an injection, you can inject onto the surface and able to rub over the surface. I'll just show a small video clip of this. So this is how you can take the needle on dot onto the spot of the bleeder and you can able to apply that one. So this was a recurrent pituitary which I operated a couple of years back. So there was a bleeding surface there. You can see my needle, it is around 3 mm in diameter. It will not block most of your operating area. You take the needle loaded with the bone wax and use just like a syringe mechanism just to push, just like what you push the like surgifoam or other hemostatic agents. You can push the bone wax onto the dot on the surface, and you can able to use the same trocar cannula system to complete the hemostasis process over that surface area. It's a simple tool, but effective in few cases, like where you have a difficulty in applying the bone wax. And not only the skull base, you can use the same tool even for the minimal access spine surgeries also, where you are using a tubular system you can reduce the operating cluttering of the instruments through the operating area through the small tube, and you can apply the same needle bone wax and you can able to hemostasize the bleeding bone or using this kind of needle. So this was recently published in Neurology India last edition. If you have any questions, I am happy to answer for that. Thank you, sir.
Very clever. I thought that's a great innovation. Congratulations.
So this is to show that innovations need not be bombastic, but if they can save you from crisis, I think they're more important. Excellent.
We are in the process actually. Initially, I made it from one local vendor, but now we are trying to do it in a systematic way. One or two instruments which I designed, I'm in the process of making them available commercially.
Put a name already on it?
Pardon?
Have you put a name already on it?
No, it was not patented, but there's no such instrument available in the market as of now. So it's already published, so there's no question of patenting, but you can market it that. So going through some vendors, some company in Bangalore gave me all those like drawings, everything. We can able to customize angulation and everything. And length also we can able to customize. There's nothing like that. Diameter, length, everything is open now to customize depending upon the need of the surgeon, who is using that one. For spine people, you can reduce the length. For the skull base, you can increase the length. Diameters also can be changed. Angulations also can be changed. But most practical will be 0 degree and 30 to 45 will be fine because there will be slanting surface. You can take dot onto that and they apply the bone wax with a very controlled manner and able to rub with the same hard needle, because many a times you use a bayonet forces with the cotton tip and try to rub it. But while rubbing that one, you need a lot of space will be occupying through a small area. So this is hardly 3 mm needle, so it won't take much of your operating space also. It's easy to take in. And if you want, you can make it angulations also. That's not a big problem actually.
Sir, is it possible to also touch a monofiller on top of that?
It's not.
If that area is needed, the bone wax applies it pretty well.
Yeah, yeah, you can do, but commercially there are suction bone polar, like monopolar tips are available. Many a times it is a small bleeding, you can able to control with the help of just a monopolar cautery. But if it is a little high pressure or because of the position of whatever it is, if it is bleeding because of the vascularity of the tumor, that time it doesn't control even with the monopolar coagulation. Then it will be a very useful because you can directly inject onto the bleeding bone there, so it doesn't matter.
So, sir, what I'm saying, use the same thing.
Yeah.
Just put monopolar on the outside. That area will be heated up. For it, try that even.
Because you load the trocar cannula, if you apply monopolar current, the wax will die, wax may get melted and it doesn't serve the purpose. So you have to have a simple thing.
So there is a skull-based instrument that we developed many years ago, Taka Fukushima and I. It's we call the THD, touch here dummy, because you get your assistant to touch the end. It's a long probe with a tip, and it's designed to cauterize the bone because it works very well, as you know. And sometimes you don't have those bendable tips and long bipolar. So it's a separate instrument, and it has a little spring tip. So when your assistant touches it, it doesn't move your hand. So
Thanks.
Thank you, sir. So our next speaker is Dr. Surat Munasinghe, who is a consultant neurosurgeon, head of the department, Teaching Hospital, Ratnapur, Sri Lanka. He is also the secretary of Neurosurgical Association, Sri Lanka. Now, I would like to invite him to speak on avoidance of complication in skull-based surgery under difficult circumstances, strategies for better outcome.
Good morning, dear chairpersons and dear friends. Again, thank you very much for the invitation, especially to Prof. Apcharian and the other organizers. So the content of my speech is a little bit different. So I'm from Sri Lanka. So I'll be talking on how to avoid complications and in skull-based surgery under difficult circumstances, and mainly the strategies for better outcome. I'm a neurosurgeon who has been working under so many difficult circumstances and very limited resources. So, for example, this is where I worked 7 years back, the entire eastern province of Sri Lanka. Nobody wanted to go there. So even though it's a so-called neurosurgical unit, there is no separate ward, neurosurgical ward, patients were everywhere. And only we had a fossilized CT scan, no MRI, and most of the instruments were not available. So wherever you work, whatever you do, under which circumstances, I think to become a better neurosurgeon, whether you do skull-based, vascular, generals, I think you need to have all this. You need to have a strong and clear mindset with good composure. I think it's the most important thing. And a decision-making capacity, especially understanding the circumstances. You understand the philosophy and the pathological basis of the condition, and then the technical skills and your knowledge, and then the technology comes. Technology is to make your life easier for a safe and better surgery, better patient outcome. So wherever you work, I think we all have a common goal, which is safe surgery towards a better outcome. So in the next few minutes, I will show you what I have learned and how I have tackled all these difficulties with few examples. So wherever you do, wherever you work, whatever you do, adhere to the principles. So correct techniques, positioning techniques, marking the incision. So I usually go with the craniometric points because I don't have the navigators, an adequate exposure, drilling the bridge clinoidectomy. I used to work without retractors, but because I did not have the retractors initially. So always targeting for a relaxed brain and master the sharp dissection techniques always, and learn to innovate when necessary, and gradually learn when to stop and when not to operate. So these are few examples, as I told you. So we did not have MRI scan in my hospital, teaching hospital, Batiklo. This is what happened. So this is a patient with olfactory groove meningioma presented with a small tumor. We sent this patient for MRI, and the patient did not turn up, and she presented with this huge tumor with a GCS of 3, and she died. So there onwards, I decided not to send these patients for MRI because these patients, most of the time, they don't want to go 200 kilometers to a different center and they get the MRI scan and come back. So this is what I did. I operated without the MRI scan. So I did all these surgeries without the MRI, just with the CTs. So see, large olfactory groove meningiomas, these type of tumors, without the MRI scan. So, and the outcome was very good. So you can see again the contrast CT, the immediate post-op scans of these patients. And these were the patients who were presenting with a low GCS, with large tumors. So we did not have time to go for MRI. So this is not very far, not very long ago. This is 3-4 years back. This is in my current station. So I had no option operating these tumors without an MRI. So this is a 74-year bedridden lady for 2 years due to unsteady gait. You can see this large posterior fossa tumor. So nobody wanted to take a CT at least and to operate. So we operated this patient. See this cavernous sinus meningioma on the left side. This is the only image I had. She's a 40-year-old woman who did not have 15 Indian rupees to come to the hospital. A day worker laborer with widowed, 8 children. So this is how she presented. She was losing vision. And this is immediate post-op. I don't have a post-op scan because the CT machine was out of order. So this is 3 years after, 3 years later. So I think even though I don't have the scans, the clinical picture speaks out what it is. So how do you operate without MRI? So convert the 3D anatomy in your mind into a physical reality with your mindset from the beginning, where you anticipate the worst and the most difficult challenges. So you need a lot of tolerance, anticipation, and patience, and act smart. So this is recent. So this is a young lady presenting with gradual loss of vision and third nerve palsy. So this is a medial sphenoid wing meningioma engulfing the great vessels. And this is the post-op. 48 hours post-op contrast CT. So she had no deficit. So all these cases were done without the navigators, without the CUSA, without the intraoperative ultrasound, nothing else, only the fine scissor and the bipolar. So another case, a large sphenoid wing meningioma engulfing the blood vessels. So it's a very firm tumor. So I have to be very patient. You can see the carotid artery there. And so fast forwarded video in the interest of time. So you can see the anterior cerebral and the middle cerebral artery, and then the total gross total excision of the tumor was done. And this is the post-op contrast CT at 48 hours. She presented with loss of vision and third nerve palsy. And this is her immediate post-op, and her third nerve palsy gradually improved 6 weeks post-op. Another case, recurrent medial sphenoid wing meningioma operated twice in a 76-year-old female. It was a very, very firm tumor and complete resection was not possible. So a sliver of tumor was left in situ, which was firmly attached to MCA branches. So I knew my the limitations. So I work according to that. So the interesting case I'll show you is a 78-year-old lady with renal impairment and multiple drug allergies and refractory epilepsy and headache. So nobody wanted to give her contrast to carry out a contrast CT or an MRI scan. And she had so multiple drug allergies and severe renal impairment. So this is the non-contrast CT. You can see it's a calcified lesion. So, and she was in status and in severe headache. So I decided to operate her with this image. You can see the tumor. So what I wanted is to go through a very minimally invasive method. So through a supraorbital eyebrow incision, I tried to remove the tumor. So a little bit firm tumor. So gradually the tumor was separated from the optic nerve and the anterior cerebral vessels. And this is what we found at the base of the tumor. This is a ACOM aneurysm. It's a large aneurysm. So it was a surprise. And this is the patient, this is the post-op. So if you take the challenges, you should be able to deal with that as well. So you can see here. So she had this hypodensity. So most probably she must have had an aneurysm rupture at that time, even though she didn't give anything, any important history. So anyway, so the outcome was good. Right. So another case, see this 67 years recurrent tumor operated through the intranasal route. Light perception is intact, a large pituitary tumor. So I operated through the interhemispheric approach because I thought the optic nerves is the key here. So rather than damaging the optic nerves, so rather than going through the terional approach, you can see the optic nerves are paper thin. I wanted to have a panoramic view, so I went through the interhemispheric approach in this case, and I was able to preserve, at least anatomically, the paper thin optic nerves. In the interest of time, I will skip. So all the important vessels were preserved, and this is the post-op scan. Aneurysm surgery. So this is the quality of the aneurysm CT angiogram we get. So it was it's a large ACOM directed anterosuperiorly. So I had doubts. I always had doubts with all these angiograms. Unfortunately, so this was done through the interhemispheric approach because I needed a good view from the above rather than going through the lateral corridor. See the pituitary tumors, I go through transcranial route, but with this mini terional approach. So always the amount of exposure, the exposure does not equate to the size of the craniotomy. Basilative aneurysm, see, operated through this mini terional approach. So you do a clinoidectomy and you get a very beautiful picture. Right. So this is another interesting case. I will just go through this. So this is a patient presented with polycystic kidney disease and vascular malformation with repeated bleeding and refractory epilepsy. This patient had severe renal impairment and my anesthetist did not want to anesthetize him. So I did this case with sedation, with a very small incision. So I don't have a navigator or any other instrument. So this is what I did. You can see it's a very small incision. I wanted to go through that, the sulcus. So it was all through these craniometric points. So I was able to localize the tumor with going through that sulcus and took it out. So that was the lesion, and this is the pre-op. You can see this is the post-op. It was a very small incision. So you can see this patient was discharged thereafter. Cystostomy. So this is a tribute to Dr. Aibcherian. So I'm going to finish. This is the last few days. So this is an 18-year-old lady presented with GCS of 3. This is the inspiration for me to go to continue with cystostomy. This is what we did. Right. So initially, I did not believe Professor Aibcherian, so I did not put the bone flap back. But now I have 100% confidence in him. So we could put back the bone flap on day 24. So she was presented with a GCS of 3, and she discharged on day 26. So then we did so many cranioplasties, so many cystostomies. You can see the bone flap was put back. So more than 200 cases over the last 4 years, and marked reduction in number of cranioplasties, 27. Cranioplasty titanium mesh is very expensive in my country, $300 US. So that's why I started doing cystostomy in order to avoid cranioplasties. But nowadays, my intention is not that. Right. So I will stop. Thick SH with low GCS. These type of patients, they die very quickly, even before the CT angiogram in my setup. So what we do a a left-sided dominant side decompressive craniectomy and then do the aneurysm clipping. Another case, this is the angiogram we get. You see, it's normal. In this patient, you understand it cannot be normal. So this patient deteriorated and I operated even without a CT angiogram in this case, and there was an aneurysm. So this is the type of, situation that we face most of the time. So that is how we work, and that is how we tackle all these, difficulties. So it's not easy to work under these type of circumstances, right? And to achieve good. So I will stop here. Take home message: lack of cutting edge technological experience does not always equate to poor outcome. So the important thing is performing the safest surgery to achieve the best outcome for each and every individual, using whatever available resources at the most appropriate time through the most simplistic and uncomplicated procedure. So understanding the circumstances is always very important. Thank you.
It's really challenging to work under low resource situations. So as we rightly summarized, it's important to choose what is appropriate, what is not what is most challenging. So this is wisdom. So that was excellent. Thank you. I think we'll go on to the next speaker. Thank you.
Now I would like to invite our next speaker, Dr. Karthik.
We can instead of not replacing the bone, we can sometimes leave the bone flap free riding, but the concept is always to keep the bone back.
So doctor, congratulations on doing all those surgeries in very resource limited settings. But I'm quite surprised that even though the settings didn't have MRI, you have got a good microscope to perform surgeries. And how was that possible for you to manage?
The cases I showed you without the MRI was 7 years back when I worked in Batiklo in the Eastern Province. Now I'm working in Ratnapura. So we do have the microscope. That was also with a lot of effort, with a lot of fight, I got the microscope. The initial microscope, I didn't have the recording facility, so that's why I don't have the recordings there. Now I do have the microscope. Now we do have the MRI. It's after a lot of fight and a lot of struggle. Thank you.
I would like to invite our next speaker, Dr. Karthikeyan Paraninadan, who is a consultant at JKNM Hospital, Coimbatore. He's going to speak on the topic facial nerve reanimation techniques.
Good morning, one and all. My topic is about facial nerve reanimation. A small brief about me that I did 1 year fellowship under Professor Sana in Italy, where they do more of lateral skull based work. So going on to the topic, facial nerve in lateral skull base is a very important nerve. And much of the approaches are designed around the facial nerve, and also in that most of the tumors in the CP angle and lateral skull base are benign tumors. So we have to strike a balance between appropriate disease removal and preserving the function as well. So an adequate knowledge of all the rehabilitation techniques of the facial nerve, and if there is in some cases, if the nerve is completely transected, we have to do reanimation nerve transfer techniques and all. So what are the reanimation techniques we know? Wherever possible, we have to preserve the native nerve. Like an end-to-end anastomosis, if a short segment of the facial nerve is involved, it is better to do a direct end-to-end anastomosis. Or if there is a section of the nerve which is involved and considerable portion of the nerve has to be sectioned because of the disease infiltration or involvement, we can go for a cable graft or a graft interposition. The most common nerve which is used is the sural nerve because it is ideal in caliber and it helps for proper approximation. And also in skull-based tumors, while operating, one surgeon has to operate in the main field for 6 to 7 hours, and so that the other person, assistant surgeon, can take the nerve. It will be easier. The greater auricular nerve also can be used, and if in case the proximal, and it is important to get the proximal and distal stump also, so that proper approximation can be done. If there is inavailability of a proximal and distal stump due to the bigger size of the tumor or considerable infiltration, then we may have to consider either a facial nerve hypoglossal anastomosis or a facial nerve trigeminal nerve anastomosis, particularly the mesenteric branch, which we will discuss in detail. So this is in one case of a petrous bone cholesteatoma, where after complete removal of the cholesteatoma, this was operated by my professor in my center. After removal, you see in the internal aortic canal, the proximal stump is being delineated, and this is the sural nerve graft which is being kept. A considerable length of the graft is better, so that there is a tension-free anastomosis. So this is the proximal and the distal stump which is being approximated. So you can, if possible, you can use a nylon, or in many cases in these small crevices, it is difficult to suture. So we can put a temporalis fascia graft to approximate the graft segments. And finally, fibrin glue is applied. So this is in a case of glomus jugulare. In my series of 6 cases, most of the time you can preserve the facial nerve because there is not much of infiltration, and it's considering the benign nature of the tumor. So in one of the patients, I have to section the nerve, a small segment. This is a large size 3 by 2.5 by 2.5 centimeter size of the tumor in the jugular fossa. So this is the facial nerve which is being delineated. There you can see considerable infiltration of this nerve. What I did was to, since he's a young patient around 25 years old, I had to preserve as much as possible the native nerve. So I sectioned, delineated a portion of the perineurium, epineurium, sorry. One second, sorry. This is the epineurium being stripped off. And this portion of the nerve I had to remove because it's considerably infiltrated. So I took the extra length from the intraparotid segment. So I could mobilize the nerve. This is the parotid cuff of tissue. And this is the distal segment and the proximal segment. This is the proximal segment kept under the bed over the tensor fascia lata. Sorry, this temporalis fascia. This is adequate after approximation. the temporalis fascia is being placed in position, and we can apply a fibrillar glue for securing it in position. So this is the patient in the 5 weeks post-op. Sorry, I don't know something. 5 days post-op. Sorry, it's a bit delaying. 1 second. Can you see this one? That's video. It's not responding. Yes, sir. I'll just open and.
I'm sorry. वीडियो स्किप करें तो
Video I'll put in.
खाली वीडियो पे वहां से प्ले कर
Let it come on this one. I'm sorry for the delay. This is 5 days post-op. Almost a grade 5 palsy is there. He was operated 3 years back and he continues to remain in follow-up. Now his voice is compensated and he's doing well. And now we could achieve this almost complete eye closure. There is some amount of like the fibers which are a little bit affected. So only the opposite side, the smile is affected. Otherwise, his eye closure is good. So after 3 years of follow-up, he continues to be disease-free and there is a complete resection of the tumor. So now we go on to certain specific case scenarios where we encounter the facial nerve and particular areas where we can do a re-anastomosis. This is in the case of translabyrinthine approach, which is mainly used for vestibular schwannoma. Most often we encounter the facial nerve being either thinned or sometimes with the tumor being very much pushed to the posterior side. In those cases, it may be difficult to preserve the facial nerve. So either while removing the disease process, it gets sectioned off, or for removing the for the thinned out nerve to survive, it will be difficult. So in those here, in one case, the facial nerve is sectioned, and this is the proximal stump, and this is the distal stump in the internal artery canal. So a sural nerve is grafted, taken as a graft, and the facial nerve in the CP angle is the graft is placed, and temporalis fascia is being wrapped around, and this is in the internal artery canal where there's adequate approximation close to the at the level of the internal artery canal. So more often than not, while skeletonizing the facial nerve in the internal artery canal, there are chances that we might injure the facial nerve as such, which has happened in this case. While the surgeons going in search of the facial nerve, the Pillsbury has gone more laterally to injure the facial nerve in the fundus itself. So in that case, the distal stump was sectioned off, and interposition graft was applied and wrapped with the. This is the graft in place between the sections of the facial nerve, and temporalis fascia being applied. The graft apposition can either be done by 9-0 nylon or wrapping around with the fascia. Both of them yield equal results through studies. And this is a case of transcochlear approach, where in the case of facial nerve neuroma, you can see the facial nerve being skeletonized, and the facial nerve, the neuroma is quite deeper inside the internal auditory canal. This is the cochlea, and this is the internal auditory canal. Since the neuroma is very much deeper, we have to take control of the internal carotid artery. This is a transcochlear approach. So there is a sectioning of the facial nerve here, and the neuroma lies deep inside. So this is the proximal segment, and this is the distal segment where the neuroma is sectioned off. This is the neuroma, it is sectioned off, and interposition graft is applied. So now going on to the reanimation techniques with the dual nerve transfer, we can do either hypoglossal anastomosis or a mesenteric nerve anastomosis. Because hypoglossal nerve is a cranial nerve that it interferes with the functions of the tongue as well as atrophy. So more often
You may have to hurry up a bit, please.
Yes, yes, sir. This is anastomosis between the proximal segment of the facial nerve and the hypoglossal nerve, which is rerouted, and 9-0 nylon applied. Just a 2 minutes video. This is now being most often followed, which is the facial nerve mesenteric nerve anastomosis. This is a small video wherein this is the buccal branch of the facial nerve is taken up, buccal division, and this is the mesenteric muscle. We have to go deeper inside the mesenteric muscle to look for the mesenteric nerve, and an end-to-end anastomosis is done between the buccofacial branch and the mesenteric nerve. And this is the main stump being sectioned, buccofacial branch. Depending on the site of the facial nerve may either the complete main trunk or the divisions of the facial nerve, either the orbitozygomatic or the cervicofacial, can be anastomosed depending on the disability of the patient, whether the eye closure or the smile which is being affected.
I think you can fast forward with your videos to make it.
Yes, sir.
What's the magnification you're working on?
So
At this,
like we use a Zeiss Varios. Probably the focus is not mean for outside.
so one comment maybe from the audience, and then we move on to the next talk. Let's invite the next speaker.
Okay.
Thank you so much.
Thank you.
I know you had a little problem with
yeah.
your video. Excellent, excellent.
Thank you, sir.
As this conference brings together a diverse group of professionals and its diversity of thought and experience that makes our discussion so rich and impactful, we're excited to dive into the topics ranging from endoscopy, future of neurosurgery, artificial intelligence, and innovations.
Now I'd like to welcome Dr. Bani Thakur, who is a research neurologist, to talk on topic trigeminal neuralgia, microvascular decompression with the side graph technique.
Okay. Good morning. At the outset, I would like to thank Dr. Sahana and Dr. Cherian for extending the invitation. So I'll be talking on a very common topic, trigeminal neuralgia. But there's a slight modification that we have done for this in the surgical technique that I would like to present.
Hello.
So we are familiar with the anatomy of trigeminal neuralgia. Most commonly, superior cerebral artery is the culprit. We may have dual loops. We may have venous compression rarely with variety of anatomy. And this is the standard surgery. The fifth nerve and the loop are separated and a shredded Teflon graft is placed. So what we do is we have modified this and we do microvascular decompression with a saddle graft. So basically this is a vascular graft that the vascular surgeons use. It's a Teflon graft. We cut a bit of the graft, make it like a saddle, and then use it as a barrier. Surgery involves standard steps. We do the surgery in the lateral position. Standard 4 centimeter retromastoid incision is placed. Standard retrosigmoid craniotomy is performed. 360-degree of decompression of trigeminal nerve is done. And then we proceed with placement of the graft. So this is just a video demonstrating the same. This is right-sided surgery. Opening the cisterns to release the CSF. As far as possible, sharp dissection is advisable. We try and preserve the petrous vein most of the time. The fifth nerve and the loop of superior cerebral artery are identified and they are separated. It is important to dissect the arachnoid well. The nerve has to be absolutely bare for this procedure. Then we proceed to the other side of the nerve. This is the loop. It's completely off the nerve. And then the other side of the nerve. Similarly, the arachnoid is completely taken off. And this is the graft, shaped like a saddle. Because it covers the nerve 360 degrees, that is why it is important to bare the nerve completely by cutting the arachnoid all around. This is another video, another case. This is the fifth nerve and the SCA loop. Here, we also found that a large vein was lying on the nerve. And the objective was to separate the vein also away from the nerve. So the graft is covering the nerve, separating it from the superior cerebral artery and also the petrous vein. But we found that the root entry zone was still bare. So we used another graft to cover the loop itself. We have operated about 180 cases over last 9 years using this method. There were 2 cases of venous compression, rest were arterial, with 4 cases of dolichoectasia and 1 case of AVM. AVM was embolized. However, residual compression was there on the 5th nerve and that was dealt with by this surgery. All patients had immediate pain relief. There were 3 cases of recurrence, out of which 1 we operated. There was 1 case of hearing loss. We could not find out what was the cause. Our professor, Dr. Suresh Nair, often says, if you find that the ear is deaf on the opposite side, avoid doing the microvascular decompression on the ipsilateral side. Because in his experience also, he found that sometimes, rarely, there could be some hearing loss. In 1 case of death, that was a venous infarct. Venous infarct was seen in around 8 cases, but 1 of them succumbed. So summarizing, it's a novel technique, but it requires extensive arachnoid dissection. It may avoid formation of Teflon granuloma. This I'm saying because the case that we reoperated after around 2.5 years, the graft was lying as such like that. I mean, in the way we had kept it, and it was very easy to separate the graft again from the nerve. And we could simply just pull it away. Cause of pain was the edge of the graft that was causing compression on the root exit zone. We found this particularly helpful in dolichoectasia. I don't have the video for dolichoectasia, but provides a more solid barrier between the nerve and the vessel. And if we approximate the limbs of the saddle, catch it with the forceps, the nerve can be easily lifted. When we, we can, if we lift the nerve, the dissection becomes very easy in case of dolichoectasia. In dolichoectasia, we cannot mobilize the vessel. We have to mobilize the nerve. And beware of the venous sacrifice. Learning from that bad experience of a death, we always get a CT scan at night in all the cases in which we have to sacrifice the vein. And just to ensure that the patient and we, both of us, sleep very well. Thank you.
Yeah, very nice demonstration, Dr. Thakur. And this, your recurrence, you showed in 3 cases out of 190.
Yes. One was operated, two are kept on medical management.
2 were operated. Then what was the cause of recurrence?
One was operated. The recurrence cause was that graft was compressing on the, the limbs had come off and the edge of the graft was actually indenting on the nerve at the root exit zone.
Thank you.
Now I would like to invite Dr. Sharan Srinivasan, consultant neurosurgeon MBBS, to talk on topic functional neurosciences in the future.
Okay. Good morning to everybody at the onset. Switch off my mic. Where's my mic? Oh, the volume should go up. Huh? Okay. All right. Sorry. Good morning. At the onset, I want to thank IEP and the organizers for this opportunity. So I'm going to talk to you about a science I call as functional neuroscience, which is a combination of neuromodulation and neurorehabilitation, and that's the future. So welcome to the unique world of doing both together. Very few people do both together, because of which the functional outcomes for patients are suboptimal. I'm trying to address that. So everybody knows about VR, AR, MR. All of us as neurosurgeons and doctors are in the world called RR, which is real reality. Our patients are real, the suffering is real, our treatments are real, and our results have to be real at the end of the day. So let's look at some of the misbehaving brain circuits. So I'm going to show you only videos of patients. So I'm into a lot of lesioning in radio frequency ablation movement disorders. So let me show you some of the videos there. So we'll start with the surgery for focal hand dystonia. This is a musician or guitarist dystonia. A patient had this problem. The volume is not coming. How does the volume come? Oh, you need to put the jack here. Audio jack.
Is hand ready? 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 Is
What do I do? 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 Dr. Sanjeev Kumar is professor and unit head of neurosurgery at DKS PGI, and he happens to be a very good friend of mine as well and my colleague from Raipur. He's going to talk about a new technique for treating hydrocephalus, extra-axial ETV.
स्पीकर याचं बंद
Now. Good morning, everyone. I am very thankful to Dr. Sahana and Dr. Ayub for giving me this opportunity. And as this, the theme of this session is innovation, and this is the one innovation we together created. And we all have done the ETV for a long time, but the basic problem with the ETV that you have to go through the vein to make a perforation in the floor of the third ventricle. Next slide. So what is the rationale for the extra-axial ETV? As you know that conventional ETV is an intra-axial process, and the overall complication rate is 2 to 15% even with the expert hands. And we always thought that conventional ETV is really innocuous. And going through the brain, piercing the brain, going into the lateral ventricle, third ventricle, and perforating, making a perforation in the floor of the third ventricle, it is really innocuous. Let me show you. This is a post-operative MRI after conventional ETV. You can see that brain insert along the tract side. So endoscope does leave the footprints. And the basic problem with the conventional ETV, because of its intra-axial nature. Because of its intra-axial nature, it may produce a cortical damage. We all must have made a pharyngeal contusion, minor hemorrhage can occur from the ependymal veins, and basilar artery injury is a catastrophe. And irrigation-induced medullary body in a hypothalamic injury is also very well known. And the conventional ETV is very, very difficult if we get this situation, like slit ventricle syndrome. When there is a narrow foramen of Monro, it is very difficult to negotiate the endoscope through the narrow foramen of Monro. And when we get a thick and opaque premedullary membrane, it is very difficult to make a perforation. And when you have a narrow premedullary and prepontine space, you don't get enough space to make a perforation. And if you are trying a repeat ETV, scarring at the floor of the third ventricle is really a nightmare. So how to circumvent all these risks? Can we go extra-axial this way? Let's see that. So lamina terminalis fenestration for hydrocephalus is a 100-year-old procedure, and it was first described by Sir Dendy. And in 1963, Dr. Scarf reported 70% success rate with this procedure. And Dr. Maywoody has reported 100% success with the microscopic supraciliary approach for lamina terminalis perforation with microscope. These gentlemen have done the conventional ETV through the transventricular route, but when they went into the through the conventional ETV route, they realized there was not enough space there, or there was a problem with the floor of the third ventricle, or some anatomical constraints. So they started using the flexible endoscope to make a perforation in the lamina terminalis, and that works in 70% of cases, but there was a 20% complication rate. So we did a supraorbital keyhole approach, and we tried to perforate a lamina terminalis by making a small supraorbital keyhole craniotomy.
In this, we termed it as the extra-axial endoscopic third ventriculostomy because it's the extra-axial endoscopic procedure. You need to retract the brain very gently and very patiently. So once you reach the flow once you get the arachnoid at the around the optic nerve, you just need to open it sharply. Sometimes it get opened with the traction only. Once the CSF is released, the brain become very lax and it rests like a piece of cake. I use this nerve hook because I can lift the arachnoid through the nerve hook so that I can see the perforators and preserve them. Some minor bleeding from the dura may be possible because of the endoscope sometimes get rubbed against it. And you can see that I am going towards the opposite optic nerve, and more arachnoid dissection is required to retract the frontal lobe so that we can reach the lamina terminalis. Being an extraventricular process, there is no chance of intraventricular hemorrhage, and this is the because you are dealing with the vessels and all vessels and nerves are in the direct visibility. So you can control any bleeding if possible, if it occurs. So you can see that we can perform a wide cystostomy also there, which is not possible in conventional ETV. And the anterior cerebral artery and perforators appears on the visible side of membrane in contrast to the basilar artery and perforators which appears on the blind side of membrane in conventional ETV. So any bleeding, if it happens, you can do that. You can control that. This lamina terminalis is the widest wall of the third ventricle. It makes the anterior wall of the third ventricle. Its average surface area is 52 millimeters square. So you can make a wide stoma, and the narrow pre-memory and pre-pontine space is not an issue. You can see the nice dissection there. The another advantage of using a lamina terminalis is it is a thin and stretched membrane, in contrast to the pre-memory membrane, which is a redundant membrane. So technically, there is a less chance of stenosis. Now you can see that I am opening the lamina terminalis, and now I am widening it. You can peep inside the third ventricle, and you can see the anatomy inside it as well. You can see that pre-memory membrane is very thick and opaque. You can see the memory bodies. And this is the final picture after the ETV, extra-axial ETV. Even with the large hydrocephalus in children with enormous ventricular dilatation, the subfrontal retraction is possible. You just need a good relaxation and good anesthesia, friend. Once you open the arachnoid, everything, the brain sinks down and it is like a piece of cake. In this case, the arachnoid lamina terminalis was so thin that it got opened during the arachnoid dissection. And through that opening, you can peep inside the ventricle and you can look the beautiful anatomy of third nerve, basilar artery and perforator, pre-memory membrane, and posterior clearance process. This is the pre-op and post-op scans. Till now, we have done 58 ETVs in cases of obstructive hydrocephalus, including one case of split ventricle syndrome, 3 cases of failed conventional ETV, and 1 case of vertebropatellar dolichoaplasia. We calculated the pre-operative ventricular parameters with the post-operative ventricular parameters. There was a significant reduction in the ventricular indices. In acute hydrocephalus, the hydrocephalus get resolved, but in chronic hydrocephalus, the ventricular size came down, but does not normalized as expected. These are the clinical photographs. You can see the scar as at the eyebrows, and it is cosmetically also appealing. These are some of the example of comparative pre-operative and post-operative scans. You can see the resolution of hydrocephalus in cases of acute hydrocephalus, and in cases of chronic hydrocephalus, you can see the reduction in the ventricle size, but not normalization of ventricle size as expected. There was a worry that whether this ETV will work or not, so we checked the CSF flow through the CNS contrast MRI. Just focus on the anterior wall of the third ventricle. You can see the flow through the lamina terminalis, and it was present in all cases. One ETV failed. This was a case of a young boy. In August 2022, we did an extra-axial ETV, and this in next 8 months, the ETV was working well. Hydrocephalus was resolved. In June 2023, he had some sort of road traffic accident. He was admitted at the peripheral hospital for a femur fracture. No CT scan was done because he was not symptomatic for that. And August 2003, he came with the recurrence of hydrocephalus. So this time we placed a shunt. We have published this technique in JNS. Let's have a tour of some special cases of extraaxial ETV. This is the case of slit ventricle syndrome. This was a young girl shunted at a three year of age. She was doing well till 21 of year of age, and she presented in a peripheral hospital for a constant continuous headache and drowsiness. So they did a shunt ligation, and after shunt ligation, patient improved, and CT but after 2 weeks she came to us drowsy again, and the CT after 2 weeks shows that there was an increase in the ventricular size. So when we did the CT and ventricular morphometry, we can see that although for conventional ETV, although the entry of endoscope is possible, but further negotiation will be a Herculean task, because the minimum diameter required for a conventional ETV is a 5 millimeter. Here you can enter into the ventricle later frontal arm, but further negotiation is not possible. So what is the option left here? So we did extraaxial ETV. This was the intraoperative picture, and this is a postoperative. After 1 year, the ventricle size has optimized without having any clinical or radiological evidence of high intracranial pressure. We have published this in the CNS. This is the case of vertebrovascular dolichoectasia with hydrocephalus. If you see the literature, only one Japanese neurosurgeon has performed conventional ETV successfully. One Turkish neurosurgeon is dared to perform a ETV, but he has to back off. So how to do a ETV in this? The solution is extraaxial ETV. These are the intraoperative photographs. By making a fenestration far from the dolichoectatic vessel, you can make a safe fenestration. These are the pre-op pictures, and these are the post-operative picture after 5 months. You can see resolution of hydrocephalus. You can see the CSF flow through the stoma which we have created, and this shows that the stoma is still functioning. We have published this the utility of extraaxial ETV for this vertebrovascular dolichoectasia leading to hydrocephalus in World Neurosurgery. This is a 30-year-old man with multiple shunt failure. He has done multiple surgery. As you can see multiple burr holes there. He has done 3-time shunt, 2-time EVD, 1-time conventional ETV. So what is left to offer? The solution is extraaxial ETV. This is a virgin option. So we did the extraaxial ETV. This is at the 3-month scan. At 1 year scan, you can see resolution of hydrocephalus. And I think 2.5 years gone by, and still he is asymptomatic. You must have noticed that during the extraaxial ETV, we can very well nicely dissect the anterior cerebral arteries and ACOM region very well. So we try to step up the procedure, and we try to tackle the ruptured ACOM aneurysms. So we started using the same technique with a supraorbital keyhole, fully endoscopic, and started clipping the ruptured ACOM aneurysm of different orientation. You can see this superiorly directed aneurysm clipped endoscopically. This is a anterior laterally directed aneurysm clipped endoscopically. This is another one. And this is the posteriorly directed aneurysm here. We clipped it endoscopically. This is just a short video how to do a full endoscopic clipping of ACOM aneurysm. Initial dissection is absolutely same. Go subfrontal, release the CSF, then dissect the ipsilateral A1, prepare for proximal control. Then you can dissect the aneurysm, clip it complete endoscopically. This is the final picture. We have published this endoscopic clipping of ruptured anterior communicating artery aneurysm through supraorbital keyhole approach to Neurology India, and how to tackle the intraoperative ruptures in the Acta Neurochirurgica. If you want more detail, you can see this ACNS webinar on the YouTube. Thank you very much. Hope I have convinced you enough for trying extraaxial ETV. Thank you.
That's excellent. Can I ask you, is there a reason to think that the patency rate of this will be any different than a regular third ventriculoscopy done? Do you think it's going to stay open better?
I didn't get your question.
Yeah. So for the cases that you could do, through the brain and ventricle, is there any advantage to coming? Because I've opened up the laminar terminalis on every aneurysm I've done for years, but I've never looked to see if it stays open. You know what I'm saying? So do you think that this is more likely to stay open than the traditional third ventriculostomy?
If you see that how this ETV works, it always works because of the pressure gradient between the intraventricular and
But we've had some,
extraventricular.
John Kessel is a master in this in our place, and he's had some catastrophic failures of ETVs, traditional ones. You know what I'm saying? In children, they've had children die when the ETV stops working. So I'm wondering if this is an advantage of keeping it open more coming through the laminar terminalis. I'm just asking, I don't know.
So that's why we checked all this extra-axial ETV through the Cinephase contrast MRI, whether it is working or not working. So till now, I think we have a 2.5 years of follow-up. There was one failure with what I showed you, and the CSF flow across the lamina terminalis fenestration we created, it shows the CSF flow, and our ventricle size has not increased, and patient is asymptomatic. So we can assume that stoma is still functioning and is the CSF flowing good. The problem with the conventional ETV or any ETV, it has to work on the principle of the pressure gradient between the intraventricular and extraventricular. Once the pressure gradient is equalized, the CSF will not flow. So when there is, so that's why we have tried only the ETV, only this extra-axial ETV in obstructive hydrocephalus only, when the CSF has no other way to go out. So it has to go through that stoma only.
I think the stoma that you can make with a laminar terminalis is bigger than you can make through the floor. And so maybe an advantage. But we've had cases where they've been open with cine, and 4 years later, the kid, seals it off and they need a shunt, So there's no guarantee in the long run. It can happen in the long run too.
So this is the best anatomical advantage. If you see the size of the laminar terminalis, it is vertically 12 millimeter and horizontally it is 8 millimeter, with the mean surface area is 52 millimeter square. It is much wider than the premammillary membrane. So if you can create a wide stoma there, it is technically more likely to stay open than the conventional one.
Are there any other questions? Yes.
Thank you for your nice presentation. I'd like to ask you about your hydrocephalic cases. I see you have used blunt dissection in dissecting arachnoid and your adhesions, and this is not the base. So have you experienced any complication from blunt dissection? As
I told you, this is an individual preference. I have used scissors, nerve hook, or this bayonet forceps. Initial part I prefer to use nerve hook because you can lift the arachnoid and you can see the perforators. Any perforator are you damaging or not? You can use the scissor as well. There is no problem. So this is just individual preference. And till now, I am not encountered any problem by using the nerve hook and dissecting. So that's fine with, if you want to use scissor, that is okay, no problem. If you see the timing of what time of surgery I take, it is initially it was a 1.5 hours. Now I take around 40 minutes. Most of the time is used in the frontal lobe retraction, gentle frontal lobe retraction. As I told, the beauty lies with the anesthesia. If your anesthesia is not good, if you are not using the mannitol or hyperventilation, keeping the PCO2 around 30, you will get difficulty. Once your anesthesia friend is good, he will give you the 5-minute or 10-minute of window to reach there. And by that time, the moment you open the arachnoid there, rest is no problem. Yes.
Yes, that is also we have considered, but we have kept this in mind. We can take out the supraorbital rim or drill the frontal base, then drill the frontal base. Till now, we have not required it, but it is. But that can be done. We have kept as an option, but till now we have not used it. That can be done.
I've seen the indications that you have highlighted, the cases there, slit branch syndrome and obstructive hydrocephalus. Have you had any cases in the elderly for normal pressure hydrocephalus?
No. I have a strong belief that I told earlier. The ETV work on the principle of pressure gradient. If it is normal pressure hydrocephalus, then pressure intraventricular pressure is not much higher than the extraventricular pressure or subarachnoid pressure. No ETV should work. Any ETV, even a conventional ETV, if works in normal pressure hydrocephalus, the reported incidence, reported success rate is 50-60%, whatever. It cannot be justified how it is working. So I never try extra axial ETV in normal pressure hydrocephalus or communicating hydrocephalus. It is specifically for obstructive hydrocephalus. Even I use conventional ETV. I used to use then in only obstructive hydrocephalus only. Conventional, not for even the communicating or normal pressure hydrocephalus.
Thank you, Doctor. Now I'm pleased to call Dr. Devasa Sahana to talk on topic internal acoustic matrix localization during anterior tracheostomy.
The delegates will have to wear the belt. We are trying to maximize the speaker and your listening time. So there are no breaks here or you will be. I hope you'll bear with us. One request, after the session is over, when you go, before you go, please do go to the stall area. They have a responsibility. Gray shirt. I'm sure you have time, so you spend time there.
Good morning. I'll be talking about some techniques to localize the internal acoustic meatus of the canal during petrosectomy, and a new technique that me and my colleagues, Dr. Sanjeev from Raipur, have come up with. So the shaded area is the petrous part of the temporal bone, and the yellow shaded area is the part that we're talking about drilling, the anterior part of the petrous bone. So if we just do a temporal craniotomy and take a subtemporal route, this is the area up to which we can reach. But if we add a petrosectomy, we can reach up to the level of the internal acoustic canal, the mid-clivus lower part. So what are the limits of this bone drilling? Laterally is the greater superficial petrosal nerve. Anteriorly, it's the mandibular nerve medial to where the GSPN passes beneath it. Medially, after bone drilling, is the posterior fossa dura, and inferiorly, it's the inferior petrosal sinus. Now, posteriorly, there are structures which limit the bone drilling. So we have superior semicircular canal, we have internal acoustic canal and the meatus, we have the cochlea. But unfortunately, these structures are not, they are covered by a bone, they are not visible. So the surgeon needs to know beforehand where the location of the internal acoustic canal or the meatus lies. So different authors have come up with different techniques. They have used different landmarks. The arcuate eminence has been used, GSPN has been used, the geniculate ganglion has been used, the zygomatic arch, the external auditory canal, foramen rotundum, foramen spinosum. All these have been used as landmarks to localize where the internal acoustic canal or the meatus lie. So the most popular of these techniques is the Garcia-Ibanez technique, which takes into account the long axis of the GSPN and the long axis of the arcuate eminence and the GSPN, and at the bifurcation of this angle lies the lie of the internal acoustic canal. But there are certain problems with this technique. The arcutemenis may be absent in about 20% of the cases. The shape of the arcutemenis may vary. It may be circular, it may be flat, rectangular, has also been described pyramidal. So when the shape varies, it is difficult to say what the long axis is. And this angle is not always 120 degrees. In fact, in our study, we could use this technique only in 86% of cases, and we found a wide range and a high variance for this angle. And the bifurcation, a true representative of the internal acoustic canal, we found only in about 14% of cases. Next popular technique is the Fisher's technique, which also takes into account the arcutemenis, and at 60 degrees to this is the lie of the internal acoustic canal. So what was initially described as blue lining this the superior semicircular canal, which has its own inherent risks of damage. And this angle, 60 degree, has been described variably from the range of 34 to 75 and 30 to 30, 10 to 30. And this arcutemenis as a reliable landmark for the semicircular canal is true only in about 20% of the cases. And in our study, we found a wide range and a high variance for this angle as well. Neuronavigation can be used, but even with the lowest position of the optical camera and the highest position of the microscope, the instruments still come in the way. So one has to constantly move the microscope. So we did a study and we found, we read about 150 CT scans, so 100 sites in total. We did some study on cadaver skulls, and the results were applied to some patients with petroclival lesions. We found that foramen ovale and foramen spinosum were the only consistent landmarks, and there were some variations in the other landmarks. And like I said before, we found a high variance for the Garcia-Ibanez and the Fisher's technique. We looked at a different angle, the foramen ovale, foramen spinosum, and the RAM angle. So in this one, the first, it's formed by two lines. The first line formed by joining the outer borders of foramen ovale and foramen spinosum. And the second line is joined by forming the anterior part of the internal acoustic meatus and the posterior part of the foramen spinosum. And we found that the mean of this angle was about 94 degrees. And the variance for this was much lower compared to the other. Yeah, so the FO, FS, and IM angle is formed by two lines. The first line is formed by joining the outer borders of foramen ovale and foramen spinosum, and the second line is formed by joining the anterior border of internal acoustic meatus and the posterior part of the foramen spinosum. And we found that this angle had a mean value of about 94 degrees, and the variance was about 1/4 of what we found for the Garcia-Ibanez and the Fisher's technique. We found similar results on dry skulls. So we decided to apply this on patients. And this was a patient with prepontine epidermoid. And we did an anterior petrosectomy for this patient. After temporal craniotomy, the base was, the bone was drilled flush with the base. The dura was lifted off the temporal base in a lateral to medial and posterior to anterior direction. We started seeing the middle meningeal artery arising from the foramen spinosum, which is the first landmark. The GSPN was isolated. Care was taken not to damage it. The middle meningeal artery was coagulated and cut. And extra foramen ovale was also identified. The dura overlying it was cut slightly to help in retraction. And now we have both the landmarks ready, the foramen ovale and the foramen spinosum. The first line is drawn from the outer borders of foramen ovale and foramen spinosum. And the second line is drawn 90 degrees perpendicular to the first line. So for measuring 90 degrees, we can use naked eye, or I use a sterile plastic cover, the corner of a sterile plastic cover, and this gives a 90-degree angle. So this line is also marked, and this is extrapolated onto the petrous ridge, which gives the location of the internal acoustic meatus. And following this, the Cavaz's triangle is drilled. So this is the post-op scan. We could get the whole epidermoid out, and we can see the amount of bone drill just anterior to the internal acoustic meatus in the canal. We did some other patients as well. This was a midbrain brainstem cavernoma. And here the pre-op angle was found to be about 90 degrees. And this is the post-op scan with the bone drill just anterior to the IAM and the canal. This was another patient with a petroclaval meningioma. And here the angle, the pre-op angle was about 96 degrees. This is the post-op scan. We could get the whole tumor out. And we have done a few cases using exoscope. We had a 2D Whitehome exoscope. And this was a petroclaval meningioma. And this is the post-op scan. Some part of the tumor had to be left behind. It was stuck to the perforators and the brainstem. But the amount of bone drilling, again, just anterior to the internal caustic canal. This was another patient with epidermoid. Here the pre-op angle was again 90 degrees. And the post-op scan shows the bone drilling, the extent of bone drilling. These are some pictures from the exoscopic view, the foramen spinodome amplification and coagulation, exposing the foramen ovale and the spinosum, drawing a 90-degree angle and drilling the Kawasai's triangle. So till now, we have done about 24 of such cases, and we could identify this internal acoustic meatus reliably in all but one case, which was this case of a giant trigeminal schwannoma. Like you can see the pre-op CT scan, all the landmarks were destroyed, but we could still get the whole tumor out because these are the cases where much bone drilling is not actually required because the tumor has done most of the work for us. So this technique of ours was accepted and published in World Neurosurgery last year, July edition. And the conclusion was FOFS IM angle is a reliable tool for localizing the internal acoustic meatus. So I think right angles are right for anterior petrosectomy, but I would love to hear what you feel once you've used it. Thank you.
Any comments for? Go ahead.
Intradural work to get a wider petrosectomy.
I've never tried that, honestly.
And that is the lower limit of the resection that we're doing for typical material. That is where the tumor goes behind the section and then goes below.
Yeah.
Now can we little bit more space when we drill it off after opening the dura and doing some.
Okay, you're saying to drill a little bit more after we've done some of the intradural work. Okay, that's a good idea.
Very nice work, Devabrat. Just two comments from my side. I saw you dissecting the GSPM from behind forwards.
Posterior to anterior.
I would prefer doing it from the other way around, anterior to posterior. The reason being, you reduce the traction on the geniculate ganglion during this dissection if you come from front behind. That is number one. Number two is, there are different techniques. Your technique is also very nice, but the most practical way, which I find has been described by Dr. Roten as well, is that you start bone drilling from the safest area. The safest area is the petrous ridge, the area of the superior petrosal sinus. That is the safest area. The most difficult area is lower down towards the GSPN and its angle with IM.
Right.
Therein lies the cochlea, and around 2 millimeters deeper to it lies the petrous ICA. So you go to that area last, you start drilling from the petrous ridge, medial to lateral. So expose the fundus side of the IM. It is the porous side, expose the porous side, that is towards the CP angle side. It is the fundus side that is the most difficult part. So you start drilling on this side edge, you start seeing the internal auditory meatus and just drill it over it. You don't have to drill at the junction of GSPN and IM because that is where we can cause hearing loss. So I think that is the most practical method, and all these methods are more or less like correlating, but in prop, it becomes very difficult to take measurements and all.
Right. Absolutely correct. About the first comment, we have always done it from posterior to anterior, and that is what the standard teaching is. I don't have any experience with anterior to posterior dissection, and it's a technique like any other technique. Every surgeon has their own preferences, their own appreciation of anatomy, and that is what I think is the best way. Whatever the surgeon is comfortable with.
Yeah, very, very nice. I think having more than one method to do it is good, because we do a lot of middle fossa acoustics, And we usually just split the difference. That's called Brackman's angle, where you bisect the angle between the arcuate eminence and GSP, and then drill, like he said, right along the posterior or the superior petrosal sinuses. But if you can't use the arcuate eminence, the otologist will also just drill along the facial nerve from the geniculate, find the IAC, and then come back very shallow so you don't hit the cochlea.
Right.
Okay. Okay, thank you, doctor.
Now that we have navigation,
right?
So why can't we just point over the IAC and
we can do that, but then you have to keep on moving the microscope. With the use of an exoscope, this gets reduced to a major extent. But if you have a microscope where the working distance is limited, the navigation probe will come in the way. You have to move the microscope again, bring it back. So it's little cumbersome.
Okay.
Okay, thank you, doctor. So I'd like to welcome Dr. Vishwa to talk about his generation training in neurosurgery.
Make it share. Do it. So can I see the presentation? Yes. Thank you. So very good morning to one and all. Respected chairpersons, I would like to thank Professor Aipe, Dr. Saha and Dr. Devasa for inviting me here. Thank you. So I shall be speaking on simulation training in neurosurgery, need and current status in India. So we know that our specialty has certain peculiarities that we work for long hours. We deal with critical structures, so the stakes are very high. Often any surgical mishap and misadventure can lead to a long-lasting deficit, which would be very devastating for the family. And the training curve in neurosurgery is quite arduous, and we have certain steep learning curve procedures in our specialty. So traditionally, most of us in India, including me, have been trained by traditional Halstedian model, where a resident first assists his mentor for few cases, then he is allowed to do certain cases under supervision, and then he finally does the cases of his own. So the question is there a need to modify the training pattern? The reasons cited for this are that training in our country is non-uniform. Means the training centers are located across length and breadth of our country, which is quite vast. So the caseload as well as the type of cases may not be the same. Like I went to Sri Chitra some time ago and I saw that the incidence of spinal dysraphism was quite, I think they hardly operate any. While in North, it would be 3 or 4 cases per week. So the resident may not have the exposure to those kind of cases in each center. Then our operation theaters are under continuous social vigil and ethical questions that how can a junior person operate on my relative, and if any surgical misadventure happen, the society is intolerant. Then about our trainees, they all do not learn at the same rate. Some would be very sharp. They need just few cases to learn. Another would be not as smart, and they would need higher number of cases to learn the same skill. Another thing is that there is no way of measuring competency in the traditional method. We award a degree of MCH after 3 year or 6 year of training to any resident, but whether he or she is equally competent is not known. So we can't measure the competency in a traditional method. In India, there are 156 neurosurgical centers, 88 award MCH and 68 DNB. But as I told, the difference in terms of quality and quantity are huge. Few centers have most of the workload while others have very small number of cases. And further in government and private centers, because of the cost issues and surgeon-based outcome issues, a surgeon might not give the important part of surgery to his trainee resident. So the learning may be different in those scenarios. And another thing which happened in our country at around 2013 or 14, that the seats were abruptly increased without increasing the training base. We had around 3 to 4 number rise in the resident number without increasing the number of beds or wards or any other facility. So the numbers were cut down for whole neurosurgical trainees across India. Then the different subspecialties of neurosurgery have different training requirement. Post ISET, we all know the paradigm shift happened, and even the simpler cases of ACOM and MCA are taken up by the endovascular surgery. And so that the micro neurosurgical skills are actually now dying in this field. So the surgeons are getting more complex cases, and they are unlikely to be handed over to the residents. So the more expert people will be operating them. In pediatric surgery, we have narrow corridors, delicate tissues. Spinal surgery has an inherent risk of litigation. So the surgeon might not like to give a trainee the most difficult part of the surgery. Like in a TLIF, I would like to give only screws to my resident, but when there is a tight stenosis, the decompression would be done by me. So these kind of things do not create a harmony among the across the country in uniformity in training. So this statement was made by American Association of Clinical Anatomists that today's residents in surgery are learning their anatomy on sick patients for the first time in the middle of the night. Operating without a sound knowledge of anatomy leads to increased mortality and morbidity. I hope all of you agree with this statement. The screen is not moving. Okay. What is the answer to this query? So simulation training is the one which can help us in this regard. It is not a new idea and has been used by aerospace industry since long, because the stakes are again higher there. So simulation is imitation of a situation or a process. So what is the advantage of a simulation training? Generally, when a new rookie enters our OT, he would be second or third assistant and would not be allowed to do much part of the work. But in a simulation environment, he would be the one who is a central man, would be doing the most of work. It is a low stress environment. It is supervised by a mentor, and there is a margin of error because life is not involved. Then also that you can have multiple scenarios condensed into a short period of time. You can practice much more. So these two gentlemen has revolutionized the surgery by spending most of their time in labs. And what are the current modes of simulation which are available for a country like India? The cadaver dissection would be a gold standard thing because it mimics the normal anatomy exactly. And they were easily available till some time ago. Then animal models like rat models can be used for vascular suturing. Dry models like chicken wings are easily available, can be used for microsurgical training and suturing techniques, and they're cheap. This spine model is a example of a Barrow biomimetic spine, have been developed at Barrow Invention Center by the residents. So it has excellent properties which are like the normal spine, both radiologically as well as in the feel when you insert screws. The virtual simulators are now presented as the next gold standard, but a actual virtual simulator which has a real-time haptic feedback and realistic deformation of tissue would be much costlier, will not be available in most of the neurosurgical centers in India. So they are currently having a backseat as far as the whole country is considered. This is the list of major neurosurgical centers which have their labs or their labs are under development. Out of these, AIIMS Delhi, PGI Chandigarh are the ones who use the resident training their labs for general resident training. Otherwise, most of these centers utilize their labs only when there is a conference or there is CME. So generally, residents do not go during a part of their curriculum. Neurosurgery Education and Training School is one of a kind facility in India established by Professor Suri and German collaboration. It has all kind of facilities like cadaveric workshop, microsuturing facilities, low cost models. And this is the facility which need to be replicated at multiple centers. But again, there are some constraints. So there are few workshops in India which are which have regular cadaveric workshop in them. NSI and NSI are the two societies. The first day of their conferences is always dedicated to the workshop, which is predominantly towards the residents. Otherwise, NIMHAS Neurosurgery workshop is another one where the residents are the predominant stakeholders. But in other conferences, there are generally the practicing neurosurgeons would be the one who would be going to learn the thing. Professor Ramesh Tigla is also here. He also runs a very good academic workshop. So we also tried our hands at the simulation, and all of it started in COVID. These are our first batch of residents who are practicing on a cadaver in an anatomy lab. This is endoscopic dissection extended. We have exposed the both ICS, optic nerve, basilar artery. They can be beautifully seen. This is pituitary, which has been transposed. You can see the basilar artery perforator, third nerve traversing between PC and SCA. Photograph of a specimen of brachial plexus dissected by our residents. He's my colleague, Dr. Sarvanan, training on a endovascular simulator for residents. We have virtual dissecting facilities at our center, which can be used. And this is a synthetic model, which we can dissect by layer, and then we can resuture it. And this table is an AutoPage table, which is a very high fidelity platform. We can load any DICOM data into it and can be reconstituted into, like you can practice your CV junction strategy, any screw formation, anything layer by layer. So what are the challenges for development of skill labs? Most important are the space, fund, and their administrative approvals. Unless you think of having a lab at the start of your design of your hospital, it is not possible to later on buy a space there. So the cadaver models were initially were in plenty, but now with the policy of Government of India of having a medical college in each district of country, is now have divided that base also. In our North India, we earlier had many religious societies which gave us cadavers on regular basis. But now, because of in a small state of Uttarakhand, we are having 7 or 8 medical colleges. So again, the cadaver supply is now limited. Then another factor is if you have a lab, you need dedicated manpower. Means you need dedicated faculty members who would take the time out of their operating hours and then are dedicated to simulation training. A simulation training would be useless, a module would be useless if it is not analyzed. So you have to test the person before performing the skill and then after the skill. So this would require the designing of that performer and then evaluating it. So it need manpower hours, which is again a limitation. Most of us would like to go to OT rather than spending time in simulation lab. And then once a facility is set up, you have to maintain it. It again needs funding and dedicated manpower. So these are few challenges which we need to keep in mind. So possible solutions are that we cannot have space in every medical college. We can use the labs of anatomy, which are already used for MBBS dissection and forensic departments. And then we can collaborate in the odd hours. Then low cost physical models as have been developed by Professor Yadav, Dr. Suri and Dr. Tigla can be used. And established facility can be used on rotation for the units. So simulation training is an adjunct that improves technical competency and can provide uniformity to the training. And our conclusions are that simulation training should be integral part of neurosurgical training. And graduating from laboratory to the operating room is a way forward. So I'll end my talk with a statement of Sushuta. For one to be skillful and erudite surgeon, one must first be an anatomist. Thank you.
Very nice. I think I'll just make a comment. Teaching and learning are two different processes. You can take a horse to water, but cannot make it drink it. And I'm sure in the same community of neurosurgeons, we see so many bright sparks. But if you identify at a training stage what they were doing, how many hours they were spending, that is where the difference is. It is not the place where they come from. So I think I'd like to summarize by saying this, that, we have to evolve as a neurosurgeon from a resident day to a functioning neurosurgeon. As he said, we don't get an equal platform. Everybody doesn't get exposed to the equal variety of cases. We evolve as we go. And wherever you should be the doctor of your own self, you should analyze wherever you are falling short of skills. I think we should go to simulated situations and learn ourselves and move ahead. And we need not do everything. Identify what you can do best and go ahead. I'm sure no organization can be so perfect that it will train a neurosurgeon to a perfect neurosurgeon. I think the onus is on the neurosurgeon. Thank you. Can we call I think we'll conclude. Thank you so much. It was a wonderful talk. He summarized excellently. Is it the end of the session? Yeah. So we come to the end of this session. The next session will start. Before that, I'd like to honor the speakers. We'll be calling them. Come. Are you ready?
Yes. Thank you, speakers, for your enlightening presentation and valuable insights. As a token of our appreciation, we would like to present you with a memento and a certificate of appreciation. I would like to invite our esteemed chairpersons to come forward and present the memento and certificate to the speakers. I would like to invite Dr. Kuntal Kantidas. Yes. Next, I would like to invite Dr. Arun Sahu. Next, I would like to invite Dr. Ramesh Tigala. Now, I would like to invite Surat Munasinghe. Okay, next. Now, I would like to invite Dr. Karthikeyan Palaninathan. What's that? Baumit Thakur. Now I would like to invite Dr. Baumit Thakur. Now I would like to welcome Dr. Sanjeev Kumar. Now I would like to welcome Dr. Devutra Sahana. Next, I would like to welcome Dr. Rajnish Arora. Now, I would like to invite Dr. Sharon Srinivasan. Yes.
Thank you so much, Professor Kulwar. You know, he came, traveled 7 hours, 90, before that, I think 19 hours from his own country. And he came straight here and he's continuously been with us. I thank you so much, sir. And then he'll have to go back at 4 o'clock from here. So we are honored that you're here. I wish I was here to welcome you, but he'll be here soon. And then we look forward to your talk too. So thank you so much.
Now we are going to start the second session. Let me introduce the chairpersons.
Hello. You already have.
Dr. Sanjeev Kumar, Dr. Amit Upadhyay, Dr. William Kodwal, and Dr. Manas Panigrahi. So please be seated.
Let me invite Dr. Dibojyoti Mahakul, who is a consultant neurosurgeon at JIPMER, New Delhi, to take a video lecture on carotid stenting using embolic protection devices. Please, sir.
बस वो लगा ली टेंशन मत लीजिए वो आईडी वाला
It's not saying? Okay, fine. Okay, very good morning to one and all. I'd like to thank the organizers for the opportunity and congratulate them for organizing such a wonderful academic gathering. Coming to my topic, carotid artery stenosis, as we know, is like a ticking time bomb, and in the long run might lead to embolic phenomena. And we have three arms of management: the medical one, comprising of this mostly of statins and antiplatelets, and the revascularizing techniques. There's in the 1950s, DeBakey and Cooley actually popularized the carotid endarterectomy. And over the last half century, it has increased. The number has increased. You can see the procedures of CE over the decades, propelled by the pooled analysis of NASET, ACAS, and the VAX trial. There was a sustained increase. However, in 1990s, with extrapolation of the use of stents from peripheral intervention into carotid stenosis, there was a drop in the number of cases of CEA with increase in the number of carotid stenting. And after that came in 2004, actually, the FDA approved carotid stents for stenosis after the results published from the Sapphire study. And after that, there were certain European studies like ICSS, the SPACE trial, and the largest RCT so far comparing the CEA with the carotid stenting, the CREST trial. There have been increase in the number of cases of the stents. However, results were good, but there was an increased risk of stroke, most of them attributed to the not using embolic protection device for this procedure. So it's very important to learn the basic steps. So I had a 60-year male diabetic hypertensive with a history of acute ischemic stroke 6 months back, left with hemiparesis and the non-invasive imaging showing 80 to 90% of luminal narrowing of right ICA. Next, we went ahead with that's the most important one, the diagnostic angio, showing all the dimensions. We had a length of stenosis segment of 2 centimeter, with the degree of stenosis being 91%, And since the ICA diameter was 4 and CCA diameter was 6.7, which went for a 8.6 cross 40 mm tapered stent closed cell type with self-expandable one. And these are vitals. These important measurements are very important. The patient was already put on dual antiplatelets, 7 milligrams and prasugrel of 10 milligrams per day for 7 days prior to the procedure. And since the procedure was done under LA, the neurologic examination was done. These are the hardware that he used: 7-French short sheath, 035 exchange glide wire, 5-French diagnostic catheter to start with, then to be exchanged with a 7-French 90 centimeter long sheath. And the embolic protection device that we used was 5 mm of diameter, since the ICA, the diameter of ICA was 4 mm. And the balloon was used for angioplasty, and as I said, the 8x6 is 40 tapered self-expanding stent was chosen for the procedures. We start with the groin axis with the common femoral artery, and heparin was given, and 4,000 units was given, and the diagnostic catheter is being advanced with the descending outer under fluoroscopy guidance. Then you can see the diagnostic catheter, 5-French diagnostic catheter in the CCA, and in the proximal CCA, and the angio runs for the diagnostic catheter showing the culprit not right. Then the extended wire was actually parked in the one of the branches to stabilize it so that we can use the diagnostic catheter with a long sheath. The light wire in one of the branches to stabilize the wire. Now we are extending with the long sheet for 7.5 centimeter into the proximal part of CCA. And that's the angle run with through the long sheet again. And then comes the preparation of the filter device. It's very important that we flush out any kind of air trap in the device to prevent such complications. It comes with a bare wire of 0.14 inches that needs to be shaped according to the measure of the ICA. And you can see as we slowly progress as a fluoroscopy guidance till we go past, we give the top to actually help it negotiate through the stenotic segment and go past it. And it needs to be kept in one of the segments at least 2 centimeters beyond the stenotic area, so that you can have any kind of reporters during the procedure. That's the angiographic done. You can see the position of the filter device and the stenosis segment. At least 2 centimeters should be the gap between the stenosis segment. This is the filter device, the retinol, the frame, and with the polyethylene the filter device with the pores that now we are the balloon. Again, very important that we flush out any kind of air in it. You can see approximately the distal marker of the balloon across the stenosis segment. And with 1:1 mixture of dye and saline, we try to inflate it. Now, one eye should be over this roadmap, other on the first of the third eye should be actually watching the vitals of the patients. The patient might land up into bradycardia. That's the first attempt at freestyle balloon angioplasty. Then we go into the second attempt, and this time the patient had an episode of bradycardia, and he terminated the angioplasty, pre-stent angioplasty. Then that's the after the angioplasty. Then we prepared the stent. As I said, it was approximately 8, distal 6 mm, tapered closed type of a stent, self-expandable stent. And using the monitoring system, we place the proximal, and you can see the proximal and the distal markers of the stent right across the stenotic segment. And by actually rotating the actuator, we'll slowly deploy the stent, making sure that it gets opposed to the inner wall of the carotid artery. And once it is deployed, the next thanks to the angiographic runs, you can see we are happy with the amount of opening the stenosis that we achieved. We are trying to retrieve the filter device back. Since we are happy with the opening of the stenosis, we didn't opt for any
post-stent angioplasty, plus the patient had an episode of deadness. That embolus that was trapped by the filter device, and matter it would have put it approach if we not use the filter device. So in the post-stent margins were regular, no resilience against thrombosis, no evidence of any dissections, and no any form of embolism in the circulation, no dropout of intertidal vessels. The post-operative patient was completely intact. Even the ECG and cardiac enzymes were absolutely normal, and patient was discharged and were antiplatelets of aspirin and hospital. There's another case where 60-year-old non-hypertensive well diabetic with multiple episodes of high-risk TIMC, deficit score of 4. This time, the technique was a bit different. In that, we used a coaxial system where we didn't go with a 5-minute diagnostic catheter straight away. We went with the coaxial system with long sheet inside the diagnostic catheter and with the O35 glide wire. And once we actually calibrated the CCA, the whole inner system with the 5-minute diagnostic catheter and the glide wire was removed. Since the stenosis was not severe enough, not to allow hardness to pass, we didn't opt for any stent angioplasty. We directly went ahead with the placing the filter device. And the idea is showing the confirmation of the filter device. The filter device completely opened up. And post placement of the stent, there was residual stenosis. So we did opt for a post stent angioplasty this time. And that's the final opening of the stent. And final position. Then you will show the final. This is the final position of the stent and the There's another case with almost a pre-operative stenosis, where there was mandatory to go for every stent angioplasty, but dilation so that we can actually pass the hardware. And the showing photograph showing the filter device, and the third was showing the placement of the stent. And we're happy with the opening of the stenosis. So it's being a cerebrovascular surgeon, it's very important that we also need to evolve when the lines of signal is there. Study this technique will help us have a hybrid kind of an approach to pathology, and definitely knowledge of some of the hardware actually helps us in getting over the line. Thank you. I would take this opportunity to actually invite you for the annual conference of the Skull Society of India, which is supposed to be being organized by the Hospital in Delhi. And it's in the month of October. We'd love to host you in the next month of October in Delhi. Thank you.
A wonderful overview. Do we have any questions for our speaker? Yes.
Comments? Dr. Divya? So when we use the filter device, yes, we have got a class 2 evidence of using a filter device for a procedure. Wherever possible, we need to use a filter device. There are other devices which are wire dependent. So you have shown that wire not independent devices. So there are wire independent devices. Whenever the last case you were showing with the tight stenosis where the passing the filter was a difficult thing, the wire independent devices would definitely help in that situation with a proximal occlusion with the balloon. Again, that's a double protection, what we say. And try not to exchange. That's my suggestion. Try not to exchange because exchange causes a lot of complications.
Yes, actually, right. The first case that I saw, that was one of my initial cases. Once I got better with my maneuverability, I have moved on to the coaxial systems. And coming to the same thing, the balloon devices, we have kind of a MoMA device formed, I think, from the Medtronic that works mostly like with circulating array, like what we do for the CEA. It works in the same mechanism.
Thank you, sir. Next, we have Dr. a senior consultant in Bangalore with over 17 years of experience in neurosurgery. I invite him to take the lecture on management of ischemic shock, stroke.
Good morning, everyone. First of all, I'd like to thank the organizers for having me for this function. Dr. Cherian, Devrata, thank you so much. We all know that 80% of strokes are ischemic, and we lose around 2 million neurons every minute after the onset of an acute ischemic stroke. I'm not going to talk much about management, and I'll tell you more about how the management of stroke has evolved, especially over the last decade. And I was happy and proud that most of these have happened during the time of my fellowship. So this is what it is. Initially, you had a COX-2 device like the Mercy device. It would probably damage more of the vessels than get the clot out. And then you had a small shear like a penumbra, which would lyse the clot and you could aspirate it. But after the earlier part of this last decade, you had stent retrievers, which would probably help get the clot out. And a company based in California came out with a device called the penumbra device, which would help suction out the clot. So these are some of the pictures that we would usually see. You have an occlusion of the right middle cerebral artery. You had an aspect score, which was first devised in Canada, again by an Indian, Dr. Mayank Goyal, who settled there. And later came perfusion imaging, which would better understand which patient you would probably intervene on or probably have prognostication on their outcomes. So basically a video on how these stents are deployed, and then you aspirate the clot, everybody is happy, the clot is out. But what next? You have an MCA clot. The MCA clot has been removed and the MCA is open, the patient is happy, mild deficits rather than having functional disability. So these are some of the images that we see day in and day out. Ischemic strokes occurring in various locations, anterior circulation, posterior circulation. But there was a paradigm shift in the management of ischemic strokes on the 1st of January 2015 when the Mr. Clean trial came out from the Scandinavian countries. And this was followed by various other studies, the Extend IA trial, you had the SWIFT Prime, Revascat, the ESCAPE trial. All these trials showed that there was statistically significant outcome in these patients who are managed with a mechanical thrombectomy procedure rather than intravenous thrombolytic agents which are administered. So much so that most of these studies were stopped, so that they said that continuing the study further was more detrimental to those patients who would not receive this kind of a treatment rather than waiting for the study to get completed. And as I just showed, these are some of the images of patients who had occlusions in their internal carotid arteries or the middle cerebral arteries. And many of them, as you see, are pretty young. They had a binge over the evening. They had various comorbidities or they had risk factors, smoking, alcohol, substance abuse, and many of them have had a very good and fruitful outcome. So you remove a clot, but then we need to learn on whether we can speed it up. And this was a study which I was involved during my fellowship. applying the same concepts of getting a patient into a cardiology suite to get a good TIMI outcome. The same was used in cerebrovascular thrombectomy, where you use a TICI outcome, that was thrombolysis in cerebral infarction. So the patient should be within 45 minutes, a decision should be made whether the patient should undergo a procedure or not. And as you see lower down with the dark circle there, by 60 minutes, his groin should be punctured, his or her groin should be punctured, or the radial artery should be punctured to remove the clot. So as you see, you have this Stratos from Red Bull. The Baumgartner jumped from the edge of the atmosphere. So same way, can we stretch it further? So we go to M2 segment occlusions. We have a clot in the distal M1 going into the M2. We should remove them. What's the evidence for that? A meta-analysis showed that there is a better outcome for these patients to undergo mechanical thrombectomy than medical treatment, even if the clot is distal to the M1. So these are stretching the boundaries. What about unsuccessful thrombectomy? Where can that happen? You can have a very bad anatomy, especially in elderlies. You could have atherosclerotic disease intracranially. You could have dissection, both primary or iatrogenic when you do the procedure, or you could have a heart clot, maybe calcium or atherosclerotic plaque has disrupted and then migrated upwards. Those are difficult to retrieve. So among all the studies I show you, the chance of recanalization is around 30%. So if you have a patient you've retrieved a clot, but has a large infarct and you don't stent, it's going to have a bad outcome. But if you stent, you're going to risk the person from having a bleed because you opened a dam which was closed for nearly 5-6 hours, and suddenly the rush of blood when dysregulated cerebral blood flow would give rise to a chance of bleed. So this patient is one who had a plaque which was probably causing a clot there, and it got disrupted and the vessel used to shut down. So we had to stent this patient, and this patient had a good outcome. So rescue stenting, as I said, stretching the boundaries, is good for those who have is good. This is another one which I'll show you. This is in the carotid artery. These are good if the patient, if you stent either intracranially or outside, you should prognosticate in such a way and see the volume of the infarct. If the patient has a large volume infarct and then there are very good collaterals, then that patient would benefit from the collateralization. Whereas if it is atherosclerotic, if there is a small volume infarct, you've done the thrombectomy very early and the patient has very poor collaterals, and these cases it's better to stent these patients. So you've done distal occlusions, you've extended the time up to 16 hours. And what about trials of giving IV TPA and then doing mechanical thrombectomy? These are the various trials which came out, which showed that there was neither superiority or non-inferiority of mechanical thrombectomy directly versus IV TPA followed by mechanical thrombectomy. Then came this trial called the DAWN trial, which extended the time, as I said earlier, 16 hours up to 24 hours now. So that they found out that these patients, but there was a very good mismatch between the clinical deficits versus what you see on the radiology, clinical to radiological mismatch, then these are ideal patients who can undergo mechanical thrombectomy. So you have a DAWN and a diffuse 3 trial. There are various inclusion and exclusion criteria, which I will not go into for want of time. But diffuse 3 trial gave an idea on how much of the volume mismatch should be the ratio of the area at risk should be more than the area which has infarcted, and the ratio should be 1:8 and a minimal mismatch volume of 15 ml. So now you see you have the Mistoclean trial, which is extended up to 24 hours using the DAWN trial. So what about large volume strokes? You have a stroke in a patient who has an aspect score of 3 to 5 with volume of at least 50 ml seen on the CT scan. These are very young individuals sometimes, and you just can't leave them and say that this is a large volume infarct, this patient is not going to benefit. So a poor aspect score with a large volume, studies have shown that if these patients undergo mechanical thrombectomy, they have a 20% chance of a better outcome versus 7% for those who have just undergone medical management. But here again, you have to see that this would probably be ideal in very advanced situations, especially in the West, where you have good rehab, because not all of them, as I see in this picture, are going to improve. This is a 70-year-old lady who had a large volume infarct. We went ahead, did a mechanical thrombectomy, did not improve, and we had to go for a decompressive craniotomy. This is a case which I did last week, a very young individual with occlusion of the terminal ICA, very poor collaterals. There was no flow from the other side. The ACA, as you know, and the MCA, because of the terminal occlusion, was blocked. So we went ahead, did a good mechanical thrombectomy, but the patient did not improve. In fact, the patient had a bleed, a post-perfusion bleed, and we had to do a decompression. So why does it happen? It happens because of collaterals. You can extend your time, good collateralization, give that much time for you to remove the clot, because there'll be some amount of flow occurring through the collaterals to the penumbra area, so that it can help you to have less outcomes, bad outcomes in these cases. The jury is out in posterior circulation strokes. There are quite a few trials which didn't show difference in the outcome for those who underwent mechanical thrombectomy for basilar occlusions. But there is a subgroup of patients who have a higher NHS of more than 10 had a better outcome versus those who did not undergo a procedure at 90 days, MRS. Most of the outcomes are based on 90 days for thrombectomies in these kind of posterior circulation strokes. This is just one picture which I would like to show you. This lady came in 16 hours. There was a upper basilar occlusion, thrombectomy, stent, as you can see on the left side, is placed, thrombectomy done on 2 passes, and there was a good revascularization. What about the other way? Should you go to the patient to treat? This was a trial which I was associated with a missed trial, wherein the treating team would go to the hospital where the patient has been based and then do the procedure, or ship the patient to a mothership, or give IVTP and then ship. So there was no difference in the outcome with the study which was done in Catalan, but the NYC missed trial showed that there was a better outcome in actually going to a center to do the procedure than shifting these. This is what we usually see. There are in the West, wherein there is a mobile surgical unit which does the pre-op basic scan to see whether there's a bleed or not, gives the intravenous TP at the site after doing preliminary blood tests. And there are a few centers in India. I think there's one in Gujarat which has it, which does this. So it saves time, gives IVTP, and then shifts the patient to a center wherein you can actually intervene on this patient. So doing that has found to have a better outcome in all these patients. This is one case which I'll show you. This patient was enjoying himself in a mall. He had a dissection after these falls. Maybe there was a flap with a clot. We went about, removed the clot, and that person was actually given preliminary treatment in the mall itself, and then in the ambulance in the mall, and then shifted to a hospital, and then he had a good outcome. You can use 2 stents to retrieve a clot. Suppose there's a clot in 2 of the branches of the middle cerebral artery. You can have devices which go as distally as possible. So what is the guideline that we follow? Less than 3 hours, shift the patient immediately to a scan center, get the non-contrast CT, no bleed, plan for angiogram and thrombectomy. 3 to 6 hours, get a CT angio, and beyond 6 hours, do perfusion imaging. See, that is helpful. So for the first thing, there's level class 1 evidence for an early stroke within 6 hours, but for between 6 to 24 hours with perfusion imaging, again, it is class 1 level B evidence. These are distal clots, which I again showed you earlier. Artificial intelligence stroke has come to play a big role. Perfusion imaging is fed into the system, and that is relayed to your mobiles, and the stroke team can take a decision on whether to operate or not. And this has found that 50% of all strokes which would have been missed conventionally by actually looking for the imaging can be intervened on by using artificial intelligence, which would pick up these strokes at a very early stage. So beyond that, beyond 24 hours, we still need to work on it. This is stretching, as I said, a little too much, but then nobody, from taking it from an area wherein you reach the edge of the atmosphere, you want to leave no one behind. So God, we only hope that we don't stretch the limits too much and cause more problems rather than trying to save these patients. Thank you.
Yeah, thank you, Dr. Sunil, for the excellent presentation. And I'd like if anybody else has any questions, yeah, Dr. Uday.
It's very Yes, suppose you have background images which are compatible with the apps, not a problem. The company which was there is one of the pioneers is Rapid AI. So that was the pioneer. I think there's one called iStroke or InStroke, which is another app. Yeah.
But all of them are paid apps.
They're all paid apps,
Free.
yeah.
Rapid AI is a paid one.
Very costly license.
Once a month. But Sanjeev wants.
You are a world-class neurosurgeon and you are very well versed with the endovascular and open thing. I have one question for a very long time and till now I have not got any answers from anywhere. You do mechanical thrombectomy after 3 hour or 4 hour onset of stroke, and now even you are stretching out up to 24 hours. But in our experience, when we are doing the aneurysm surgery, and when we are putting a temporary clip, and 3-4 minutes is such a huge havoc. And if you have listened the talk of Dr. Salim Abdul Rauf, he shows that even the few seconds of temporary clipping can produce a clinical deficit when you are operating without anesthesia. So how it is different in both ways?
One would be because not all patients who have undergone mechanical thrombectomy are not without deficits. They do not dramatically improve. They take time to improve. Some of them may be dramatic, but what would probably be based on is the collateral circulation. You have a good pile collateral circulation, which would probably give that much time to that area to kind of have some sort of a buffer till you do the mechanical thrombectomy. When it comes to any aneurysm surgery, again, the collaterals would probably play a big role. Applying clips again off and on would probably give that much time for the brain to recover rather than keeping it for a long time. Many of them, if you see the post-op scans, would have some focus of an infarction, especially in the basal ganglia and the thalamus, and they take time to recover. Suppose it's in the basal ganglia extending to the internal capsule, those strokes will take more time to recover. It's not that these images are stroke-free in the post-op imaging. They have a lot of infarcts which have already set in. What really tells you how much of brain is actually involved is based on the collaterals. Yeah.
Yeah, means as you said, 30% recanalization rate, is it?
Yes, 30%.
But how many percent is clinically improved?
I think
that's what many of when all presentations they will tell 30% recanalization, but what percentage of functional recovery?
If you see the trial which was done, which was with the Mr. Clean and the MRS is done at 90 days. Okay, so there was a 15% difference in those who had 15 times difference in those who underwent the mechanical thrombectomy versus those who were medically managed.
No, my question is not comparison with medical and the procedure. My question is, if you do 100 thrombectomies, 30% are recanalized, but how many clinically
recanalized?
So now, how many clinically recover? And that percentage will be similar to the vasospasm. So how many clinically recover? That is what is important.
You actually base it on the MRS, so I don't have the details in that. Yeah.
Depends upon the profile of the patient, what is the patient. But generalized, because of the regionalized,
60.
The 70 is getting up to a 90% getting faster. But when we translate it to the clinical outcome, this clinical outcome goes of the recanalized patient, 50 to 57% of the patients, they will have a better, good outcome of MRS 0 to 2 at the end of 3 months. So, at the discharge, I would say we don't have, I don't remember the data, but we have those data also. The data would be around 40%, 30 to 40%. Most of these patients we also see, as Dr. Sanjeev was telling about this temporary clip. So we do same apply with our balloons. We sometimes inflate the balloon for 5 minutes, 6 minutes. We do a thing. It's almost like a temporary clip application. And very rarely do we see clinical deficits post balloon usage.
So it will amount to similar statistics, what we get in aneurysm vasospasm. Because we always talk of 3 months. We think of at discharge at 1 week. We go for the next paper. Can we call the next presenter?
Next, we have Dr. Tariq Mateen, who is a neurosurgeon in Gurugram with more than 20 years of experience. Now, I would like to call him to take lecture on the topic recurrences in endovascular treatment of aneurysm. Please, sir.
Thank you for the introduction. Thank you, chairpersons. So a correction from my part, I'm not a neurosurgeon, I'm a neurointerventionist. And I'm associated with the Artemis Hospital, Gurgaon. Just to the previous talk till the time it is set up, it's a revolution. Overwhelming evidences have come for a large core. Now we are moving to the next frontier. Dr. Sunil's talk, I'm concluding with that. With the next frontier for us is low NIHSs. We are dealing with low NIHSs. Probably we will very soon have the data pertaining to the low NIHSs thrombectomies. Now we'll go from an aneurysm recurrence. This is what we, as a neurointerventionist, we keep on hearing. Your aneurysm treatment is not durable. It keeps on coming back. You need to treat it, retreat it. There are rebleeding rates associated with it. So I'm trying to give my perspective on that. That's my disclosures. 2023 guidelines, they say treatment within 24 hours is preferable, class 1. Complete obliteration is preferable to reduce the risk of bleeding. It's reasonable to retreat a partial obliterated subarachnoid to prevent rebleeding, class 2A. Just a case, adjoining case where the surgical treatment was not possible because of the comorbidities. She happened to be known to Dr. Anil from a known family member from the from one of the prominent neurosurgeon. So we took a decision, collective decision. We treated it partially. We know we have to come back and retreat this because the PCOM is not completely. PCOM tends to come back. Because of their anatomical location, this aneurysm is going to come back. Though we have evolved, just to show the armamentarium has evolved. We can do Y, we can do web, we can do endosaccular. In fact, the last case you can see, the last slide, we can flow divert a pica. The pica has been flow diverted, a dissecting aneurysm in the pica, which was flow diverted. So the things are evolving, and the guideline is tilting. This is 2023 guideline. coil, these are the anterior circulation guidelines, the posterior circulation guidelines, wide neck fusiform guideline. This is the slide taken from the Stroke Association. And the treatment, again, the same presentation. The guidelines are tilting, that we have to acknowledge. But there is recurrence. We can't put the things under carpet and then say, okay, it is a safer way of treating, but no, we can't address the recurrences. There are recurrences. We have to address the recurrences. Now we go back to the tabulated version of data. Yes, we see recurrences happening. Will not go in the interest of time. But as we keep on scrolling this data, we came to these two papers. This is 2010 and 2023. The recurrence has gone down from 9.1. These are papers 9.1 to 3.6%. What happened in these two papers? So what was changed? More experience, this refinement of techniques, the better strategy, the better hardware. The coils, yes, nobody talks about the coil. The coil has evolved a lot. Use of newer techniques. And in the second paper, 2023 paper, more than 80% of the aneurysm were coiled with assistance. The remodeling technique was used. So we are going through this Kruger's curve. From there, we are reaching the plateau of sustainability, the plateau of the enlightenment, where we say, okay, we have plateaued, but still we need to go further to have an outcome which matches the scenario. As Dr. Sunil's talk was just before preceding it, it shows a revolution in the endovascular, in the acute ischemic stroke, a paradigm shift. Similar has not happened in the aneurysm treatment because we have got a very robust modality, the clipping, which we need to compete. We need to prove that we are better than that. So, we'll try to forage into some clipping data. There are recurrences in the clipping. This is one of the clipping paper, which says there are, yes, it's lesser than the endovascular arm. The clipping, it can be a pre-exist if the clips are not applied properly, or there is a pre-existing weakness, or the slipping of the clip, or it can be an existing comorbid condition associated with the patient, which can cause the aneurysm to recur. So almost it's like a improper applied clip or the slipping. It's inadequate packing of an aneurysm. It's almost equal to that, where we pack the aneurysm inadequately and the neck comes back or the clip is down below there. So, sorry. ACOM, clipped, recurred. Similarly, we have got a SC aneurysm, loosely packed, recurred. So when we are comparing an inadequately clipped aneurysm with an inadequately coiled aneurysm, the comparison has to be on a similar front. It has to be the inadequacy, yes, but despite there are some aneurysms which tend to come back and again. This basilar aneurysm that was coiled very well, but has recurred. Most important cause, but when we see, is the completeness of the procedure. If we see this aneurysm and ACOM, we are trying to coil. The first coil is a very important way to determine whether we are going to have a recurrence or not. And then we need to coil. This is a roadmap. This is where our new coils are going to give in. We need to pack the neck, the inflow zone tight, and we need to pack with the coils which can prevent recurrences. So all the nicks and tiny bits and pieces of the aneurysm sac has to be coiled. The metal has to go inside it. It's the length of the metal and how you put in the metal that has to go in. So complete aneurysm has to be completely coiled before we saying that, yes, we have got a recurrence, because we have not done a great job. And it's an inadequate coiling which have got a recurrences there. So this is a RNR occlusion rates. Everyone is aware about it. But my submission is that class 3B and class 2R the aneurysms which should be followed. 3A will go off. 1, we don't worry. But 3B and the class 2, they need to be followed up very stringently. These are the how a 3A and 2 looks like. We'll just pass it. Now, as we are moving towards an saccular to endoluminal, we have got an occlusion criteria looking for a endoluminal devices. These are the criteria which are there. We'll not go into detail. Just see a complex MC aneurysm. A lot of branches coming from all around. Ruptured one. This was a ruptured one. Device put. Everything is reconstructed. This is the aneurysm. This is the device. And this is 6 months. And then subsequently, this patient was having a contralateral aneurysm. Again, the device put. So we have almost got a 3 months follow-up of this patient, 3 years follow-up of this patient. And we have got bilaterally same symmetrical aneurysm, healed well, remodeling happened. A young girl with a fusiform dissecting aneurysm of distal ACA, healed, but there is a small residual. Probably that is going to remain there because we have got this artery to fill. So we will take it as a complete occlusion because if we go by that, it's a class 5B occlusion what we got. So from moving to recurrence, we are moving to a more relevant terminology, which is known as target aneurysm recurrence, which means that was 2015 AGNR paper, that target aneurysm rupture happened, a sudden unexplained death happening in that patient in the follow-up, or a target aneurysm is required a retreatment procedure. So then we say it is a TAR which has happened, which is taken as a TAR. Why adequate occlusion is inadequate? Because most of the time it is self-reported. It is a self-assessed thing. Okay, this occlusion, what we have done is an adequate occlusion. Probably we may not have done a complete occlusion. The recognizing complete aneurysm occlusion after coiling is only achieved half of the time or less. We are inadequately coiling. Probably that is the first word. Creep into the literature. The concept of adequate occlusion, wherein complete occlusions and neck remnants are lumped together as an adequate occlusion. So we are taking most of the inadequate one as an adequate occlusion, and later on when they bleed, we say, okay, we got a failure. We have treated and we have to start with done half a job. We have not done the complete job before that. The last point is very important. The concept based on the intuitively attractive but unproven assumption that rehemorrhage is exceedingly rare in aneurysms that have neck remnants but no residual filling of the aneurysm sac. We'll rush through it. So, a case, a sac, big aneurysm, neck, we are coiling it. If suppose we coil it till here, we will have a remnant. We need to coil till the inflow zone. So it has to be packed. It has to be packed this dense. This amount of metal has to be there. Still we can have a recurrence. Again, a aneurysm coil, same aneurysm, SCA, it has got a recurrence. We'll not go into this with the short of the time. We'll again, whenever we are just a case, ACOM rupture, ACOM is smooth. There is a small nubbin near the neck rupture. If we leave this small neck, we will have a rehemorrhage. We are going to just coil the primary sac, we will have a rehemorrhage. So this was the primary sac was coiled, and this subsequently we went inside the secondary sac. This is the secondary sac which has been coiled. We need to secure this. If we have left this small one, we have not seen that this aneurysm probably have re-ruptured in the coming months, and we would say we have got a failure of the treatment. So identifying the morphology, the aneurysm sac, and treating it completely, every nicks and bits has to be done. Then using the different coil technology. Probably there are some coils which reduce recanalization. These are one of the coated coils. We'll not go into detail. These are few of our cases with those coated coils, extra large coils that again using a devices, the endoluminal devices. When we started a decade back using endoluminal device, because that incorporates using a mandatory double antiplatelet, which was a very fearsome thing for us. Now, as we came to understand the pharmacology of these medicines and using this inhibitors, the GP2B, the IV inhibitors, we have gained a lot of confidence in controlling this device to happen. This is a half T stent, this is Y stent, and various ways of doing it. Again, we'll not go into that. We'll cut it short. These are the results of the big, large aneurysms, just a follow-up of the few of the aneurysms what we want to check on it. Devices, again, when we are using the devices, the first web when we used, we were not sure. We were just trying to size it. Now we know. We can play with a web device. We can have a good stable result. We can do a compression maneuver, which can give us a better result. So as we are evolving, we are trying to get, but still, we will have a retreatment. This is one of the aneurysm MCA which recurred, we retreated. This is one of the aneurysm again recurred. There are certain aneurysms, say P1 dissecting aneurysm, we coiled it, we stent coiled it, again recurred. Then we subsequently put a FD inside the stent, and almost 3 years of follow-up has happened. We have got a stable result. This is one of a giant ACOM where we have put the FD with coil, recurred, balloon plasty, again a second FD, still recurrent. So there are certain cases where we fail. One of the last case to sum up, a ruptured MCA. Again, 3 clips were applied. All of those 3 clips missed the MCA. The surgeon was good, but probably the brain at that time was quite tense. We coiled it with an stent assistance. But these things happen on the other side also. There are sides where we coil and there are huge recurrences, re-ruptures, which happen. The data available us with is a very haphazard. We are not able to combine it. Number of patients since 2011 to 23, what we combined was 1209. We are trying to compile it. Number of aneurysm we dealt is 1523. 5 year or more, just 423 follow-ups we have got. 43 patients have got TARS, that's an aneurysm rupture, with 13 mortality of patients who have got a more than 5-year follow-up. So the man, machine, and tools are evolving. Data in the quoted literature are lagging because when we are comparing these data, they are of the things of 10 years back. A decade is a long time. There's a huge evolution has happened. Nevertheless, aim is the better patient outcome. Criticism should challenge one to step up. We try to take this bull by horn, probably got hurt, but still we will try. This is our team. Thank you for your patience here.
Thank you, sir.
Anybody want to ask any questions? Some of your comments?
So we'll ask you during lunchtime. Thank you for at least you presented like a surgeon, not like a radiologist.
Actually, first time I have seen any interventionist accepting that there are recurrence and there are complications, there are deaths.
Yeah.
Otherwise, we have only seen the good side of the story till now.
Can you please call the next speaker?
Next, we have Dr. Parthasarathy Datta. He's a highly skilled neurosurgeon with over 27 years of experience. I welcome him to take a lecture on the topic GAN aneurysms.
I congratulate KVB Neurocon organizers and Professor Devabrata Sahana for the kind invitation. So, talking about these giant aneurysms, so this is my hospital. We know all these facts that this giant aneurysm has 25 millimeter of diameter. And all these things, we have various surgical techniques like direct clipping, occlusion, wrapping, trapping. We have various endovascular techniques, the stents, coils, polymers. There is combination of microsurgery and endovascular techniques where one assists the other. Various evolving techniques are there, the skull-base approaches, adenosine-induced cardiac standstill, rapid ventricular pacing, then endoscope assistance. But with all these adjuncts, where do we stand now? Whether we are still in a stage to say that we can treat all patients. So I present few cases. So my first case is a giant ACOM aneurysm, and this patient presented with unilateral loss of vision, and this is the DSA post-op. So for this aneurysm, we did a direct clipping as there was a very nice neck and the aneurysm was situated in a very anatomically clippable area. And this is the patient in the post-op period. Now coming to the next case, this is a giant MCI aneurysm in a young female who presented with one-sided weakness. Now, this is the pre-op DSA. This aneurysm had a wide base, but this aneurysm was clip reconstructed with multiple clips, and the patient did well after the procedure. This is another giant MCI aneurysm, and this aneurysm was simply excised. Aneurysm excision was done, and this is the post-operative angio. Coming to the fourth case, this is another giant MCI aneurysm. For this, we did trapping and bypass. So this is the post-op DSA. This case was admitted on the day I left from Kolkata. So still not treated, but just I collected this photo for presentation. Sixth case, this is a 64-year male who presented with headache and drowsiness. And this is the CT angio picture. This is the 3D reconstruction. This is the DSA. So for this aneurysm, what is the option? We explored various options. First, we thought that we can place two diverging Y stents from the basilar into the two PCAs. But this was not possible because the PCAs were very thin. As you can recognize from the DSA, the PCAs were very thin and there was a thick clot within the fundus. So the devices could not be negotiated from the basilar to the PCA. So this option was not possible. We came to the second option. The second option was direct clipping of the basilar artery, but when we saw the anterior circulation, it was not completely filling the posterior circulation. So direct clipping of the basilar trunk was not possible in this case. So the third option was direct clipping of the basilar trunk and one-sided PCA STA bypass. So we did a posterior subtemporal approach, exposed the basilar and PCA, but intraoperatively we found that the PCAs were very thin and in the deep location
the bypass was not possible. So we came to the fourth option. The fourth option was we coiled the aneurysm not very compact way with the idea that aneurysm thromboses gradually, posterior circulation remains patent, and gradual development of the collaterals occur. And this patient was next subjected to VP shunt for the hydrocephalus, but developed no neurological deficit after the procedure, and he was well till 1 week, but developed a respiratory distress and drowsiness after 1 week, for which he was intubated, ventilated, and tracheostomized. He was gradually weaned from the ventilator and tracheostomy and shifted to bed, general bed for rehabilitation, and he was found pulseless in one morning. So what may be the causes? It may be delayed aneurysm rupture, it may be progressive hydrocephalus, or brainstem compression. We do not know exactly what happened. Coming to my last case. This is a 26 years male who visited almost all the hospitals of this part of the country and came to us with severe headache and complete blindness in both eyes. He was completely blind in both eyes. So this is the MRI picture. And this is a CT angio, 3D CT angio. With the DSA of this patient, this is right carotid, one picture is right carotid injection, another picture is left carotid injection. I'm again playing the DSA. One is right carotid injection, another is left carotid injection. Both the carotid are entering into the lesion. So what may be this lesion? Is it a highly vascular tumor? Is it an AVM or it is a giant aneurysm? We do not know. What are the options? Microsurgery, endovascular, or radiosurgery? We do not know. So to confess, not to conclude, even in this era of modern microneurosurgery, still in some cases we have no answer. So this is my team. I thank you all for hearing.
That's a possible to comment.
No, I know Dr. Parthasarathi for a long time, and he has Manas is one, he's one enthusiastic person in Calcutta who wants to learn, who wants to, no matter how senior he is, he still wants to learn, still wants to do. I think this kind of personality is a very fantastic personality. As far as the cases you have shown, all cases are beautiful cases, all cases are difficult and dangerous cases. The one you showed last, that vascular lesion where you were struggling, whether it is AVM, whether it is tumor, whether it is aneurysm of a different kind. It did look like a tumor to me because, I didn't see any draining vein, big, large draining vein from the whole system. I didn't see it very nicely or properly, but I thought, what do you think, Manas? What do you think? Can you show that case again?
Yes,
if you have time.
These are the MRI pictures.
No, it is not.
Next.
These are MRI pictures. This is 3D CT angio.
Show the regular angio. See in this, you see, Manas, if you may see in this case, there is no big, large, huge draining vein. Where is the draining vein? AVM will have a big draining vein, superior striatal sinus, or somewhere there will be a draining vein. I don't see any. So you have not done anything here, or you have done something here?
No, this patient, I left and he went to all the hospitals in the country and then returned to me again.
Okay.
So I operated this case.
You operated some, yeah.
Yes, I operated this case, but I could not control the bleeding at the last moment. So
what was it finally?
It was a huge vascular mass. Wherever I am going, I am finding a wall, and within that wall there is some the blood is coming. I am coagulating that part, going to another area. Again, a wall, and I am coagulating that wall, and within that I am seeing that there is a huge gush of blood. So in that way, I tried to go around the periphery of this lesion, but huge blood loss. Anesthetists were not very much, they are reluctant, they are telling the stop the procedure, and then ultimately patient could not survive.
Was it a tumor, or did you get some histology, or you didn't get it?
No, we could not get any histology, but to me it was not a tumor, it was really a vascular lesion. AVM like that.
It was a challenging case, but if it was an AVM, then one could have developed some strategy to resect it. See, on the other hand, you know what I'll tell you, Parsati. AVM is one condition, which I always say is the last chapter of neurosurgery, last chapter, where you have to have anatomical understanding, where you have to have your own technical mastery. The third and foremost is your supreme confidence in the lesion, that you can resect it. If you are going to resect this lesion, you have to have confidence before operation that yes, it is possible. You cannot go with a feeling that very difficult, may not be yes, no, or yes, no. This is one lesion where you have to understand your own technical mastery, your own. You cannot say patient has come with a consent, so let me do it. Relatives are giving consent, so let me do it. These kind of things will not work here. Unless and until you know the lesion, unless and until you know that you can resect it, unless and until you know it is AVM and it is not a tumor, or you know it is a tumor and not an AVM, I think I don't know what to say, but Manas will say something about it. Manas.
No, means here the diagnosis was in doubt, but the learning point is if you get a similar case next time, what has to be done? Whether we send for if the patient is asymptomatic, whether we leave it alone, or if it's symptomatic, whether we think of non-surgical methods like radiation and all those. So that is what has to be explored in the literature. Because there's a lot of time, we'll call for the next presenter.
Up next, we have Dr. Jayanand Sudhir, who is cerebrovascular neurosurgeon, who will be presenting on two topics. The first one being novel insights into innovative pathogenesis and surgery, and the second one being mathematics of cerebral aneurysm, CFT, and other formulae. Please, sir.
Good afternoon, respected chairpersons and my dear friends. I must thank Dr. Aip and my friend Dr. Debabrata Sahana for having invited me to this conference. There are two topics I would like to share with today. One is the mathematics of cerebral aneurysms, CFD and other formulae. So this topic is possibly the cleaner side of vascular neurosurgery, because you don't really have to deal much with blood. And my next talk, I'll be going through some uncharted territories of managing moya-moya angiopathy. So this work is done in collaboration with the Indian Institute of Technology, Madras, and these are the funding statements. So I'll be taking you through an overview of how we use computational fluid dynamics and simulation studies to understand blood flow in aneurysms and how they they are involved in the hemodynamics and as well as how the wall properties of the aneurysms are also taken into consideration in the simulation studies. So for that, we have specialized techniques called fluid structure interactions. And we also try to take some other basic concepts from mathematics and basic sciences to try to understand the mechanics of how aneurysms behave. So for that, we have used natural frequency and we also used Murray's law, which I'll be talking to you about. So these are the plethora of lesions that we deal with: aneurysms, bypass surgeries, and arteriovenous malformations. These form the mainstay of cerebrovascular surgery. So CFD studies, as you say, this is an MC aneurysm that I was operating, and this is the kind of flow that we often see on the operative field. That's why I was saying the cleaner side of it is the computational fluid dynamics, because we don't have to directly deal with the blood. And definitely these are familiar clinical situations where we are still in doubt whether to operate a patient with an unruptured aneurysm when he comes to the OPD. And we always rely on these, we always base our decisions based on the cumulative statistical data based on the size, shape, race, age. You are all familiar with the FACES score that is come up in literature. And but still nothing is specific to the aneurysm as such. Rather, we are dealing with pooled statistics as well as the comorbid conditions. Now, these are all familiar from literature, size characteristics of the aneurysm, which we assess to understand the risk of rupture. But what I'm going to take you through is the hemodynamic parameters, that is wall shear stress mainly, that is a tangential force that the blood exerts while it flows through the blood vessels. So this is the basics of wall shear stress. You can see that, I'll just take the pointer. So if this is the inflow blood and these are the outlets, so you can see that blood will impinge into the fundus of the aneurysm at this point, and beyond that you can see these arrows represent how the blood actually flows. So around these regions where the maximum impact occurs, that's where the high wall shear stress regions exist, and those distal to the site of impact will have lower wall shear stress regions. Now, this wall shear stress is actually a physiological phenomenon that is essential for maintenance of homeostasis in the vascular wall between the flowing blood and the vessel wall. Now, the aneurysms possibly develop in an attempt to normalize the wall shear stress by expansion, so that as they expand, the wall shear stress comes to normal in the areas of impact by the impinging bloodstream. Now, these are physiological normal values of wall shear stress according to the blood vessels. And in these studies that we do with simulation, there are many terminologies that we use: wall shear stress, maximum wall shear stress, the gradient between the high and the low wall shear stress regions, the time average wall shear stress that takes us through these values through the cardiac cycle, oscillatory wall shear stress, that is the between the systolic and the diastolic parts of the cardiac cycle, the relative residence time, that is how much the time the blood particles actually spend time within a particular region, as well as how these wall shear stress vectors diverge from certain points on the aneurysm fundus. So this is a workflow. We take the DICOM images either from CT angio or DSA and then process them to extract the geometry as such with the inlet and the outlets, and then we use commercial software to do these simulations. And we have access to the National Supercomputing Mission at IIT Kanpur, as well as we also rely on small workstations that we use in our laboratories. And these are the kind of results that we get. These are the pressure plots on the aneurysm. This is an MCA bifurcation aneurysm. You can see the pressure and the daughter blood building up. So that could mean impending rupture. And also you have these wall shear stress maps, as well as you can visualize how these flow streamlines evolve within the aneurysm. We published certain literature way back in 2014 as well. So now we are going into how to understand how to extract the wall properties as well when we do these simulation studies. For now, we have been using only the blood flow domain within these aneurysms, and now we are trying to extract the wall properties as well. So for that, we use computational methods to generate a wall around this fluid shell. And we have also been able to develop variable wall thickness. You can see the uniform wall thickness here, and we are also been able to generate variable wall thickness and do these simulations. We also published such results here with basilar top aneurysms. And we also done what is called turbulence modeling to try to understand how turbulent the blood flow is within these aneurysms as well as in the inlet and outlet, and to see whether they have any bearing on aneurysm rupture characteristics. We also delved deeply into morphological characteristics of these aneurysms and found certain parameters that could be helpful in understanding why certain aneurysms rupture. We also looked in the tortuosity of the ICA to see whether proximal or distal IC aneurysms have any bearing on the tortuosity of these blood vessels, and we found positive results. We published this work on the influence of carotid tortuosity on the hemodynamics of aneurysms. Now, we also studied how this asymmetricity of the ACAs influenced the development of ACOM aneurysms. Some of these, the anatomical variations may be responsible for development of aneurysms. As you know, the A1s may be asymmetric, but sometimes symmetric A1s also may develop aneurysms, and we try to find answers to why this happens. So this is a situation where we have symmetric A1s, and we also have compared it with asymmetric A1s. You can see a very hyperplastic A1 here and a large A1 here. And these are flow simulations in these symmetric and asymmetric A1s. And we are just in the process of formulating these results, and we did publish some preliminary work on this in ASME journals. And to encompass all the morphological parameters together, most of these are 2D parameters. You have this the aspect ratio or dome height ratio and other things that are 2D ratios. We also have 3D parameters like the ellipticity index, non-sphericity index, which could encompass the 3D structure of the aneurysm to find whether there is any relationship between morphology and the rupture risk of an aneurysm. In this domain, we looked at natural frequency, which is a basic physics concept, and tried to understand whether natural frequency of these aneurysms, when they are extracted as a structure, have a bearing on the rupture potential of aneurysms. And we found that the natural frequency of aneurysms actually was able to classify unruptured and ruptured aneurysms. And we also published this work in the Journal of Engineering and Medicine. And ongoing research, we have tried to use Murray's law, which was actually published in 1926, and that is almost 98 years back. So this relates to the fact that the cube of the parent vessel diameter is equal to the sum of the cubes of the diameters of the branches. So we tried to get the diameter ratio of bifurcation aneurysms, and you can see how beautifully we are able to classify aneurysms that are less than 5 millimeters, which are ruptured, from aneurysms that are greater than 5 millimeters. We are just compiling the results here, and we'll be soon publishing this. We also are looking into wall shear stress divergence. You can see these points that are moving during the cardiac cycle. During the you can actually see which all areas of the aneurysm wall are under severe stress during the cardiac cycle. And we also looked at evolution of aneurysms. We have reduced the aneurysm in the parent vessel to the non-native vessel through computational methods and try to understand why aneurysms develop at these points. And of late, we also extracted aneurysm tissue and subjected them to histopathological sectioning. We have created multiple slides and tried to reassimilate those slides and put it on as a cap over the fluid domain, trying to give a patient specificity to the aneurysm wall, and then doing the fluid structure interaction studies. Now, this is a giant in IC aneurysm, and what we did was a IMAX to MCA bypass. And in this case, you can see the internal maxillary artery having been grafted to the having been connected to a radial artery graft given to the distal MCA, and flow was reversed into the MCA, and you can see how the aneurysm has got thrombosed. And we also subjected this case to computational fluid studies, and you can see this is a pre-op CFD picture showing how the aneurysm is filling. The immediate post-op situation, that is a processed image. You have the pre-op as well as the post-op image. So we have fused these images to generate a post-op scenario to see that the flow has actually got quelled within the aneurysm. And this is 3 months after the surgery. You can see how the flow has streamlined and the aneurysm has thrombosed. This is the team that I'm working with in neurosurgery department, and also the team at IIT Madras as well as Indian Institute of Science and Technology at Trivandrum. And my radiology colleague, Dr. Santosh, is also involved. Thank you very much. Now, I'll also talk about Moya Maya. So we are all familiar with Moya Moya angiopathy and that the surgery for Moya Moya is revascularization. Both the direct and indirect revascularization strategies have been adopted, and many studies are available in literature that say that both are equally good. Only thing that the combined revascularization will help in alleviating symptoms of Moya Moya earlier than indirect revascularization. In the long term, both these procedures have comparable results. We have at Sri Chitra, we have a team comprising the neurologists, the stroke neurologists, the neuroradiologists, and the neuroanesthetists, as well as the neurosurgery team. So this is through the history of Moya Moya disease, where Suzuki and Takako initially described this disease in the 1950s and 1960s. And progressively, the caseload has been increasing. And there are many terms that are confusing: Moya Moya disease, Moya Moya syndrome, quasi Moya Moya. But I would prefer the term Moya Moya angiopathy because we believe that the pathogenesis of both Moya Moya disease as well as syndrome are the one and the same, that results in the distal occlusion of ICA, resulting in collateralization. So these are 2021 diagnostic criteria by the Japanese groups. But so far in literature, we have not found much. This is the theory that we have proposed in 2021, the mechanobiological theory of Moya Moya, where we have unified both Moya Moya disease as well as Moya Moya syndrome. And this is a complex pathways that ultimately lead to an increase in the tissue inhibitors, decrease in tissue inhibitors of matrix metalloproteinases and the increase in matrix metalloproteinases. So this imbalance is the one that, So this imbalance is the one that is possibly responsible for the genesis of Moya Moya angiopathy. And this came in 2011. So much hype has been generated about RNF213 gene as a pathogenic mechanism for Moya Moya. But the truth is that only 1 in 150 carriers of an RNF213 mutation actually develop Moya Moya. So there is possibility that there is another factor that could explain this low penetrance of this gene. So here is our proposal in 2023. Arsenic is probably the catalyst for genesis of Moya Moya. And this is what we have published in Medical Hypothesis Journal. So coming to the essence of today's discussion, it's patient management decisions. And these are the questions I would like to answer. In bilateral ischemic Moya Moya angiopathy, which side should be operated first? What is the surgical procedure that should be performed? What should be the interval between the surgeries? In hemorrhagic Moya Moya, what is the surgical procedure to be performed? Bilateral hemorrhagic Moya Moya, which side would you operate first? What should be the management strategy for unstable Moya Moya? And whether surgery has a definite role over medical management, or is medical management actually necessary? So I'll classify it into ischemic and hemorrhagic Moya Moya. So for ischemic Moya Moya, I have this table that is based on the Suzuki stage, Suzuki 1 to 6. But the fact is that the Suzuki stage 1 to 6 actually does not correlate with the symptomatology of these patients. You can have fully asymptomatic stage 6 as well as fully symptomatic stage 1 disease. So you can see the pattern here that is developing. The ICA MCA supply is progressively going down the stages from 2 to 5. The Moya Moya collaterals initially increase up to stage 3 and then decrease. As the Moya Moya collaterals decrease, the ECA collaterals through the middle meningeal artery or the ethmoidal vessels slowly increase. So we also try to look at symptoms and MR perfusion and then decide on surgery. So this is the overall framework on which we are going to rely on, depending on symptomatology, MR perfusion, and revascularization surgery, whether it is required or not. And there are some exemptions to this, and I would like to go through those case scenarios. This 11-year-old boy, he has a stage 4 on the left side, but a stage 1 on the right side. So the MR perfusion study showed a decreased perfusion on the left side, and we took up the case for a left STMC bypass with indirect procedure. And in the postoperative period on the day 2, when the child became dehydrated, he developed watershed infarcts on the right side, which was deemed normal. So why did this patient develop a watershed infarct on the right side? definitely as per guidelines, he doesn't require a surgery on the right side. But this is possibly one clue that we found, that the angle between the cavernous and supraclinoid ICA is higher in this case, and possibly the mechanobiological theory works here. The ICA is remaining turgid because of the blood flow within it, and when the child was dehydrated, possibly resulted in a flopping of the vessel, resulting in the watershed infarct. Now, for stage 2, 3, and 4, the decisions are almost straightforward. So here we have a stage 3 moya in a 28-year-old lady. You have the hyperperfusion regions on the brain, and that will guide you where you need to do the revascularization procedure. And so it's all through green. There is no doubt with it. So it is stage 2, 3, and 4. There is no doubt. Yes, you have to do this revascularization surgery based on the MR perfusion. You can use it as a guidance for where and what procedure you do. Now, stage 5, you can have patients with global hyperperfusion, but remaining is but symptomatic. So we had a 7-year-old boy, bilateral Suzuki stage 5, and you can see the angiogram showing the middle meningeal artery going up there and then coming down as falcine arteries and supplying the cortex over here. So you can see it has split into 2. Now, in this situation, if you're going to do a revascular, this is the STA, port parietal branch. If you're going to do a STMC bypass, you have a possibility that if you do a craniotomy here, you can cut this middle meningeal artery that could lead to a compromise in the collateral circulation. So this is what we do. We try to mark out the STA and the middle meningeal artery on the scalp of the patient during the surgery, and then we tailor our the bypass, the revascularization procedures so as not to injure the middle meningeal artery. So here we would harvest the STA from around here, go up and do a craniotomy more based posterior-inferiorly than anteriorly, in an attempt to preserve the middle meningeal artery. So that will be our incisions, and that is definitely guided by the MR perfusion. So this is the MR perfusion image. You can see those hyperperfused regions of the brain. It's almost blue now. Now, this is another stage 6 moya, normal perfusion on that side, asymptomatic. So here we have done the STMC bypass on one side, which was symptomatic, stage 4. But the stage 6, the perfusion is near normal. Child is asymptomatic for that hemisphere. So we have kept the child on follow-up. You can see the collateralization through the middle meningeal artery, taking in through the falcine artery, as well as the ophthalmic artery is also supplying parts of the brain. So we have kept this on follow-up. Stage 6 hyperperfused symptomatic. So we had a 10-year-old boy, left side stage 5, right side Suzuki stage 6. So he had bilateral frontoparietal hypoperfusion. We did a left combined revascularization in September 2023, but the scan shows that this is not functioning, but the child is asymptomatic. But the perfusion scan showed that even though we had done EDAMS, the frontal region was still hyperperfused. So we went in for a customized procedure. We reoperated the right side with a large frontal EDAMS, and we did a frontal and parieto-occipital EDAMS on the left side. So that's the one. Stage 6 symptomatic, MR perfusion is decreased. So we did a customized procedure for this patient. Now, there are 2 types of unstable moya that I would like to discuss. One is usually that occurs in stage 1. Stage 1, you would have a doubt whether the ICA is normal or there is only a small constriction of the ICA. So usually it's a diagnosis in a unilateral moya, wherein one side definitely you have a moya, you are doubtful what is actually happening at the right side. We have had patients who have a normal ICA but still are symptomatic on the normal appearing side. So this is one such patient, 30-year-old lady, bilateral moya. Left Suzuki stage 4, right Suzuki stage 1 is the radiologist diagnosis, but you can see the angiogram done in December 2023 is almost normal. The right ICA caliber is very good. You would not treat this as a moya. So this patient was kept on follow-up, and continued to develop right hemispheric TAAs. So this normal ICA, but still patient was developing right hemispheric TAAs. So 2 months back, we did an angiogram, and this is what we found. There's a mild constriction of the supraclinoid ICA, and that is possibly relating to a collapse of the ICA during states of hyperperfusion that is causing this recurrent TAAs. So the protocol for that is to defer surgery, to hydrate the patient very well, to stabilize until the symptoms stabilize, at least 6 weeks interval between the last TAA, before we reperfuse, but that is again guided by MR perfusion. If the perfusion is normal, we still have to wait. So the other type of unstable moya is in advanced moya cases, wherein we had patients who had frequent drop attacks but recovers in the supine position. So this is a 30-year-old lady who was doing PhD in the US, and this is what the MR perfusion showed. She has a blue brain, and I would call this a blue brain because almost the entire brain is blue in color, very poorly perfused brains. So this is what we did. We did a multi-territorial Adams indirect procedure on both sides with an interval of 3 months, and the patient recovered very well. So here in this chart, I would like to add unstable A at stage 1 and unstable B before stage 6. So in hemorrhagic moya, there are only two patterns of bleed that you can see. One is intraventricular bleed. This is a 38-year-old male who survived 2 bleeds. He was treated at a hospital where they put EVD, and then they found moya and referred the case to us. So this is what we found. There is only a mild hypoperfused area in the right parietal region. And because it was bilateral, we were confused which side to operate first. And the decision was based on this TOF MR angiogram. You look at the anastomotic channels, periventricular anastomotic channels, which are more prominent on this and almost protruding into the ventricle on the left side. And this is what guided us to do a left side procedure first before we did a right side procedure. So this is hemorrhagic moya 2, in which you can see the plethora of perforate region moya, and this perforate region is the one that caused bleed in this patient. It's an anterior temporal bleed. You can see the ischemic region is very minuscule, and this patient was taken up for surgery. So you have to target the side that has more perforators and the side of bleed in this type of bleed. Whereas in the intraventricular bleed patterns, you have to look at the periventricular anastomosis. The more prominent ones will be treated first, and it is always better to do a ST-MCA bypass in these cases. This will alter the hemodynamics, reduce the burden on these collaterals, and reduce the chance of hemorrhage. So we had 2 cases where moya was associated with aneurysm, and this was a 4-year-old child with a very slow filling ACOM aneurysm, and this we kept on follow-up. And this is another case, 1 year, 5-month-old child with moya, and she had a MC aneurysm. It was looking more dysplastic, and both these cases of aneurysms we kept on follow-up, and these so far have not bled, so possibly we are right. So between aspirin and water, I would choose water because hydration therapy is the best for moya patients. If you look at the history of any moya patients, the symptoms are related to episodes of dehydration or hypotension, and hence it is of prime importance to hydrate these patients both off and on surgery. So during perioperative period, postoperative period, we have to maintain good hydration of these patients. A few other innovations that we have done: strategic tunneling of the STA during bypass. We have tunneled the STA through the temporalis muscle for a shorter course to reach the surgical field. We also described this technique of knotting in the deep for deep microvascular surgery. This is my team at Sri Chitra. Thank you very much for your this. Yeah.
Yeah, thank you, Dr. Jayan. I think we're short of time. Right. We're hurrying up. Thank you. Yes.
Thank you, sir. Now let's call Dr. Kamlesh Singh to give a lecture on the topic Doling approach and clipping of paraclinoid aneurysm.
Thank you, organizers, for giving me opportunity. I will be presenting on clipping of paraclinoid aneurysms. As we all know, the C5, C6 segment of ICA is commonly known as paraclinoid aneurysms. And this aneurysm always excites us neurosurgeon. And this paraclinoid region includes area of around 1 centimeter cube, which is complex anatomy, which consists of antecular process,
dual rings, optic nerve, and small segment of ICA. So these aneurysms are always challenge to us, but with the advancement of endovascular therapy, neurosurgeons are getting lesser and less exposure for these aneurysms. So for these aneurysm, we need to practice more now because we are getting less cases. This is the typical picture taken for 7 aneurysms. What we see, C5, C6 segment obscured by anticlinal process and distal dual ring. And we have to negotiate all these anatomy for clipping of the aneurysms. So this is the Varami classification. We classify the paracrine aneurysm. But what are the surgical challenges we face to get, first to get a proximal control, to go beyond the aneurysm. And if the aneurysm are mostly of giant size, so clipping, application of clip may be difficult. And neck calcification, atherosclerosis and ICA makes job more complex. Negotiating anticlinal process, preservation of branches, and surrounding neurovascular structures. All these aneurysms factors increase complexity. So for these aneurysms, we should treat these aneurysms like a skull-base lesion as you usually do. Only a cystoidal approach may not get that good result, or we can sometimes have bad results also. So combining cystoidal and skull-base approaches for these aneurysms are best. So what we are doing at our setup, our institute, our team, we are following this approach, which Dollings had given a beautiful approach, which extradural and interdural stage to decompress and mobilize and unlock the middle cranial fossa structures for these beautiful 6 extradural and interdural structures. The unlocking of middle fossa, both extradurally and interdurally, very necessary before going for actual clipping of these aneurysms. I will show a small video. This was a 36-year-old lady. We can see a giant aneurysm in suprasellar region, medially directed. Patient had no deficits. I will show. This is being done after frontotomic orbitotomy, posterior orbitotomy being done, and superior orbital fissure being opened here to dilate the meningoorbital vein. A small perpendicular part of bone being removed, and this is the delineation of meningoorbital band, and this is being coagulated and cut sharply. After that, the dural duplication we open up to V2. This is tailored opening of dural duplication. And we can see intraorbital part of optic nerve before decompressing the optic nerve before it. This is orbital groove being opened to disconnect the optic anticlinal process. Then after removal of anticlinal process, we deal the optic strut to take control on clinoidal ICA before opening the dura. On all cases, we are doing in all cases of paracrine aneurysm. We are just try clip being applied so that in case of any premature rupture, we can take control on this ICA. After that, dura being opened, ciliary fissure dissected in standard microsurgical technique. And we can see giant aneurysm, middle directed, going below the optic nerve. Sharp acromion dissection is being done. After the dura open perpendicularly to open the dural ring, this procedure makes these deep-seated aneurysms more superficial, and we have more space. The complete cutting of distal dual ring. We can see ophthalmic artery. The optic aneurysm is defined all around. Proximal clip is applied in clinoidal ICA to decompress the aneurysm before clipping. We are trying multiple clips after aneurysm decompression. We'll see how aneurysm is deflated after taking proximal control. And neck being reconstructed. So we were planning to plane the straight fenestrate clip to clip this aneurysm. Multiple clips applied to completely occlude this aneurysm. So we can see we're getting lots of space for clip application also. Sometimes we have to apply multiple clips to for these aneurysms. Aneurysm was clipped successfully. We were checking for residual lag and perforator of antecoronal artery. Last clip being applied and this is intra of ICJ or distal vessel are filling well. Aneurysm is occluded. This is a 3-month post-op. Patient has no deficits. This is another case, ventral wall aneurysm, resting on posterior process. So 38-year-old female, we had presented with SAH. The similar procedure. The tailored opening of dura, cavernous and temporal dura, dual duplication. Taking control of canodal ICA, opening of dura and cutting of dural ring. So complete superficial cutting of dural ring sharply. Now we can see aneurysm neck just distal to distal dural ring. Proximal neck is defined. Now we will apply temporary clip just to deflate the aneurysm before clipping. And proximal and distal part of neck being defined and a single clip, cup clip applied to occlude this aneurysm. Checking clip application, we can see posterior process below aneurysm. After the aneurysm, little bit readjustment of clip to take the residual part of neck. Intra of angio shows complete of clipping of aneurysm and filling distal vessels. The post-op angio, complete exclusion of aneurysm and surgery was uneventful. And sometimes people ask, what about the dorsal wall aneurysm, giant ophthalmic segment aneurysm? Will you go extradurally in these cases also? We are doing it by tailoring it. This is why this approach, we can wide exposure. Posterior orbitotomy gives our better control on optic nerve. We can drill optic nerve away to intercanal site from orbit for drilling of antecanal process. Similar steps. Also, this is complete decompression of optic nerve. One advantage is this is early decompression of optic nerve before mobilize handling the aneurysm or optic nerve. So extradural approach gives you optic nerve decompression early. The cutting of dural ring in ophthalmic segment aneurysm. Now we can see cutting drill and dural ring and the aneurysm can be seen going below optic nerve and ophthalmic artery. This is fluorescein angiography in drop before clipping. After temporary control to deflate aneurysm, the clipping was done by single clip by preserving the ophthalmic artery. This is a post-clipping angio, fluorescein angio. Aneurysm is not filling. Patient discharge of post-op day 7. This is angio showing complete exclusion of aneurysm from circulation. This is the specific case. This lady had bilateral aneurysms. One was giant, one was smaller, one aneurysm. Patient presented with a history of stroke and she was planned for endovascular therapy. So due to constraints, they wanted one side endovascular, one side clipping. So we clipped one side aneurysm before the endovascular therapy. The one advantage of these the approaches is your similar steps, and what we started doing the tailored opening of dura. Dura we open a skull base, so we don't expose much of the brain, and we don't need so much of silent facet dissection what we used to do earlier, because we are reaching directly at aneurysms. This is the dorsal wall aneurysm, just sitting at distal dural ring being dissected from aneurysm neck. And we are getting so much space due to dural pilling, so that we are able to do this process very safely. And you can see the oculomotor membrane, what we tell, we are able to mobilize it and cut it and define the neck of aneurysm. Neck was defined and a single clip was applied, top clip, to exclude this aneurysm. This is ICG in draw. You see complete exclusion aneurysm, patent distal arteries, and with limited dural opening. So to summarize, the parenchymal aneurysms are always surgical challenge and exciting for us as a neurosurgeon. Complex anatomy which makes the task very difficult. The pre-op planning is key, and ultimately the skull base and cerebrovascular approach for this aneurysms is key. We can't go only cystial approach. We have to combine some skull base approaches to reach this aneurysm directly. Thank you.
Thank you, sir. Our next speaker is George C. Villanilam. He is professor in neurosurgery at Sri Chitra Trivandrum. He has done extensive work in epilepsy surgery today.
My dear friends who are the moderators here, we honored that the fastest rising stars in the neurosurgical circuit and the messiahs of neurosurgery in India put us all together for this fascinating get together here. And this is a topic, perhaps, however good you are technically, there are the few and Professor Ramesh Nayar's country as compared to India. So, there are some days in neurosurgery where we have triumphant moments and when we feel that, we are God's gift to mankind. And there are some other days when we feel that, we wish we had not been neurosurgeons. So, knowing these basic questions, I'll introduce this topic in the form of 7 basic questions. So, the first basic question is that, we all feel that we are very honest, conscientious, we are very hardworking, we always keep upgrading our skills. So this negligent doctor, is he really an existence, or is he an imagination of, created by the media or created by unsatisfied patients? To answer that in a very simple way, the concept of, negligence, to understand it better, we really need to understand that with our patients, we have what is known as a fiduciary relationship. So we have a relationship to take care of the patient, to continue to treat unless under circumstances, to have reasonable skills and to maintain certain sort of professional standards. So there is an unwritten consent the moment a patient walks into your clinic, and we need to act in good faith and candor for the patient. So, the basic concept of negligence rests on these 3 things. That is, omission to do something which a reasonable man would do, or doing something which a reasonable or prudent man would not do. Like, for example, say Suppose after surgery, a patient has develops meningitis, and a reasonable doctor would give a suitable course of antibiotics. Or if there is an intraop hemorrhage, a reasonable doctor would do everything within his skill to stop, or not doing that is amounts to negligence. So in our concept, we have this word called professional negligence, which we'll discuss a little bit more in detail. So to have negligence, you need these three things: duty to take care, a breach of duty, and most importantly, consequential damage. All these three together only fit into the legal definition of negligence. Let me give you a simple example. So when you're operating, if your bone flap falls on the floor, the natural reaction is that you put it in an antiseptic solution and you put it back. And then nothing happens. Say patient never develops an infection. So technically or legally speaking, that is, you may think, we have this habit of internalizing all negative outcomes and taking it within ourselves. That's good to keep us grounded. But that really doesn't amount to negligence in this situation, because there is no consequential damage. There is this whole concept of, in today's era, everybody is aware of their legal rights. Patients with negative outcomes who are actually suffering from sequelae of incurable diseases also feel that some negligence happens, and the whole concept is to make a damage whole again. So there are two aspects when there is negligence. One is to compensate for the harm suffered. So the harm may be in the form of a deformity, in the form of a deficit which is unexpected, and also to compensate for it in the form of a sort of a monetary compensation, direct or indirect loss of income, and also to punish the offender. So in legal terms, for any sort of negligence or any sort of criminal activity to be considered as criminal, there are two things. One is a criminal mind, that is a planned criminal activity, and then the criminal act. Only when these two together come, you consider it as medical negligence. So that new kid on the block, or you might say the new noose around the neck for every medical professional today, is the Bharatiya Nyaya Sanhita, which is the new Indian Penal Code, even a modification of the Criminal Procedure Code. And in this, the new thing which has happened is that if there is medical negligence, now you are likely to be punished with imprisonment and a monetary fine. So the previous IPC just had probably imprisonment or a fine. So both together, only when this pans along as the few years go by, we will know the impact of the IMA and the lot of professional medical organizations have been protesting against the legalities of the BNS, but only time will tell us how it is going to really affect us. So, let me put it up. Can you sue these two honorable gentlemen who have called us here today? Technically speaking, yes. If you're not happy with my talk or any of the talks which are going to follow or come up tomorrow, or with the food, technically, yes, you can. And how do you do it? There are definitely ways to do it. And in fact, that is how the whole legal system in the United States runs. People are suing their neighbors, people are suing somebody for road rage, and there's no end to it, because the concept is very vague. It's not really black and white. It's the whole is a gray zone. So the second question is that who is a victim of negligence, and what are the redressal mechanisms available in our country? So negligence, this concept is not new, and right from Hammurabi's code, when we used to say that physicians were considered as God. So it started with probably considering them as God, but then again there was a time when they had to pay a price, with heavy price, being sentenced to death, chopping off the hands of the physician. So this is something which has been there since time immemorial. And as one of the very famous thoracic surgeons has put it, that however technical skilled you are, however hardworking, conscientious you are all vulnerable to some form of a litigation. So what are the remedies for the disgruntled patients? The longest remedy, and which is likely to get the highest compensation, is civil law, where the failing in duty is considered a tort violation. There's also a contract, that is sometimes a written contract in the form of consent, which can be considered violated. The easiest is the Consumer Protection Act, where you can even plead your own case without a lawyer. And this has been there since 1986, when the medical professionals were included a few years later, where the contract violation, where the patient is considered as a consumer and the doctor a merchant. Criminal law is applicable only when there is very gross negligence, wrong side surgery or something like loss of life. And you can also complain to professional regulatory bodies. But what is worrying today is the trial by the print media, the social media, which have already caused enough damage to the doctor's reputation that no amount of undoing the harm, even if proven not guilty, can be done later on. So the third question is, where does neurosurgery stand in the world of negligence claims? So this is a study from NEJM published in 2011, where our neurosurgery tops the list of medical negligence claims all over the United States, and perhaps in our country it may not be really so. But then this is because we are dealing with a system which is very delicate and unforgiving. So the next question is that what are these high risk situations? So, we often think that when there is a complication or an adverse event, that is a high risk for a medical negligence claim. Nevertheless, yes, but to a large extent, most of your highly complicated patients or those who have the highest adverse events are not going to be the one who are going to be creating medically vulnerable situations for you, because a complication need not always equate with a negligence claim. So all negative outcomes, are sometimes clubbed together, which includes the other than adverse events, even sequelae of illness, like you operate a motor cortex glioma, you might have a hemiparesis or a hemiplegia, which is a sequelae perhaps of surgery, despite all your efforts. Failure to cure a patient with a glioblastoma 2 or 3 times recurrent sometimes might also equate that failure to cure with a negligence situation. So, adverse event in our circumstances is very, very broad definition, which is used very, very vaguely. And in the current era, when we hear the term complication, it makes the surgeon very defensive, the patient go into a litigatory mode, the hospital authorities go into a damage control mode, and obviously for the press, it is always an interesting story. So this concept, always keeps changing as there is no clear definition, and it's a gray zone, especially in several adverse events. The top 5 causes reported in neurosurgical literature for potential litigant are surgical site infection, which is always very obvious and delays the hospital stay. Technical error 22%, lack of information about the illness, delayed diagnosis, lack of supervision. So some of the causes like a communication gap are top for creating medical negligence vulnerable situations. So the usual negligence claims are, that the doctor was not skilled enough in, say, endoscopy, but he still tried to do it. Or when I called, he was not available to look after me after surgery. There was some little bit of diagnosis errors in the treatment, failure to communicate. Again, it's one of the very important reasons. Surgical substitution. I thought that Dr. X, who's a big professor, is operating me, but he was operated by a little more junior doctor. And more importantly, vicarious liability. So your mistakes of your nursing staff are also, you become liable for it. So the next question is, how do you survive? How do you bail yourself out? If you have performed a wrong side surgery or if somebody has died on the operation table, is there still hope? The answer is yes. There is hope, and don't hang the innocent. 100 गुनेगार मतलब होंगे, but आप जो निर्दोष है उसको छोड़ दो. That is always the concept in law. So you have to somehow prove your innocence in medical negligence claims. So one of the basic 2 tests are the Bolam test and the Bolito test, which says that if you have acted in good faith up to reasonable standards of care, the Bolam test, then that is enough. And the Bolito test is a little more detailed in that. So in the interest of time, I'll go a little faster. So what are the redressal mechanisms available for a neurosurgeon? We have legal support mechanisms, you have regulatory bodies, you have associations which also provide legal advice, and there are always alternate disputes redressal. There's always opportunity to call the patient back, talk, explain, plead your cause, and say that you did your best under the circumstances at that time. Suppose you are operating in a war situation, you're operating under highly constrained circumstances, and you have done a wrong side surgery and you're able to plead it before a court, perhaps your plea might work. So what is the defense for the neurosurgeon? You did it to your best with existing standards of care, and it conforms to a standard adverse event rate. There was no deficiency of care. It happened in the heat of the moment. The facilities were suboptimal. There was contributory negligence from the patient side as well, and obviously vicarious responsibility. So there are a lot of some very, very landmark cases which actually tell you that what you thought was medical negligence is not actually medical negligence. Written consent not taken, not getting the desired relief of symptoms, giving precedence to some patients over the other, not providing ICU bed when not available, refusing to treat an elective patient. So these are very, very interesting cases, and my idea here is to inspire you to go into this and look at it in little more detail. What are the punishments that the neurosurgeons can get? In the IPC era, the maximum punishment which you can get is when you have criminal negligence, and that is when you have caused grievous hurt, something like wrong side surgery, or suppose say retained surgical instrument, where sometimes the evidence speaks for itself. It's called as res ipsa loquitur, and the penalties imposed, the highest could be imprisonment or a legal restraint. But more importantly, in today's era, it's the indirect penalty, malreputation, legal charges, loss of work focus, and heartburn that you suffer, which causes more of a harm to you than the actual financial liability that you may have. So do we need this fault finding? If you actually look at it, in many countries, European countries like Sweden and Switzerland, there's no concept of medical negligence because they find fault within their own system. If something goes wrong, they feel that it's a systemic failure. It's not an individual failure. So probably when we actually go into a damage control mode, what we need to understand is we definitely have to be defensive, but we shouldn't get demoralized, and we should use the lesson to inspire higher standard of care, build up further expertise and error prevention. And like in the Chernobyl disaster, the Challenger space shuttle disaster, try to look into how to avoid the fault rather than whose fault it is. And the common misconceptions always are that, medical adverse events reach to a malpractice claim. That's a misconception, and to err is human, but that doesn't mean that you try to do everything possible to avoid errors. And the success rates of litigations, even in India is about only 15 to 25%. So there is still hope for all of us. And we have to, work towards a future where there will be a state-sponsored no-fault social support program, which helps to identify a systemic failure. And frivolous litigations are, going to be more common in the future, especially with easy litigations possible in the Consumer Protection Act. And we have to definitely save our skin, but it's not in the form of a namesake cover-up attitude. I think the lesson should not be lost in the whole bargain. And just like we have primary prevention and tertiary prevention for every disease, there is the same for litigation or medical negligence as well. Primary, secondary, tertiary prevention, and then only the highest level do we have. Prevention is definitely the best form of cure. Only at the highest level do we have legal advice and support groups and things like that. So survival tactics, definitely the foundation for all this is to build a rapport with your patient at the first contact itself, so that he trusts you implicitly, he or she, and whatever misgivings may happen are often forgiven by the patient. And there are some very, very landmark cases in neurosurgery where failure to inform the disc surgery complications and post-operative cauda equina syndrome actually led to negligence claim. And in Indian law itself, there are some very, very important cases which you can look into further, where the court ruled in the favor of the neurosurgeon, just because the sequelae of the disease made the patient file a negligence claim. So this is a very landmark case where patient had post-operative paraplegia, where again compensation of 14 lakh was awarded by the National Commission, and then further appealed to the Supreme Court, where 1 crore compensation was given. So the message that we have to take home is that we are dealing with a very unforgiving nervous system, and our specialty tops the list in medical legal claims, and more than 80% of these are definitely avoidable. We need to take precautions like conforming to standard of care, good communication, ensure that we have some form of an indemnity insurance. Most importantly, don't panic. Whatever happens, because there is definitely a way out. Plead your cause in a logical, ethical, and legally upright manner. And malpractice claims never are related to the complexity of the case. Error prevention and maintaining high standards of care are the key way forward. And the strong bond of a surgeon-patient relationship is the key way forward. So let me end with this cartoon which says that even Humpty Dumpty, who fell from the wall, can sue for negligence for loose mortar and no warning signs. Thank you very much.
Thank you so much, sir.
Thank you.
Now I request the respected chairpersons to give away the mementos.
Sir, thank you. This is M.K. Shastri. I've been a assistant in Supreme Court and I've been an assistant doctor to universities.
Right, sir.
So right now there are 4 points which I'd like to put forward. See, the word all is going to be reinserted again. This conversation has been with JP Nadda and this all, which you say, all is not going to be implemented. Right now, it has been a matter of serious concern and all is going to be implemented. Second is the CGI of Supreme Court of India. Since he was a judge of Bombay High Court, you have been following him, and he said that doctor has done to the best of his efforts. So negligence has to be avoided. Now, the thing, what we do is that the party comes with a negative concern. So now, I'll just add one point to you, sir, if you don't mind.
Sure.
Whenever a legal notice comes to you, you don't call the party to concern. You are asking the party to concern, it motivates them.
That's right.
And it goes against you in the court of law. So whenever a legal notice comes, take a cup of coffee, drink, and put it in your don't respond to the first notice. When the second notice comes, ask the legal advisor, make all the legal points, how it was admitted, what it was admitted, and most important things are the four things which you have to maintain case diary. We call it the case diary. And every case diary is very important because it goes to the Supreme Court. The first thing the court will call you is the case diary which you have maintained. Every incident, event, and what was reported has to be maintained in the case diary. If case diary is in your power, I tell you, even the constitutional bench of Supreme Court cannot go against you. And that is the reason a case was filed from Apollo Hospital, Hyderabad, and the chairman was my very good friend of National Consumer Tribunal. They allocated around 17 cases to in his favor, but later on the judgment was reversed in Supreme Court, saying that the case diary is this, the event has happened this, there is a doctor responsible. And something that you say, where is the sanction available? It has to be very clear with the eyes of the High Court and Allahabad High Court judgment, the landmark judgment. Two things we have to mention. One is about the handwriting. The most problem we are facing in the court is because of the handwriting. So court has mentioned in one judgment, they have given 200 rupees penalty for the doctor to mention his handwriting, which is not clear to them. And second, if you mention your truths properly in the case diary, I can bet on you, sir. No one can judge your court. And third thing about social media, whenever such events happen, immediately approach the CGM court with your lawyer that anyone who writes against you becomes sub judice and is imprisoned. And then you can fight the court against the media and this, so that no all this recordings which goes to social media is adopted. So nothing can happen to you if you mention your case diary and you approach the court and don't tell the party for negotiation. Nothing should happen in the table. Everything should be on the table. And I tell you, the party knows very well. And tell them, you want to go to Supreme Court? Okay, fine. I'll go to the constitutional bench. Party will not go. It takes 60 years to file and get a judgment. No party is full, sir. Thank you so much.
Thank you. Thank you very much for raising the point. And I think the message is well taken that as neurosurgeons, we always want to act upon everything immediately because if we feel, the patient will deteriorate. So that doesn't happen in legal sciences. We should sleep over the problem, should give it some time, give it some thought, and as much as possible, allow the natural course of justice in our country, which takes a very, very delayed time to take its course, taking all precautions from our side. Thank you very much, sir, for raising those points. Thank you.
Thank you, sirs. Now I request the respected chairpersons to give away the mementos. Firstly, to Dr. Dibyajyoti Mahakul. To Dr. Sunil Furtado. To Dr. Tariq Mateen. To Dr. Pathsarthi Datta. To Dr. Jayanand Sudhir. To Dr. Jayanand Sudhir. To Dr. Kamlesh Singh Baiswara. To Dr. George Villanilam. Thank you, sirs. Now, we would like to start the next session on endoscopy and oncology. I would like to call upon the next chairpersons. First, Dr. Ramesh Nair. Second, Dr. Parthasarathi Datta. Fourth, Dr. Jayanand Sudhir. And Dr. Ishwar HV. Please be seated, sir. Now we would like to start the next session on endoscopy and oncology. I would like to call upon the next chairpersons. Dr. Ramesh Nair, Dr. Parthasarathi Datta, Dr. Jayanand Sudhir, and Dr. Ishwar HV. Please be seated. Thank you, sirs.
Now, I invite our next speaker, Dr. Anil Sharma, who will be giving lectures on two topics. The first topic is endoscopic assisted microneurosurgery, and the second topic is surgical management of giant multi-compartment trigeminal schwannoma technical aspects.
Start now. Very good afternoon. I'll talk about giant multi-compartmental trigeminal schwannomas. As we know that trigeminal schwannoma is second most common after vestibular schwannoma, but it's relatively uncommon and rare kind of tumor. Constitute almost 0.8 to 8% of the tumors. And these tumors has slow growth and highest incidence in third to fifth decade of life. And surgical resection is curative for these kind of lesions. So these tumors mostly arise from along the course of fifth nerve. It may be from root, it may be from ganglion, and it may be from
various divisions, V1 and V2 and V3. And most of the time, these tumors arise from the sensory fascicles. And that's the region that each patient invariably has some sensory deficit in the fifth nerve involvement. So there are various classification schemes. One that is commonly used is Kawase classification that has been divided into MPE type and predominantly in middle fossa, predominantly in posterior fossa, and extracranial, and that may be combination of any of these. So most of the time these tumors erode the petrous bone. 70% of the time body destruction is present and frequently associated with cystic association. And autopetrosectomy is most of the time is already done by the tumor. As we can see here, reformatted image, there on right side, petrous is hardly seen, and CT scan also we can see. And these tumors, when grow extracranially, these tumors widen the foramina along their involvement along the root, and from the widened foramina, it becomes easier to remove this kind of tumor by the single approach. As we have Professor Goel sir, who has done extensive work on trigeminal schwannomas, and one of the very few early and one of the largest series on the vestibular schwannoma. So this one representative image with this very huge tumor with Kawase MPE type and middle fossa, posterior fossa, and growing extracranially. So there can be variety of approaches for this kind of tumor depending on their area of involvement. That can be, if predominantly in posterior fossa, that can be retrosigmoid approach. If predominantly in the middle fossa, that can be interdural approach. That can be combination of Kawase, modified Dolen-Kawase. There can be variety of approaches for these kind of tumors, depending on their area of involvement. But as we have discussed, that most of these tumor, they grow along the Meckel's cave, widen the Meckel cave, and widen the foramina. So it becomes easier and safer to remove these tumors by the single approach. And these tumors can be removed by the single approach. So this is one interdural approach. Linear incision also can be taken, and I prefer to take reverse question mark incision. Patient is supine with lateral. And this is the representative diagram which shows how tumor grows along V1, V2, and V3. And the section is carried out along the middle fossa base to expose various foraminas, middle meningeal artery that is coagulated and cut in early part of the procedure. And then we work in the interdural plane, in periosteal side of the dura and inner membrane. So coming to some representative cases and videos, this one young gentleman presented with sensory dysfunction of the fifth nerve. Tumor is Kawase MP type, predominantly in middle fossa and posterior fossa with lot of cystic changes. And when we see CT scan, that petrous is already eroded by the tumor. Autopetrosectomy is already done by the tumor. So these are the preoperative and postoperative images. So this is some images which showing middle meningeal artery. Navigation also can be helpful in the tumor. And this second picture depicts after development of the interdural plane. So coming to surgical video. So this is anterior clinoidectomy is being done. That is the workhorse of all anterior and middle skull base surgeries. Orbitomeningeal vein is being cut. And this anterior clinoid that should be decorticated, and one should avoid that amputation to remove in a single piece. Now we have drilled the temporal base flush. That is very important, that all osseous extension that should be drilled with the flush with the base. And middle meningeal artery is identified, that usually come nearly 1.5 centimeter at the root of the zygoma if we go from outer surface. And that foramina should be widened. It should be drilled before coagulating and dealing with middle meningeal artery. It's advisable to widen this foramina because it helps in better coagulation and avoid that retraction of the middle meningeal artery. So now that foramina is being drilled for a better coagulation and avoid that drilling. It can be widened with the Van Emmen Garrison punch also. And now that middle meningeal artery is being coagulated and middle meningeal artery is being cut. And just posterior to middle meningeal artery will identify GSPN. As I said, most of the time when Meckel's cave is wide, that standard anterior petrosal approach that is not required, pittus drilling that is not required most of the time. Here we can see just posterior to is GSPN. So now that interdural plane is being developed. Here is some cystic part that's coming out, that cyst should enter. And that interdural plane is being developed. I put stitches on the temporal dura, and this is the tumor we see after development of the interdural plane. Now capsule is being incised and the tumor is being decompressed. So as Meckel's cave is wide, so single approach is more than enough for these kind of tumors. And these kind of tumors are usually well circumscribed and with discrete. And usually these tumors, though there may be extension to cavernous sinus, but usually these tumors does not involve cranial nerve and cavernous sinus. And very well and easily can be separated from the surrounding structures. So now tumor capsule is being dissected from the dural layer. So these tumors are interdural in the middle cranial fossa and interdural in the posterior cranial fossa. So now this tumor plane is being developed and is being dissected from the dural layer. So here very well we can appreciate how tumor is being dissected from the dural surface. So this is the tumor and this is the part of Meckel's cave tumor which is extending posteriorly. That after decompression the dura is reflecting here. And now it's being dissected and tumor removed by the single approach. So this is the view we get after removal of the tumor. And we can see reflection of the various trigeminal roots. And this is just to confirm the completeness of resection. This endoscope was put, and we with the ability to look around the corners in the hidden areas. This endoscope we can see impression of various trigeminal roots, and there is no obvious residual lesion. So this endoscope, this can help as an adjunct. This can help just to confirm the completeness of resection. So coming to another case, this preoperative MRI, when young this pediatric patient, 12-year-old girl, presented with facial trigeminal nerve sensory involvement. The huge tumor with Kawase NPA type, significant component in middle cranial fossa, posterior fossa, and extraforaminal. It's going in the temporal base by the foramen ovale. So here we can see preoperative and postoperative images. Tumor had been resected completely. So this is surgical video. I think I'll same. I won't go into the detail. This is another patient, elderly female, nearly 50-year-old female, presented again with sensory deficit and temporal muscle atrophy. This preoperative MRI. Here that Meckel's cave is not that wide. It's wide, but not that wide at what we have seen in previous cases. Preoperative MRI and this is postoperative MRI. This patient also had extra cranial extension in the temporal base. So this is the interdural stage, as you have seen by standard approaches. Here we will see this posteriorly. This is after coagulation of dura, and here interdural coagulation middle meningeal artery. Here interdural plane is being developed from posterior to anterior. So this is very easier to develop the interdural plane, and it's offers a combination of blunt and sharp dissection. And we can use tooth forceps also, and we can peel. We can work between two layers. So here that tool is being developed with the knife, with sometimes back end of the knife, cutting with the front end and working with the back end. So this plane is being developed. So here again, that tumor is quite huge and almost filling the middle cranial fossa. Completely the capsule is being incised and that being decompressed. So this tumor most of the time is soft. This here, the V3 segment that is being separated from the tumor. Most of the time, this tumor is soft and easily QSA is really very helpful in these kind of cases. Here we are dissecting the tumor from the V3 segment. This is the next stage. So as Meckel's was not that bad in this part, in this tumor, that Kawasa triangle is being drilled. It was difficult to reach the posterior fossa part, and dura is stand at the T shape. Dura is being opened. Now tumor is being dissected from the basilar and SCA and PC and third nerve. Here the dissection is being done. Usually these tumor can be dissected. There is definite plane. There is no adhesion, or usually this can be can be dissected. Here tumor is being dissected here inferiorly. Time is up. So here we can see basilar and PC and SCA and third nerve. Here. So this is the view we get after removal of the tumor. And here we can see there is no obvious residual, and we can see posterior circulation vessels. This is another case. I'll skip that. This is another multi-compartmental trigeminal schwannoma with cystic component in posterior fossa and predominantly solid in the middle fossa. You can see preoperative, postoperative images. I will skip these videos. And so coming to conclusion, these tumors are best managed by total resection, and most of the time these tumors can be removed by the single approach. And skull-based techniques are favored. There are various techniques as we have described, like subtemporal approach. An endoscope may be used in selected cases, and for residual disease, gamma knife can be helpful. Thank you. Thank you very much.
Thank you, Dr. Anil. You've shown some great cases. And these tumors, by the way of its location, lends itself to the approach, extradural approach. I think the trick in this sort of cases is to avoid injury to the normal trigeminal fibers. So often difficult. Often the patient end up with trigeminal neuropathy and numbness. And I wanted to ask you, what's your view on lumbar drain? Do you...
No, I don't use lumbar drain. Initially, I used to use, but nowadays I don't use lumbar drain. And most of the time, these patients can be managed without lumbar drain. If I found, as I told, like I prefer to take a reverse position incision. And if I find during surgery that there is bulge and it's getting difficult to dissect the interdural plane, I just put a small nick and release the CSF from the interoptic or opticocarotid corridor.
Thank you. And obviously, Professor Goyal wants to.
First of all, I must say that I'm very happy to see some very beautiful presentations on skull-based tumors from anti-planar dissection and trigeminal neurinomas from you.
Thank you, sir.
The other thing is you see this interdural strategy, that was described first by me in 1995.
Yes, sir.
When I had said, like you said, that the middle fossa part is interdural and the posterior fossa part is subdural, or like acoustic tumor. But later we have realized and we have published that even the posterior fossa component of the tumor might be interdural in location, particularly in tumors which are multi-compartmental. And if they are bicompartmental, like middle fossa and posterior fossa, they might be subdural in location. The other thing is, as Dr. Nair also said, preservation of trigeminal fibers is the key in these tumors. In the paper we published in, I think in the year 2000, for the first time in the literature, we said that you can improve the sensations of trigeminal nerve. And it is very highly critical to save the V1 division in particular, because if you lose the V1 sensation, you lose the eye. So it is important to come from the undersurface of the tumor and then debulk the tumor. And critical is to avoid teasing of the tumor from the trigeminal nerve fascicles.
Yes.
And to break the tumor of these nerves rather than tease the tumor from the capsule. So it is very highly critical and important to save the V1 division in particular and debulk the tumor. Many of these tumors, as you have shown, are cystic in nature, they are necrotic in nature. The other thing is extracranial compartment of the tumor is also interdural in location. This is
Yes.
also one
Yes,
thing we described.
That's also.
And the third and important thing is, it is important to work within, identify the membranes, break the tumor, avoid dissection of the cranial nerve. And you see this dura will protect you of the carotid artery, dura will protect you of all the other things. So it is important to do a beautiful dissection as you have shown, and I am happy to see what you have shown.
Thank you, sir. And what I observed, sir, majority of these patients, they report significant improvement in their sensory symptoms after surgery.
This was never reported earlier. This, you show me the literature.
Yes.
The improvement as a series, isolated cases were there, but as a series, it has never been reported.
Yes.
Yeah, one of the things which we have observed in Sri Chitra is that the initial phase, the image guidance is a very useful tool. But as we grow on it, there are very fixed landmarks everywhere here. The middle fossa approach renders a lot of fixed landmarks, which means that you're sure of where you are, which improves your confidence in dealing with them. Well,
yes, sir. Yes. Thank you. Thank you.
Now I invite our next speaker, Dr. Prakash Nair, who will speak on endoscopic endonasal approach for lesions of the petroclival region. Please, sir.
A very good afternoon to all of you, and thank you very much to Professor Aip and Dr. Debabrata for this invitation. We've seen over the course of the day, all this approach into the cavernous sinus from the lateral aspect, where we have looked at various techniques of peeling the cavernous sinus lateral wall. I shall be talking about the endoscopic transpterygoid approach for skull-based tumors and focusing upon displacing the cavernous sinus on the medial aspect. So these are a set of tumors that you have, which extend into the posterior part of the petrous apex or into the cistern or towards the jugular bulb, and all involve have extradural course. Do you have a pointer? All have an extradural course, are predominantly bony, and involve the petroclival synchondrosis. No, this I can do. No, it's okay. So these are tumors that can be approached to the endonasal aspect, and this requires making our medial approach more lateral, and the transpterygoid approach is one way in which we can extend the approach towards one direction. So the petrous apex as such can be approached through an anterior petrosectomy or through a translabyrinthine approach, and these approaches have their own advantages. But there are also certain disadvantages. For example, with the anterior petrosectomy, there is a very limited access to the medial aspect of the clivus, and there is a significant requirement for temporal lobe retraction. With the posterior transpetrosal approach, the soft tissue of the clivus or to the nasopharynx cannot be approached. And even with the best of hands, the extent of resection is quite low. And there is a significant amount of risk to both hearing and to the facial nerve. The transpterygoid approach relies upon the removal of the pterygoid wedge and the upper part of the pterygoid process. And there are three important structures that we need to deal with when we get there. We have the foramen rotundum, the Vidian canal, and the palatovaginal canal. And the relationship of the Vidian nerve and the foramen rotundum can be used to divide the sinonasal tract into three lateral compartments. We have the infratemporal fossa there, the pterygopalatine fossa, and the lateral recess of the sphenoid sinus. And these can be accessed through the transpterygoid approach. Now, how does it help? The transpterygoid approach makes our direction or the direction of access more direct. And the exposure of the tumor and the circumferential delineation of the tumor is improved. The ability to move instruments and to have bimanual surgical access in this region is improved. And we can also isolate the entire course of the ICA, starting from the foramen lacerum up to the cavernous sinus. And in cases where it is required, we can also mobilize the eustachian tube. So there are two very important landmarks. We have the median nerve and the pterygosphenoidal fissure, both of which can be used to come up to the foramen lacerum and to identify the genuine of the ICA. Now, this is an example of a patient who had a tumor involving the posterior clinoid here, the upper clivus, the posterior clinoid. And like all chondrosarcomas, this extends inferiorly to involve the petroclival synchondrosis. Now, chondrosarcomas tend to be surgically amenable to complete resection. And one of the advantages of coming from the medial aspect is that you can avoid all the cranial nerves that lie laterally in the cavernous sinus. So we performed an extended transpterygoid approach. This is the initial approach that brings us to the nasal cavity from the right side. And on the left side, we go on to do a maxillary antrostomy. A maxillary antrostomy gives us. So once we do the maxillary antrostomy, we come to isolate the sphenopalatine artery. The sphenopalatine artery can be coagulated and divided, and then the posterior wall of the maxillary sinus can be opened. So this gives us access to the pterygopalatine ganglion. Once the posterior wall of the maxillary sinus is opened, here you can see the shiny surface, which is the periosteal surface of the pterygopalatine ganglion. We harvest a rescue flap and also create a medial septectomy so that we get bimanual access from both sides. So now we have converted the posterior nasal cavity into one cavity, and we can now go on to do a bimanual two-surgeon forehand approach. So once the posterior septectomy has been done, we do a wide anterior sphenoidotomy. So a very wide anterior sphenoidotomy so that this can be extended towards the left side is very important. Now, at this point of time, we are slowly lateralizing the pterygopalatine ganglion towards one side, and the median nerve is being exposed. This is the exposure extended further laterally onto the foramen rotundum. So once the median nerve has been exposed, we selectively isolate the median nerve and do a median neurectomy. And the median neurectomy now, once the median nerve has been seen and isolated, we can drill towards the pterygopalatine to the foramen lacerum. Now, the important landmark, the important idea of having the median nerve there is that the median nerve always lies, the genuine of the ICA always lies above the median nerve. And drilling the undersurface of the median nerve is a safe way to get to the foramen lacerum. The other important landmark that we can use is the pterygosphenoidal fissure. So the pterygosphenoidal fissure is a fibrous streak that runs towards the foramen lacerum. So these landmarks can be used to triangulate upon the foramen lacerum. Here the entire Meckel's cave is also exposed, and the laceral ICA is now drilled so that it can be mobilized towards one side. We have a very important landmark here, which is the lingual process of the pterygoid bone, and the lingual process can be resected and removed. So in this way, the entire ICA from the cavernous segment to the foramen lacerum is now freed. After this, we use a Doppler to isolate and identify the ICA, and the entire course of the ICA can be identified. Because the tumor now lies inside the cavernous sinus, we go on to open the anterior wall of the cavernous sinus. The anterior wall of the cavernous sinus is opened, and now we are opening above the paracellular ligaments and the keratoclinoidal ligament. So here the pituitary is being mobilized in an extradural manner or an interdural manner. And now we come upon these small vessels that are branches of the ICA. These are the inferior hypophyseal vessels. And slowly the posterior clinoid and the upper clivus is removed downwards. So the pituitary has been transposed towards one side. The tumor that is lying in the upper clivus is being slowly dissected downwards. And we can also remove the outer wall of the dura that lies in this plane. So this is a manner in which we can get resection of the involved bone and the involved dura. The area behind the carotid is now being exposed, and this is where we use neuromonitoring to identify the sixth nerve. There's a very important landmark here, which is called the sphenoidal process of the pterygoid bone. This is a landmark for the sixth nerve, and the sixth nerve can be then isolated and then identified. So in this manner, the entire tumor, the upper clivus, can be resected. Now, this can also give the same approach can be used to come down to the petrous apex. So this is another case. This is another case where we're using the same approach, drilling on the inferior surface of the median nerve to isolate the foramen lacerum. We can identify this fibrous edge of the pterygosphenoidal fissure. And now we slowly skeletonize the ICA. So the entire ICA is skeletonized. And at this point of time, the tumor that lies behind the carotid artery can be slowly removed. Now, the important thing here is that chondrosarcomas are extradural tumors. And we have the ability to, get a complete resection, which is curative in these particular patients. So the bone, till the normal segment of bone is identified as drilled. And at this point of time, one can see the entire Meckel's cave. We can see the maxillary nerve, the sella, and the genu of the ICA. Here again, the tumor involves the upper clivus and the posterior clinoid. And extensive bone removal allows us to resect the entire tumor. So now the upper clivus is being disconnected. The upper clivus is being disconnected from the and the posterior clinoid and the dorsum here is being dissected and removed. Now the important thing here is that the tumor all chondrosarcomas extend along this petroclival synchondrosis. So they extend lower down and they also involve the upper part of the petrous apex. So here we can drill towards the petrous apex, which lies behind the ICA. The ICA can be mobilized. Once again, the sixth nerve can be decompressed. And when we get bleeding from the cavernous sinus, it can be controlled using hemostatic material like gel foam. Now, this is a very young child. So the important anatomical pointer here is that, I am drilling on the upper surface of the petrous apex. And we can identify both the petrosal process of sphenoid bone, which is a key landmark to the sixth nerve, which can be dislocated. The sixth nerve at this point of time can be identified using neuromonitoring. And one of the main clinical presentations in these patients is sixth nerve palsy. So here, using the navigation, we've confirmed that we're in the upper part of the petrous. We have the clivus on one side, and you can see the petroclival fissure. And the upper part of the clivus can be further drilled to get negative bone margins. So this is the postoperative CT scan where one can see that the upper part of the clivus has been drilled inferiorly. And this is a very useful way for getting complete extradural resection from the upper part of the clivus to the lower part of the petroclival fissure. So extensive craniofacial procedures that were used in the past to access this area can be avoided, and the manipulation is essentially medial. The cranial nerves 3, 4, and 6 lie on the lateral part of the cavernous sinus, not on the medial part. And these are not standalone approaches. They can be paired with anterolateral approaches or skull base to get complete resections. So another important relationship was often this ICA that often comes along to the anterior aspect of the eustachian tube. Now, this is important in patients where you have tumors that come down into the petroclival synchondrosis under the upper part of the jugular foramen. So the procedure here, the initial part of the procedure here is very much the same. We do a maxillary antrostomy, we open the sphenopalatine foramen, we decompress the posterior wall of the maxilla. And once the upper part of the clivus has been removed, I'm nearly done, upper part of the clivus has been removed, the eustachian tube here can be displaced downwards. So this is the cartilaginous part of the eustachian tube that is being mobilized inferiorly. The tumor that lies behind the ICA is being slowly removed. And because the softer matrix of the chondrosarcoma can be aspirated out, we remove it and then drill the upper part, the lower part of the clivus here towards the petroclival synchondrosis and towards the jugular foramen to get negative bone resections into that particular region. So we can now see the dura of the posterior fossa there, and that is the resection being extended towards the upper part of the jugular bulb. So this is the surgical reconstruction. One can appreciate here the tumor resection being continued up to the anterior part of the jugular bulb, and the clivus on the left side is completely drilled up till this point of time. So these are not just approaches that can be used for small tumors. These can also be used for very extensive skull-based tumors where the ICA has been displaced towards one side. So one can appreciate this 3D reconstruction where the entire course of the ICA is displaced laterally. And once again, this is the drilling of the lateral aspect of the sphenoid sinus where we are unroofing the Meckel's cave and unroofing the foramen rotundum. The bone of the clivus is removed. The initial protruding part of the tumor is also dissected and removed. And once this has been done, we go on to expose the entire course of the ICA. Now, this is important because petroclival chondrosarcomas involve the upper clivus, they involve the posterior clinoids, and these are areas where there is always residual tumor left behind. So, at this point of time, we slowly unroof the cavernous part of the ICA and drill off the bone over the Meckel's cave to completely skeletonize it. And then remove tumor that is extended behind the ICA. So this also lets us remove and resect soft tissue that has been involved by the tumor. So one of the problems with tumors like chondrosarcomas or chordomas is that there is a lot of recurrence in the sinonasal cavity or chordomas that recur in the region of the bone. And this is the anterior wall of the cavernous sinus being opened. The anterior wall of the cavernous sinus is now being opened, and the posterior clinoid is being slowly dissected from the upper clivus, and the posterior clinoid is also removed. So in this manner, the upper part of the clivus, which involves the dorsum and the posterior clinoid, is removed. The petroclival synchondrosis, the tumor involved there, is removed, and the lower clivus is drilled till one can see normal bone margins. And reconstruction of the skull base is done using a nasoseptal flap. So this is the postoperative MRI where one can appreciate the resection of the clivus and the upper part of the petrous apex here. So this can also be used for very extensive chondrosarcomas which involve the cisternal part of the brain, and large parts of these can be resected using the extended approach. So to conclude my talk, the endoscopic intranasal approach can give very wide access to the petroclival synchondrosis. The Vidian nerve remains a very key landmark to identify the journey of the ICA. And this can be used for approaching various regions like the petrous apex or the upper part of the jugular foramen or the infratemporal fossa. And at the end of the day, the procedure widens your operative corridor and improves the extent of resection. Thank you.
Excellent demonstration of how to push the envelope in endoscopic surgery. Any questions from the audience?
Very, indeed, absolutely happy to hear you. And I wish you continue to do this kind of work and progress the way you are doing. And I want to see and hear more from you. And I want to see more about you. Okay. Thank you very much for beautiful. I'm very happy to hear your presentation.
Now, I would like to call upon Dr. Atul Goyal on his topic, revolutionizing the spine surgery.
First of all, I welcome my dear friend Bill Colwell. For all those who see Bill here, you can imagine he has come all the way from US. Late night he arrived here. He's here with us and now about to leave. This is not easy, believe me. My wife was discussing, to come from Mumbai here has been so troublesome. 8 hours of drive in a little bit tricky terrain. And then Bill is here. So Bill, you make me happy. And you have made every one of us happy. He is one big good friend of Dr. Nair. He is one good friend of India. And except for the COVID times, every year he used to come 3 or 4 times to India. Unbelievably, Bill, thank you very much for your friendship, your affection to this country, and what you have taught to this country. Come from the beginning. No. Come from the first slide. Where is the slide presentation mode? By the time he is setting it up, I welcome Dr. Samay is here. Samay is one very powerful, one of the emerging leaders. Will you know him, Samay? one of the emerging leaders of neurosurgery in the world. His organizational skills, his collaboration in various groups, Dr. Nair knows, and his work on endoscopic spine surgery is indeed fantastic. One of the emerging powers of world neurosurgery. When did you come, Samay? Just morning, like Bill Colwell. Yes, Krishna. So today I'm not going to talk on one of the power figures. I'm happy to introduce Samay to you. And I was in Egypt a few weeks ago. I couldn't meet him for some strange reason. But Samay is Samay. Thank you. And welcome to you, Samay. Take care and my best wishes to you. Thank you. Please. Thank you. So I'm not going to talk on skull base. I have been in skull base all my life, but recently people have started calling me spine surgeons. So let me talk on spine because it has been indeed a wonderful journey in spine surgery. And I wish to present before you, which I have presented on several occasions recently, a spine surgery revolution, a completely different version of spine surgery. And I have to tell you that whatever I'm saying, whatever I'm showing, I believe in what I'm showing. And I believe that this is the future of spine surgery. When we talk of spine surgery, we talk of compression. And we talk of decompression as the treatment. I take you to a different version. I'm introducing a different concept in spine surgery. The concept is compression is a non-issue in spine surgery. Compression is never primary. Compression is secondary to segmental spinal instability. Compression is protective and adaptive in nature. Excuse me, please, can you be quiet? Because it is some spiritual lecture going on. Okay? Compression is protective, it is adaptive. And more importantly, compression is reversible. Compression indicates unstable spine. And this statement, decompression, is never the treatment. So this is quite a different version of spine surgery. So let me go through it rapidly. Human position, standing position is what matters. We stand on two legs like no other animal on the planet. All our muscles are focused to make us stand. All our muscles are focused to make us run and dance on two legs. All our muscles are focused on the facets. There is a huge group of muscles focused in the nape of neck, focused on the C1, C2 joint. Much of the muscles are focused on the facets. There is nothing in front of the body of on the vertebral bodies or around the disc. There is nothing. You put your finger, in the mouth, you can touch the odontoid process. You put your finger from here, you can touch your vertebral bodies. All our muscles are here. And weakness of these muscles is the problem due to disuse, abuse, misuse, or injury. Weakness of these muscles make the facets weak. There is subtle listhesis at the facets which cannot be recognized or may not be recognized on imaging, and this weakness is the problem. I introduced to you a concept of vertical facetal instability, the point of genesis of spinal spondylotic disease. I introduced to you a concept of central or axial atlantoaxial instability due to weakness of muscles of the nape of neck. Atlantoaxial joint is the most mobile joint of the body. Atlantoaxial joint is the most unstable joint of the body due to its architecture. Atlantoaxial joint is the more instability, is the most under-recognized instability in the entire spine and under-treated clinical entity. So basilar invagination, I have talked on several occasions. It was treated by decompression, either from front or from behind. We introduced the concept that you can realign the joint, you can stabilize the joint, and you don't need decompression. This was what we described in 2004, that transoral decompression is not necessary. This kind of entity, the whole world was doing transoral decompression. We said this is clearly unstable. This is clearly not a fixed anomaly, which it was considered previously. You don't need decompression. You need realignment and stabilization. So over the years, we have treated hundreds of these patients where we have not done any kind of decompression, which was the norm earlier. And stabilization is the issue. So facetal instability as a cause of basilar invagination, we talked about in 1999. And we said that in basilar invagination with or without Chiari, with or without syringe, basilar invagination listhesis at the facet due to weakness of nape of muscles, nape of neck muscle is the problem. Stabilization is the treatment. And transoral surgery, as you have seen over the years, has been completely demolished and has been put in the realm of history. Chronic atlantoaxial instability, there are several natural reparative gains that happen, which are all protective, all indicating unstable spine like Chiari malformation, syringomyelia, degenerative spine, deformities, OPLL, Hirayama disease are all due to unstable atlantoaxial joint. So carefully see this slide. Atlantoaxial facetal instability is the problem. Instability is the issue. Stabilization is the treatment. There can be retrolisthesis. Instability is the problem. This kind of basilar invagination, even today, the whole world is doing decompression. I am saying without any doubt or any confusion, decompression is an absolutely nonsense kind of treatment. This is unstable. Stabilization is the treatment. The third clinical entity is even when the facets are in alignment, presence of basilar invagination, presence of platybasia, presence of assimilation of atlas, presence of Chiari, presence of syrinx, presence of clipal file abnormality are all indicators of unstable atlantoaxial joint. Stabilization is the treatment and decompression is a negative form of treatment. So chronic atlantoaxial instability, there are all these things which are mentioned here are secondary. They are all currently being treated by decompression. I am saying that they are all protective. They all indicate atlantoaxial instability, whether they are present in cohort. Cohort means when Chiari is with syrinx or Chiari is without syrinx or Chiari is with basilar invagination or without basilar invagination. So when these problems are present in isolation or in cohort, any of this, if you see only bifid spine, you do atlantoaxial fixation. If you do only C2-3 fusion, you do atlantoaxial fusion. So this is a huge, in my estimation, without any doubt, without any confusion, I am saying complete revolution in craniovertebral junction treatment. So basilar invagination is always secondary. It is always indicator of unstable spine and it indicates the need for stabilization. Both group A and group B basilar invagination indicate an atlantoaxial instability. Both indicate the need for stabilization. Now I am saying even realignment may not be necessary. So basilar invagination, Chiari malformation, syringomyelia are all secondary to atlantoaxial instability and atlantoaxial stabilization is the treatment. This kind of Chiari and syrinx, you know the whole world will do with decompression. I am saying absolutely negative form of treatment. You might like to see the facets, they are unstable. Even if the facets are not unstable, no atlantodental interval disturbance, no compression, atlantoaxial stabilization is the treatment, and magic is the clinical result. No problem here. Look at the facet. Even when the facets are in alignment, this entity of Chiari and syrinx is secondary. It is protective, it is reversible, and magic is the outcome after atlantoaxial fixation. So basilar invagination with or without Chiari, Chiari without basilar invagination, syrinx without Chiari, and things like that, present discretely or in cohort. Tight posterior fossa concept, which we introduced in 1998. Tight. I'm saying it is never tight, and foramen magnum decompression is never the treatment. Over the years, we have now treated hundreds of patients of this kind where we have treated with only stabilization, and syrinx has reduced in 100% of cases. More important is patient has improved dramatically. And if you have you please go through this article where my experience on this subject is very elaborately discussed. So Chiari is not a malformation, it is a formation, it is protective, it is a nature's airbag. Syringomalia is not negative, it is not harmful, it is helpful phenomena. This I introduced this article in 1996. And you have seen the number of patients undergoing syringostomy is remarkably reduced. So when syrinx is present in isolation or discretely without Chiari, or with Chiari or with basilar invagination without Chiari, it is called idiopathic syrinx. This needs stabilization and there is no other treatment. Cervical fusions are protective. They are secondary. You see, there is no compression here. Multiple bone fusions, they indicate unstable atlantoaxial joint. You stabilize, difficult to stabilize, but that is the treatment. Bifid is secondary, it is protective. Bifid, you see, we always talk of embryological problem in bifid. It is not embryological, it is nature's protection. When you see bifid, you don't see here and there. When you see multiple fusions, you don't see here and there. You do atlantoaxial fixation. When you see short neck, torticollis, this kind of problem, immediately do C1, C2 fixation, and that is the treatment, and magic is the clinical outcome. That is what I have to say about craniovertebral junction. Short neck, short spine, short body height are all indicative of basilar invagination, all indicative of atlantoaxial instability, and atlantoaxial stabilization can give such beautiful outcome. Central atlantoaxial instability can cause kyphoscoliosis, like it causes short neck causes torticollis, short spine causes kyphoscoliosis. When you see kyphoscoliosis, don't come with multiple screws and rods and things like that. Look at the craniovertebral junction and you will find unstable atlantoaxial joint, and stabilization can create magic, a magic that you can, breathing will recover, deformity will recover, limb weakness will recover, and number of things will happen. So central or axial atlantoaxial instability is absolutely a new phenomena. So when you see syrinx, when you see bifid, you do atlantoaxial fixation. So my understanding is foramen magnum decompression is a surgery of history, and no, don't ever do it. Now I go to degenerative spine in a different version. When we talk of degenerative spine, we always talk of disc. Disc is the problem, disc space reduction, disc water reduction, and disc herniation. We talk of always of disc. My feeling is disc is divine, disc can never go wrong. Problem is the muscles, instability at the facet is the issue. Now, I want to, degenerative arthritis of craniovertebral junction has seldom been discussed in the literature. So this was the first article where instability and degenerative osteoarthritis was discussed. Now, carefully see this slide. Reduction in the joint space, buckling of this ligament, Osteophyte formation is not a primary event. It is due to instability, vertical spinal instability. Osteophyte formation at the apical ligament, osteophyte formation here, osteophyte formation here is a result of segmental spinal instability. Stabilization is the treatment. Retroodontoid pseudotumor is not a tumor. It is secondary phenomena to vertical buckling of this ligament due to facetal problems. And this buckling, the need is atlantoaxial fixation, craniovertebral junction stabilization is the treatment. This retroodontoid pseudotumor is not pseudotumor. It is an osteophyte related to atlantoaxial instability, and stabilization is the treatment. When we talk of facets is the strongest. It is the fulcrum of all movement. Body is not as strong. Facets are strong. Spinous process is not strong. Pedicle is not strong. This is the strongest part of the bone. Use it for fixation. We have discussed C1, C2 instability as the cause of basilar invagination. We have discussed subaxial facetal instability as a cause of whole lot of problem of the spine. Carefully see this slide. Reduction in the interbody space. Osteophyte formation, bulging of these discs are not primary processes. They are due to vertical instability manifested first at the facet. Instability is the issue. These are secondary, these are protective or adaptive, and these are all reversible following segmental stabilization. So vertebral facetal instability is the issue in degenerative spinal disease. About 17 or 18 years ago, we introduced these facetal spacers as treatment. Distract the facet, introduce the spacers, and this results in stabilization, and arthrodesis is the ultimate clinical outcome. This introduced for me a new concept in spinal degeneration. No decompression was done for the first time in the literature. This kind of buckling of the ligament, buckling of ligamentum flavum, bulging of the disc are all secondary to vertical instability. So we introduced these intra-articular spacers. This was my treatment 20 years ago. Multiple areas of multiple facetal spacers, and you see a new disc is formed, the bulge is gone, and more importantly, the patient has improved dramatically. So the whole concept of spinal degeneration surgery is decompression, whether there is kyphotic deformity or whatever. So my concept was there is instability at the facet, stabilization and arthrodesis is the treatment. And during that time, I did multiple cases like this where there was no decompression, only distraction and arthrodesis. You see multi-segmental compression, and this is after surgery. And this is immediate post-operative period situation, multiple facetal distraction, no decompression. And this was the article published as cover page in Journal of Neurosurgery. And there was a lot of reluctance in the whole world. Now many people in the world are doing this kind of treatment, and there are several articles now published on this subject. Similar concept for lumbar canal stenosis, multiple level issues. We introduced intra-articular spaces, lumbar canal stenosis, no decompression, only distraction. So lumbar canal stenosis being treated by only distraction. This was described for the first time in the literature, and there are some new articles on the subject. But now I have changed further. If you have realized decompression of the compressed and deformed neural system was the basis of surgical treatment for several decades, it is still the treatment. In 2013, we said that there is no need for even distraction, only fixation as the treatment for cervical spondylosis. In 2020, I published my series with multiple cases where we have said, you read the title of the article in World Neurosurgery, muscle weakness related spinal instability is the cause of spinal degeneration, and spinal stabilization is the treatment. There is no mention of decompression. There is no mention of discoidectomy. There is no mention of corpectomy and things like that. You see multiple segmental compression. Compression is naturally protective or adaptive. It is not harmful. Identify which segments are unstable.
most important issue in spinal degeneration is identify which segments are unstable by compression, by osteophyte formation, and various issues are there. Only fixation, no decompression. After 18 months of surgery, you see the whole spine has all these compressions have reversed. This is another patient, multi-segmental. The gold standard today is treatment is laminectomy, even today. Many people will do multi-segmental corpectomy, and the whole world has said multi-segmental corpectomy can create a lot of negative clinical implications. Many people still in the world are doing laminectomy and laminoplasty for such a situation. This patient has undergone only transarticular fixation, and after 16 months of surgery, you see the entire phenomena has changed. Most importantly, I say on multiple occasions, and I have shown in multiple workshops, magic is the clinical outcome as soon as the patient is reversed from anesthesia. So degenerative myelopathy, cervical or lumbar, we should look into from a different eye, not from an eye of compression and not with the vision of decompression. Instability is the cause of symptoms and stabilization is the treatment. So I use this Camille's technique of fixation. I sometimes for cervical, I use 2 screws. More often for cervical, I use 1 screw. For lumbar, I use 2 screws, and sometimes I use 3 screws, but not 1 screw for lumbar. If you ask me what is the key issue in degenerative spinal disease, the key issue is to identify which levels are unstable. And that is the key issue. In this case, you see there are 2 segment compression, but I have done 4 segments or 5 segments of stabilization. Why for 2 segment I have done? That is the key issue in spinal degeneration, and you have to read my article on that subject. And this is after a few months of surgery. You see the whole spine has changed. The entire radiology has turned magically different. This is another case. You see multi-segmental. There is no decompression from front or from behind, and there is only stabilization and facetal stabilization using transarticular screws, and sometimes there is a spacer also in the midst. So over the years, I have done several hundred cases now where where I was myself doing decompression from front or from behind. I have not touched any lamb bone part. I have used the lamina for stabilization and arthrodesis, transarticular fixation, a beautiful technique. Atlantoaxial instability in degenerative spine nobody has ever discussed that atlantoaxial instability can be present. My feeling is atlantoaxial instability is very frequently present in multisegmental spinal degeneration. Multisegmental spinal degeneration, no compression, but there can be facetal instability. Even if there is no facetal instability, this can be unstable. I used to do this kind of fixation for C1, C2, but now I have changed. More important is only fixation, there is no decompression. When the patient comes with severe myelopathy, patient comes on a wheelchair or on a trolley, atlantoaxial instability is very frequently present. This patient, you see, not much issue, but this patient was on a wheelchair and there is no compression. You see this problem. I have included C1, C2 in the fixation construct, not in the decompression construct. Now I have, as I mentioned, I have changed my technique of C1 fixation. I don't introduce my screw in the C1 facet. I do C2, 3 fixation and remove the spinous process of C2 to avoid all movements of the region. And I have to tell you, and you have to believe me. And if you have to, I have no way to tell you how magic can be produced. Lumbar canal stenosis, this term stenosis, and this paper published in Neurosurgical Focus, of which Bill Colwell is the editor. I know it was not easy to publish this article, but read the title, Analyzing the Role of Stabilization and Futility of Decompression. When you talk of stenosis, stenosis means stenosed canal. Decompression is the treatment. I am saying stenosed canal indicates a multi-segmental spinal instability, and stabilization is the treatment. This kind of multi-segmental stenosis, it is not a stenosed canal. It is a multi-segmental unstable canal. When a person becomes old, person becomes weak, his muscles give way. And when his muscles give way, he becomes vertically short. Like I have talked on several occasions, your grandfather is shorter than you.
Why is shorter? Because the whole spine has become vertically compressed. And when it becomes unstable, there are symptoms of pain. Why your grandfather always keeps on complaining of backache and neck pain? Because he's vertically becoming unstable. He needs stabilization. So this kind of stabilization can produce magical clinical outcome. Only issue is identify which segments are unstable. The issue in the entire field of spine surgery is to resect osteophyte. Whether you resect from front, whether you make space for the osteophyte, my answer to that question is osteophytes are divine intervention. Osteophytes are protective adaptations. Osteophytes should never be touched. They should never be handled. What is to be identified, which segments are unstable and stabilized. So this beautiful article of mine shows what happens to osteophytes after 12 months of stabilization. These multiple segment osteophytes are not a problem. They are not disease. They indicate an unstable segment and they indicate the need for stabilization. They do not indicate the need for decompression. So this kind of multi-segmental compression by osteophytes do not need decompression, they need stabilization. Another very important issue in spine surgery is kyphotic deformity. Kyphotic deformity, in my estimation, and in this article it is mentioned, is a result of multi-segmental spinal instability. This identify which segments are unstable and stabilized. This patient needs C1, C2 stabilization. This patient needs segmental stabilization. This patient needs C1, inclusion of C1 in the stabilization construct. More important is this kyphotic deformity. Do not do any bone work. Do not remove bone either from front or from behind. Identify unstable segment and stabilize. Another very magical concept. Bill, you please hear this. Prolapse disc, the entire world, entire corner of the world will do disc resection, either by endoscope or by microdiscectomy or whatever. I am saying disc herniation is a result of segmental spinal instability. Disc herniation is a protective natural response. You do stabilization, and when you have a disc herniation, you give a collar. When you give a collar, there is no pain. But when you move like this, there is sudden pain. You wear a belt, there is no pain. The entire concept of degeneration herniation is that you give complete bed rest, don't let him move. And if you don't let him move, he will be all right. But when he moves, he's not all right and he comes for treatment. I am saying instability is the issue. This kind of disc herniation, the entire world of spine will do ACDF. But I am saying even the upper segment may be unstable. Identify, this is the key. Which segments are unstable, which segments need stabilization. This herniation will resolve in no time. So this is whatever statements I am making are all published and published in high profile neurosurgery journals. This is in World Neurosurgery. Facetal fixation arthrodesis is the treatment of cervical radiculopathy. Lumbar radiculopathy, disc only fixation is the treatment. This kind of disc herniation, you do fixation and see the magic. You see the magic. Have the courage to do fixation. Problem is compression. Oh, this is nerves are getting compressed, nerves are getting stretched. If you have that, you will never be able to go beyond what you are doing. Last thing which I am going to say is a magic of another kind. OPLL, the whole world is doing decompression. I was doing decompression for a long time. I described this technique of oblique corpectomies several years ago for OPLL for the first time in literature. But now I am saying OPLL is secondary to unstable spine and only stabilization is the treatment and magic is the clinical outcome. I promise you. Most important thing that you have to identify is which segments need to be stabilized. Just what you see on images. If you see 3 segment, you don't need only 3 segment. Here also there looks some problem. Here also there looks like some problem. Identify which segments are unstable and stabilize those segments. Atlantoaxial instability is very frequently present in OPLL. You have to include atlantoaxial joint in your fixation construct, not decompression. As I mentioned, I don't do this C1 direct fixation. Nowadays, I do subaxial C2-3 fixation and go further down. So this kind of OPLL compressed, nerves are compressed, and this is compressed and that is compressed. Compression is divine intervention. Compression is natural protection and adaptation. Don't worry of compression. The whole world of spine surgery has only one issue, compression. I'm saying compression is not the issue. Don't worry of these nerves getting squeezed and compressed. Identify that this is unstable and stabilize, and that is the treatment. So atlantoaxial and subaxial fixation, it can revolutionize the treatment of OPLL. It can revolutionize the treatment of lumbar canal stenosis. It can revolutionize the treatment of cervical canal stenosis. It can revolutionize the treatment of disc herniation. It can revolutionize the treatment of Hirayama disease. It can revolutionize the treatment of kyphotic deformities and so many other things that we have all seen in spine. So my vision is in spine surgery, decompression is soon going to become historical. Compression is never a primary issue in spine surgery, and decompression, my dear friends, is never the treatment. Thank you very much. Is there any questions for me?
It's an eye opener, I have to say. It's a revolutionary concept, and you always been thinking about these things and going to the root problem rather than much more than all of us. And I remember what I remember most is that in long time ago that you should, especially for the neurosurgeon, you should think more and operate less. But in your case, you think more and operate more as well. And clearly, these are quite a courageous concept you're proposing, and I hope this will be taken up for the general neurosurgical population. I don't know whether anyone wants to make.
Thank you. Thank you, dear brother, for this amazing lecture. And thank you for emphasizing for that compression is not the main play role in spine surgery, and we have to find the primary pathology. But you have shown us, as we have seen, most of them are cervical spine, and the cervical spine is rewarding in its intervention. It's not the same equation when we deal with lumbar surgery. The solution that we are always saying is fix and fusion, fix and fusion. And we have a lot of issues with fix and fusion because we have many problems and troubles with fusion too. So what's your vision for the future?
Let me answer that question. You know, I operated 16 cases in Egypt 4 weeks ago, 16 cases. Why don't you go and follow up those cases, my dear Samay? I know there will be some difficulty, but you must follow up. Or you can ask the doctors. See, this is a new concept. In my view, this is the future. And now I am not basing this concept on 1 or 2 or 10 or 15 cases. Now I have got hundreds of cases, hundreds. And I have been talking, there are at least 100 articles of mine published in various journals. So it is very heavily published and very on the basis of a large personal experience. And many of my own fellows and students and many people in the world are now following this concept. It is not that it is now in isolation. And my dear Samay will also follow these concepts very soon if you have not already started. All in all, I wish that, I have talked on various issues in very quick time. I have talked on Chiari, I have talked on searing O'Malley, I have talked on basilar investigation, on degenerative spine, on OPLL, on this. In 20 minutes, the whole spine I have covered. I will suggest you read my articles. And if you are free to discuss with me at any point of time, and I'll be happy to talk to you or with anyone.
Okay, thank you.
Thank you
very much.
Thank you.
Thank you, Doctor, for the excellent presentation. Now let me invite Dr. Abhidur Shah to talk on topic white matter and glioma surgery.
So good afternoon, everybody. And let's move a bit from skull base and spine to intraaxial brain surgery. So as we all know that glioma surgery has advanced in the last few years, and these advances in high-grade glioma are basically because of the dyes that we use. In low-grade glioma, the strategy has changed from doing only observation to taking a biopsy to now supramaximal resection or radical resection for low-grade gliomas. A lot of technology has come in to identify white fiber tracts, to identify functional areas in the brain, so that you can do a safe surgery without causing too many neurodeficits. A lot of intra-op imaging has come into picture, and now you saw yesterday IPS OT, and it has gone to a futuristic level. So this is intra-op MRI, intra-op ultrasound, which are quite useful when doing glioma surgery. What has not changed is this: the understanding of the anatomy of the cortical and subcortical structures of this magnificent organ that we treat every day. Now this is how we look at it. Earlier we used to look at cortical areas which were eloquent, but now the whole philosophy has changed to vodotopic. And the human neural network consists of nodes, which are cortical areas connected by a series of edges or links, which is the subcortical grid. And it creates the most fascinating grid of motor, sensory, autonomic, and emotional function. So white matter is not a passive conduit. It is a dynamic, active tissue with insights into brain function. You actually, if you damage a cortical area, there will be some cortical area which might take over and because of the plasticity. But if you disconnect the white fiber tracts, if you connect like in a train line, if you disconnect the wires, disconnect the track, the train is not going to function. So this is how the whole picture now comes into play. It is connectomics. There are areas of the cortex which are connected to each other by white fiber tracts, and the whole system works together to perform a certain function. So this is the semantic or the ventral pathway of language, and the constituents of this are the superior temporal gyrus, the middle temporal gyrus, the superior temporal sulcus, the dorsolateral prefrontal cortex, the angular gyrus, and the white fiber in play here is the IFOF, of course, with help from the ILF, the uncinate, and the middle longitudinal fasciculus. So you damage the IFOF on the dominant side, you will have semantic paraphasias. On the non-dominant side, you'll have non-verbal comprehension disorders. Similarly, the phonologic or the dorsal pathway is mediated by this arcuate fasciculus, which is the direct component, and the SLF3, which is the indirect component. And the cortical substrates are the middle and in the inferior frontal gyrus, along with the superior temporal gyrus. So if you look at this image, this table shows the damage or the deficits that can occur when you damage the white fibered pathway. This is a pictorial representation of the same. So you see, you damage this SLF, you damage this arcuate, you will get speech arrest, dysarthria, and repetition errors. You damage the IFOF, you'll get syntactical errors and semantic paraphasias. So all these fiber tracts are actually important, and it is important to understand the anatomy of these fiber tracts before embarking on intraaxial brain surgery. So this was our paper on the subject, which defined white fibers not based on association, projection, and commissural fibers, but based on the direction of their anatomical structure and on the depth from the surface. So we divided the white fibers into these layers. So there were 4 horizontal layers and 1 vertical layer. The first one here is the superficial group, which is the short arcuate fibers. The second one here is the middle group, which is the long association fibers. The third one is the group in association with the ventricle, or the deep group, in which there is the fornix and a lot of other fiber tracts. In the center, you have the commissural fibers that you see in red here. And majority of these commissural fibers lie between this vertical group of fibers, which consist of the projection fibers, that is the internal capsule and the thalamic radiations. Now we have studied on surgical aspects of glioma, on how to, we have gone into molecular pathology, we've gone into how to identify the cortical eloquent areas and stuff. But we've still not gone into the basis of glioma. Where does this glioma rise from? So this is a very old paper from Yasser, who said that gliomas grow and they invade along the vascular structures. So they follow a vascular pattern, and he thought that they have a wedge-shaped configuration and they go towards the ventricle. Now we know about neural stem cells and the origin of gliomas. We know that There are multiple regions of the adult brain where these neural stem cells can be formed. They have been isolated from the subventricular zone, the lining of the lateral ventricles, the dentate gyrus, and the subcortical white matter. So this is the key, the subcortical white matter, where the glioma can originate from. And based on this, and looking at a lot of radiological images, correlating this radiology with the anatomical understanding, we have come to this concept that gliomas are surgically confined to a named white matter tract. Histologically, they may be diffuse, they may, go, but they are confined to, they arise from a named white matter tract. They displace the adjoining tracts. They do not destroy them, they displace them. The involved white matter tract may be, of course, affected, but the other ones are normal and they're displaced around the tumor. So we defined these gliomas into types based on this radiological and anatomical understanding into diffuse and localized type. So if you see this tumor, where is it arising from? It is arising from the short arcuate fibers that harbor these gyrus. So this is a localized type of glioma. This is a diffuse type of glioma which arises from the long association fibers. So if you see, this is the cingulum, and you see this projection of the cingulum going towards the precuneus. The glioma actually tracks along this, as you might see in later radiological images. And this is the other type of diffuse glioma when it arises from the commissural fibers. It tends to be bilateral, as we all know, corpus callosal gliomas, and they grow towards both the sides. They remain confined within this vertical group of fibers, which are bordering them laterally. So based on this understanding, we devised a strategy of en-masse tumor resection for low-grade gliomas based on the understanding that they arise from the short arcuate fibers that harbor that surround the gyrus. If they go to the other gyrus, it is by means of these short arcuate connections. So let's look at this tumor. This is a tumor in the supplementary motor area. This is the precentral gyrus, the central sulcus, the postcentral gyrus. And this is the corticospinal tract based on tractography, displaced posteriorly. This is the supplementary motor area as we know it anatomically. And this is the strategy, surgical strategy. This was proposed by Professor Goel. We used to use a lot of intra-op monitoring earlier, but the need of our intra-op monitoring has actually reduced now because our anatomical understanding has increased. And now you can see that this plane of tumor resection can be easily identified, and the whole tumor can actually be defined by using this plane, and you can remove it like a meningioma in an en-masse fashion. To identify these boundaries, you can do it visually as you have once you gain experience, but in the initial time, you can use neuronavigation to define the craniotomy. You can use an intra-op ultrasound to define the anterior and the posterior margins of the tumor, and then you can go around the whole tumor and remove it in an en-masse fashion, as you can see here. So in the depth of this tumor resection, you will actually see the white fiber tracts that have been retained, and the tumor only is being removed. So this is quite a radical resection of the tumor. And we are removing the tumor with the concept that we are removing the short arcuate fibers around the tumor and removing it in en-masse fashion. And you see the normal subcortical network that is lying in the depth. So this was the radical tumor resection after the surgery, and you see that the MEPs have been maintained. This is another tumor that is there again in the supplementary motor area. You see that it is protected here. It is not crossing that boundary of the vertical group of fibers. And here we have gone interhemispheric. But here you can see that we've gone in the depth as the tumor was in the depth right up to the corpus callosum. And this patient, this is the video, this patient developed an SMA syndrome after the surgery. Now you can see this defining by visual inspection, defining the boundaries of the tumor. And then once you enter it, there is definitely a well-defined plane which can be identified. And the tumor can be removed. You also see that there is hardly any vascular damage by using this. There is no coagulation in this whole procedure. And you do not injure any major vascular network. And here you can again see that the tumor has been removed in an en-masse fashion with all the vessels surrounding it protected. And this is actually the motor cortex posteriorly. So this was a recent subject. So when we analyzed all our cases with supplementary motor area syndrome, we realized that if you manage to preserve the cingulum, if you do not go beyond the cingulum and you do not enter the corpus callosum, You will also prevent injury to the frontal aslant tract, which lies at the same level laterally. So this is the frontal aslant tract, as you can see here, and it lies at the same level at the cingulum. So if you restrict your inferior margin of resection to above the cingulum, you will not cause the supplementary motor area syndrome, as we have written in this paper, and you can read it if you're interested. So these are some images of tumors that we've removed. You can see they're in quite critical areas of the brain close to the motor strip and removed in an en masse fashion. And patient did well without deficits. We used to use a lot of functional MRI, a lot of tractography, but the need of this has decreased as our anatomical understanding has developed. Now you see this tumor, it's in the Broca's area, right here. It's in the pars opercularis, in the classical Broca's area. And this patient was not at all ready for an awake surgery. He absolutely was not cooperative, but we used our understanding to remove this tumor again in a similar fashion. You can actually make out the boundary between the normal and the abnormal. You can visually inspect and see that there is tumor here. And we are forming this boundary and removing the tumor in an en masse fashion. With all the vessels preserved. And this is at the end of resection. And this is the patient on day 1 of surgery. It's in an Indian language, but you can see that he's speaking. I think the audio is off, but he's speaking very mild dysarthria, and he did very well after the surgery. This is again another tumor, again in the same region, in the region of the pars opercularis. And if you see this image, here you can identify the pars opercularis, this U-shaped structure, and you can identify the whole tumor in this region. So this is the ultrasound that was done, and this is the post-operative resection cavity after I've removed the tumor in an en masse fashion. And this is the post-op ultrasound. And here you can see the tumor, and this is the post-op resection cavity. This patient also did very well without any problem. So insular gliomas are the next thing that are coming in, because a lot of low-grade gliomas harbor in the insula. And you have to understand all these networks that connect the insula to the higher structures and to the subcortical network. And also you have to preserve the middle cerebral artery branches. These are the 2 keys in performing insular glioma surgery. So here you can see an insular glioma that has been radically resected, and you can see the post-operative images. Coming to the limbic system, this is again another important system which harbors low-grade gliomas. So here you can see this is the Pape's circuit that we have dissected. We have done this quite a long ago, and it's a very highly cited paper. Here you see the hippocampus, the fimbria, the fornix, the mammillary body, the mammillothalamic tract, the anterior-thalamic nucleus, the anterior-thalamic radiations, going to the cingulum, and the cingulum coming back here in the region of the hippocampus. And this is how the cingulum connects to the precuneus or the higher cortical structures. This is the Pape's circuit that was dissected outside after doing the dissection in the brain. And this is a paper on the subject. Again, based on this understanding, we've devised a medial temporal approach to medial temporal tumors and also for epilepsy surgery. So this was originally done by Professor Goyal in, I think, 1990. And this is the fundamental behind it. If you see this region, this orange area, this is the anterior part of the temporal horn. You see the fiber bundles in this region. This is the IFOF, and this is the whole body of the sagittal stratum. So in this anterior part of the temporal horn, there are no fibers. They are all in the roof, and in the posterior part, they are in the lateral wall. So if you're able to make your entry here, you are beneath these fiber bundles. And if you retain your resection below the roof of the ventricle by going in this direction, you will not cause damage to the IFOF or to the optic radiations. And this is the surgical position that we have, vertical structures that we've removed while doing mesial temporal sclerosis. So this was our paper on the subject. Just 2 minutes more. So this is a tumor in the region of the uncus. So the anterior part of the uncus is the amygdala. The posterior part of the uncus is the hippocampus. And we've used this middle temporal gyrus approach to resect this lesion. Again, another tumor that is going both in the amygdala and the hippocampus. Again, using the same approach, we've removed the tumor. This is a tumor in the isthmus of the cingulum. It is not in the corpus callosum. It is unilateral. It is going towards the fibers of the cingulum as they are going to the precuneus. And this was resected using an interhemispheric approach. This is an orbital cortical approach to deep-seated structures, especially to lesions in the caudate head. There is no major fiber bundle using this trajectory. You can come from the middle orbital gyrus or the lateral orbital gyri, and you will reach the frontal horn. And this is the tumor, and this is the resection cavity. Lastly, coming to the corpus callosum, this is a magnificent structure again that connects each part of one hemisphere to the other. And it is a embodiment of placental mammals. Before placental mammals, the anterior commissure was carrying the information, and now it is the corpus callosum. And these are the way we have divided into dorsal, anterior, posterior, and ventral callosal radiations. Callosotomy, we advocate it should be performed transversely so that you displace the fibers and do not cut. This is a region where the motor fibers connect, and you should not perform a callosotomy in this region. And it's a tumor that we have resected using this. I'm not going to go into this. Lastly, this is the brainstem, and we are studying this. We've divided the brainstem into multiple zones and defined our safe entry areas to enter into it. And for those who are interested, this is our book on the subject. Thank you very much.
Thank you with the great talk. Yeah, I think we are running out of time, so.
Thank you, Doctor. Now I'd like to invite Dr. William Codwell to talk on topic petrol soil melanomas. Where are we?
Where's the okay. No, just where's the plug you just took it?
I mean, you can make the one. Yeah, and now I'd like to invite Dr. Aipcharian to felicitate Dr. Adil Goyal. Invite Dr. Aipcharian to felicitate Dr. Abhidar Shah.
Thanks, Ron. Thank you very much. After this. Next week.
Great. Well, I think we'll get started. It's an absolute honor to be here to see my many Indian friends. And also, I just want to acknowledge Ike for organizing a terrific meeting and his lovely family, who I spent a week with last week in Ladakh. And it was just an absolute honor to be there. And to spend time with you and your beautiful daughters and wife. I want to acknowledge Takanori Fukushima, who we lost this year. He was a great mentor for me. He was probably the most influential surgeon that had a impact on my thinking about surgery. He was innovative and avant-garde, and he was always thinking outside the box. Brilliant man. And I thought about, since the theme of this meeting was what's new, I think there's a lot more going on in orbital surgery right now than there is in petroclival meningioma. So I'm going to talk a little bit about orbital surgery and also a big series of sphenoorbital meningiomas that we're just publishing right now. So this is where I'm from. This is the foothills of the Rocky Mountains. It's a beautiful place to live. And southern Utah's parks. I don't have any disclosures relevant to this. But the interesting thing is that we get a lot of extensive disease. And I just use this case as an exemplifier of the problem we have with skull-based surgery. So this was a adenoid cystic carcinoma. And what's the appropriate treatment for this tumor? Do you know? Does anybody know? And we don't have any like level 1 or 2 evidence on how we treat skull-based tumors. This patient had hidden in her cabin in Montana. She'd been blind for 2 years. And so we decompressed her to save her life. But again, the oncologist didn't have any idea of how aggressive we should be surgically. So we have to rely on the experience of surgeons. And I would say that skull-based surgery, I think, is a lot more challenging than most aspects of neurosurgery, in that every tumor is different. And everybody in this audience knows that. And you can look at a tumor that you think it's going to be easy and it may be difficult. It's variable in size and texture, location, whether it's adherent to the arteries, as compared to a lot of other things that we do and other surgeons do that are very stereotypic. And so I think the challenges of skull-based tumors are significant. So let me show you this case. Here's a 45-year-old man. He's got sleep apnea. He's got obesity like most Americans. And he has a proptotic eye and chemosis of his eye. And he's got a mass in his eye that's highly enhancing here. You can see this. There's phlovoids with it. So we thought it was probably a vascular malformation. You can see what's interesting about this is that it's fed by the ophthalmic. Okay, so that scared our interventionalists off, and it's got a single draining vein, the superior ophthalmic vein. So they turned this patient over to me to operate on. And just think, this is an example of cranial disease that's occurring in the orbit, okay? And all the theme that I have here is that we should be familiar with the orbit so that we can treat disease that's really in our wheelhouse, okay? So we'll do a transcranial orbitotomy here. Open up the lateral wall of the orbit, superior orbital fissure. I'll find the ophthalmic artery and I'll trace it out. So we'll decompress the optic canal and do a clinoidectomy, as you've seen so many times today. And then we'll go ahead and open up the orbit and find that AVM and selectively take the feeding vessel off the ophthalmic artery so as not to blind the patient. Okay, so what I'm doing here is we're opening up the falciform ligament. We'll identify the ophthalmic artery here, and I'll trace it out and find the AVM. Now, I'm going to make the orbitotomy just above the lateral rectus muscle. If you come in below the lateral rectus, you'll have a risk of injuring the sixth nerve. So it's all about safe entry zones, just like the brainstem. Okay, retractors, which we don't use much in the brain anymore, they're perfect application here to hold back the fat. Okay, so I'm tracing out where the feeding artery should be. And what you'll see is identify the feeding artery to the AVM right there. And we'll tie that off, or I'll put a clip on it temporarily, and then we'll follow it out and identify the draining vein, which is this big, large superior ophthalmic vein. These AVMs in the orbit are very rare, but they're very much stuck to the fat, okay? They're much harder to dissect than they are from the brain substance. And you can see my partner there is holding back the orbital fat for me. We'll go ahead, single artery, single draining vein. We'll ligate the draining vein here. And then once we've done that, we've isolated the AVM and we'll remove the AVM. So again, it's just a simple matter of staying in the periorbital fat and dissecting around the AVM. It's completely killed at this point because we've stopped all the blood supply to it. And I'm just cauterizing the small feeding supply to the AVM and we'll remove it. And then we'll do an intraoperative angiogram. So fairly straightforward case, just like a grade 1 AVM in the brain. But our ophthalmologists, I don't know what it's like in your country, but our ophthalmologists don't do this kind of thing anymore. And so we'll do an intraoperative angio. You can see that there's no early draining vein. And so we'll go ahead and close and then treat him. He was fine. His proptosis got better. This is another unusual case. I don't think I have time to show all this, but this is the more common scenario that we find ourselves in. Middle fossa meningioma removed in 2004. You can see she's got proptosis. She kept going to the doctor saying, you know, I'm not feeling any better. And you can see she's got hyperestotic sphenoorbital meningioma. And these are characterized by thickening of the sphenoid wing, and tumor can grow into the orbit. It can grow into the extracranial space and obviously into the middle fossa. And as you see here now, into the cavernous sinus. So she has multiple Whittle surgeries that are suboptimal, and she has radiation, and then she ultimately has a prosthetic globe because she's lost her vision. The tumor is now filling the orbit and is threatening the contralateral cavernous sinus. So what we'll do in a case like this is we'll do a radical resection as a salvage operation and remove the cavernous sinus. I have a large series of patients that we've done this on, but the orbit is simple to remove. Frontotemporal approach, you come right down on the cone of the orbit. That's the prosthesis that we'll remove. You identify the ophthalmic feeder, which is the main supply to the tumor in the orbit, because that's where it's parasitizing the blood supply from. So once you clean out that, then you can just basically enucleate the contents of the orbit. And then we'll go ahead and remove the rest of the tumor, which is growing down in her deep face, and then remove the cavernous sinus. In this case, we didn't have to do a bypass because she passed a balloon occlusion test. But I do want to show you that this is what happens with these multiply recurrent meningiomas. And I'm sure many of you have experienced this, where the tumor is now parasitizing the main blood supply. This is the middle cerebral artery. I'm isolating the tumor vessels off the middle cerebral that are feeding the tumor as well. So you've got to isolate those. So you leave the en passage vessels, and then we'll go ahead and cut the optic nerve, ligate the carotid artery, and remove the tumor. And obviously this patient's had multiple radiation treatments, so she'll need a good closure. And so we'll do a fascial allograft closure, and then our head and neck colleagues will sew in a vascularized pericranium or vascularized thigh flap as well. So it's an all-day venture. It's risky, CSF leak, etc. Here's the post-op scan, but we've given her several years of life after this operation. And you wonder whether she would have been better served by doing a more aggressive surgery up front. So skull-based surgeons must be familiar with the orbit. And when I was young, our knowledge stopped here because we knew the cavernous sinus well, but we didn't follow it out into the orbit. And if you look at all the beautiful material that Al Roten has left us, he's done beautiful orbital dissections, the 7 bones that line the orbit. Be familiar with all those. And the structures are very interesting. Most of them come in lateral. Okay, 4th nerve, 4 crosses 3 of the superior orbital fissure, 3 staying lateral, and 5 here. So 3 stays lateral, divides into a superior and inferior branch. The superior branch feeds the rectus, superior rectus, and the levator. Here's V1, the orbital nerve, supraorbital nerve, crossing from lateral to medial. The superior ophthalmic vein does the same thing, lateral to medial. The ophthalmic artery, lateral to medial. The 4th nerve, lateral to medial. So once you take away the fat, the structures, important structures, are easy to note, and you can divine your safe entry zones at that time. We've written a review on this. There's 2 ways to think about orbital surgery. That is attacking tumors that are in the orbit traditionally, and the more conventional or contemporary way of looking at it now is using the orbit as a conduit to cranial space. And I'll talk about both of those briefly. So I'm a lumper, not a splitter. And so most of the lateral orbital and superior orbital pathology is done through a lateral orbitotomy or a transcranial orbitotomy. And the endoscopic approaches are absolutely beautiful for coming in inferiorly and medial, okay? And so there's lots of videos online, and we've got them as well. Here's an hemangioma, patients losing vision. You can see the optic nerve, endonasal approach. It's a chip shot and a slam dunk to remove that. I don't have time to show that. I do want to show this special group of schwannomas that you will find occasionally, and they're rare. But Sam El-Mefti and I had a series of these patients that we published together, and they're multifocal schwannomas of the trigeminal nerve. So you've got multiple involvement of the same trigeminal nerve or the same branch or multiple branches on the same side. It's a schwannomatosis in a very limited genetic way. And these require special treatment, but you can see in these cases, here's the tumor from the cavernous sinus all the way out into the superior orbit. And we had to do a transcranial orbitotomy and a cavernous sinus exposure. And I won't show you the video because of time. Fibrous dysplasia is a special problem too. And this is the worst case that I've ever seen. I've operated on this young man from Las Vegas about 7 times now. And I had to do decompressive craniectomies on him because the bone was so thick it was crowding his brain, you can see here. But obviously we've done several operations of the orbit to try and preserve his vision. It's an absolutely horrendous case, and it can be very vascular and very dangerous with blood loss. So what are the approaches that we might think of that can extend our idea of using a frontotemporal approach to optimize approaches to the orbit in a more minimally invasive way? So it was interesting. 1964 was the year that the term pterional was first used by Hamby. And it was really Yassergill, obviously, in the 60s and the 70s that popularized the frontotemporal approach that we use as a workhorse every day to anterior circulation aneurysms and the basilar apex. But actually, that's not the shortest way to get to the orbit. The quickest way to get to the orbit is to come through the face. And if you have a cancer patient like this, you can come in, and it was evident to us that when we did these large cancer cases and removed the facial part of the tumor, it's a squamous cell tumor in this case, you found the anterior loop of the carotid and never had to retract the brain. Okay, so that's the most direct route to the anterior cavernous sinus and the orbit, is to come straight at it. And the patients tolerate these procedures well. There's no brain retraction. You don't even expose the dura in some cases. So the quickest way is right down the lateral orbital wall, and also transmaxillarly. It's about 3.5 to 4 centimeters from the maxillary sinus to the orbit and cavernous sinus. So think about those as optimal ways of reaching anterior orbital and cavernous sinus pathology. We published this little approach a decade ago now, but basically the idea is that we took an ophthalmological approach and we used it to enter the cranial space, the cavernous sinus, the middle fossa. And now it's being developed by a lot of people using the endoscope especially, and about using it as to expose lesions of the middle fossa as well. And the beauty of this approach is that you come in underneath the temporalis muscle. So you don't touch the temporalis muscle, they don't get temporalis wasting. You're just coming down the lateral wall. We modified it so we leave the lateral wall up, but just follow the lateral wall back, and it puts you right on the anterior cavernous sinus and into the middle fossa. And we've done cavernous malformations and such. You'll see the list of cases we've done this way. Amol Raheja, who's now an attending at AIMS in New Delhi, was my fellow right after this, and we published many modifications of the approach with the mole. So you can actually use it for cavernous sinus meningiomas. Here's a case. You can do a clinoidectomy through that approach. You can see there's no temporalis wasting. You've got a little incision along the lateral canthus that heals very well. Here's a large cavernous malformation. You can see the trajectory. You're coming right through the anterior tip of the middle fossa with that approach. This is a couple of years ago now, but you can see the various things. It's really good for epilepsy, actually, because you can follow the medial temporal structure straight backwards. And again, many people now have advanced this and done a beautiful job at using the orbit as a conduit to the intracranial space for meningiomas, for lesions within the brain. So I think it's an active area. It's a very active area of skull-base surgery. But let me talk the last few minutes about sphenoorbital meningioma, which I've given a lot of thought in over the years. And we've just got a paper that's going to be published with 90 cases that I've done. And I'll show you the technique that I use for them, because I think they get undertreated by a lot of people. Here's a classic case, middle fossa meningioma. Woman's got a dry eye, an exposed eye, a tense eye. She's painful, and she says she's not getting any better. And that her neurosurgeon was telling her, well, there was nothing there. But of course, the sphenoid ridge is completely hyperostotic. Hyperostotic bone is tumor in the bone for the young people. So that should be removed to forestall recurrence. So you can see the tumors recurred extracranially. It's occurred in the orbit, and it's recurred in the middle fossa in addition to all the hyperostosis. This is a very extreme case. But what I've done is I've progressed over the years to do a much more extensive resection. And we published this technique, and this whole series that you'll see has been using this technique now. And I'm going to show you some of the results of that. But basically, the rim is classically uninvolved, which is really to your advantage. So you can leave the anterior leading edge rim, but take all the bone out behind it. And I look at the CAT scan and see where the bone is thick. And I drill all the thick bone, including the middle fossa floor, right back to the carotid artery if you have to, and the petrous bone. Here's a classic case, again, another case from Nevada that was treated but had hyperostotic bone. And you can see how exposed his eye was here, and we remove all the bone here, okay? So let me show you how I deal with the tumor in the orbit, which is the real basis of what I'm trying to talk about today. The rest of this is this lady from Eastern Europe that had this extensive tumor. I'm going to show you just the technique of how I deal with the orbital. So again, I've drilled all the roof of the orbit, and I've started to develop a plane between the involved periorbita and the periorbital and the orbital fat. And you just keep going posteriorly, and you keep that plane. The periorbital fat, and the fat is your friend, is protecting all the important structures. You go right back to the region of the annulus of Zinn, okay? And you'll have to decide, in some cases, obviously the muscles will be invaded. You'll have to decide how aggressive you want to be. Now, I used to reconstruct the orbit with these cases, but I completely eliminated doing that, and I'll show you why. Here we're into the maxillary sinus and the frontal sinus, so we plugged that. But I'm going to show you what this decompression is like. So here's her post-op scan immediately. You can see how propped up she was, but look at her optic nerve now. It's like a road course. She's completely been decompressed. So that's what we try to aim for when we do these decompressions on these people. So 2 weeks later, we'll bring her back to a custom cranioplasty, and you can see her eye here that I'll show you at the end of the cranioplasty. And this is 2 weeks after surgery. And you can see here's preoperatively and now 2 weeks later. So she's had a remarkable improvement. So do you get enophthalmos when you remove that much bone? You don't. And then none of them overcorrected. This is a proptosis index comparing to the bad eye to the good eye. It never overcorrected. And I think the reason that it doesn't do that is because there's so much disease around it. It scars in and it doesn't overcorrect. If you decompress a normal orbit like that, you'll have bad enophthalmos, but you don't get it with these extensive orbital meningiomas. So we graded it into 4 grades. Grade 1, we define as the sphenoorbital bone itself is hyperostotic, maybe have a middle fossa tumor as well. Grade 2 starts to involve the periorbita, very common. We think both of those are easily resectable, and you should remove the periorbita that's involved with tumor. Grade 3 is much more complicated. It's not involving the lateral rectus in most cases. And grade 4 involves the posterior aspect of the orbital apex around the optic nerve. And it defies surgical treatment in my mind without hurting the patient, causing visual loss. So the resectability, grade 1, grade 2, grade 3, depends on what you want to do with the muscle. If the muscle's invaded, you can remove that as well. And then grade 4, we do a maximal safe resection and call it a day. So radiographically, this is what it looks like. Here's grade 1, only involving the bone. And here's the post-op scan. Grade 2, bone and periorbita, easily resectable. You should take the time and peel it off. Grade 3 is much more complicated. You see here. But I'm going to show you one last video showing that you should take a look and see what you can do. Okay, so here's a case. This case I'm showing you. We thought this was at least a grade 3. We didn't know how well we were going to do. So Here we're doing a left frontotemporal approach. Here's the orbit. And what we'll do is you start where you know where you're at. So start back at the apex, lift up a pericranial flap or the dural flap over the optic nerve, drill the canal, open up the falciform ligament, decompress the nerve because they often get visual loss from bone involvement. Here, look at that clinoid. It's all filled with tumor. Okay, open up the falciform ligament. So once you've done the apex of the orbit, then remove the bone of the roof and the lateral wall of the orbit. There's the ophthalmic takeoff. I open up the falciform ligament so I don't leave tumor in the canal, the dural canal itself, because that's an early nidus for visual loss if it does grow. Okay, so once you've done that, we'll go after the tumor in the orbit. And so again, take off the bone right up to the rim, and you'll find normal periorbit up there. These are what we call vertical cuts. Takanori Fukushima taught this to me. You make cuts in that direction, you're not going to hurt anything. And then you can start to peel the periorbit involved with tumor off of the orbital contents. And you see here, we completely decompress the orbit now. It's like a muffin, it's expanded. And then we'll remove tumor down the pterygopalatine fossa here. Okay, so at the end, you've got a decompression. If you're into the sphenoid sinus, which happens frequently, I just plug it with a little napkin ring technique. We plug it with muscle, some fibrin glue, and that usually takes care of it. We don't really have any problems with CSF leak with that. And then place fat around the orbit. And you'll see on the post-op scan, he had improved third nerve palsy and his vision improved. And you see how much we were able to achieve. See, so you can do much more than you think, but you've got to take a look and you got to take the time and drill it out and find out what you can do. Okay. And so that's the point that I'd like to make. This is the grading system. These are our patients. For time, I'm not going to be able to go through all this. But basically, the recurrence rates were less the more aggressive we were. And they have better proptosis and visual outcomes. So in conclusion, orbital surgery should be familiar to skull-based surgeons. Only the neurosurgeons can perform all the approaches to the orbit. Remember that. The eye doctors cannot do that. And in our area, in America, they've become very, very conservative in ophthalmology. And they're sending all these cases to us to do. It's a forgiving structure. You just got to know the anatomy. And it should be taught in all these skull-based courses, all these different orbital approaches, in my mind. It should be core neurosurgery. It's an important frontier, and I think the next generation needs to take it up. We also need to be appropriately aggressive with the disease. Don't repeat radiation. Don't do small surgery. Try to get control of the tumor. And I think this is a real problem that we have, is calculating the morbidity of radiation in comparison to the surgical resection. Because surgical resection, you take all the risk up front. Radiation, you amortize it over many years. And then finally, if I have time, I'm just going to show you an operation. We published this about a year ago. Traditionally, when you remove an optic nerve glioma, you use two different approaches. You use a transcranial approach to cut the optic nerve intracranially, and then the orbital surgeon or the ophthalmologist comes from the front and disconnects the tumor from the back of the globe. That can be done in one step. And the reason why it isn't done in one step is because you give them a third nerve palsy traditionally. And that's because the upper division of the third nerve comes up into the levator and the superior rectus from below. And so when you stretch those muscles, you give them mitosis post-op. So it's important to understand what runs through the annulus of Zinn and what runs through the superior orbital fissure adjacent to the annulus of Zinn. And you've got to study the anatomy. Roden's got beautiful videos and all the anatomical work. But let me just show you how this can be done. And I've done a number of these cases now. 28-year-old woman, she's got visual loss already in her right eye. And she's blind in her right eye, and the tumor is progressing. So she's got an enhancing optic nerve on this side. She's blind. And you want to control this because she's young, and you want to make sure it doesn't get back into the chiasm. Okay. So obviously she's got some mass effect. This is another typical American patient with her obesity. And so we'll do a frontotemporal transcranial orbitotomy in this case. Orbital roof, orbital apex, anatomy you see every day. There's the meningoorbital band. You cut that, First 5 millimeters, nothing to hurt. Bring it down to the bottom of the clinoid, and that gives you a free shot to drill the clinoid out. It's a simple operation. Drill the lateral wall, drill the superior wall. Do an optic canal decompression. And then what we'll do is we're going to remove the anterior clinoid, and then we're going to open up the orbit and follow the optic nerve right out to the globe. Okay. And this shows some really important anatomy. So the way I like to do it is drill the clinoid out, so you have room to move the optic nerve, and you can be as gentle as you can with the muscles. Because this patient's blind already, but you don't want to give her a cosmetically unfortunate ptosis. So open up the dura. Here's the right optic nerve. We're going to cut the optic nerve about 2 millimeters anterior to the chiasm to avoid Willebrand's knee, and giving a contralateral visual cut from the other eye as well. So we're going to cut here. And then we're going to just follow the nerve out through the annulus of Zinn all the way out into the orbit. So it's a good review of the anatomy. And you want to open up this medially. So this is how I avoid giving people a third nerve palsy, is you come medial to the nerve and then medial to the superior rectus and the levator, which run right on top of one another. Open up the periorbita. Here's the levator. Watch out of the V1 frontal branch. Okay. And then follow this out, and you can see right out to the end of the orbit at this point. So what we're going to do is we're going to open up the region of the annulus of Zinn, and then use our retractors, and be careful of the fourth nerve. The fourth nerve does not run through the annulus of Zinn, it runs over the annulus of Zinn. And then put retractors in, hold the fat back, and then follow the nerve. Okay, and here's the companion diagram, what we're seeing. This is the nasociliary nerve and the fourth nerve. Here's the thickened optic nerve. I'm just following this out. The nerve was biopsied by the ophthalmologist before, so you'll see some scarring here. And we're just going to dissect the optic nerve from the periorbital fat. The only challenging part to this is dealing with the fat that's sort of fungating in your face as you're trying to do it. So go out to the globe now and cut it behind the globe. And if you can spare, don't cut too close to the globe, because you'll drain the vitreous out of the globe and the eye will atrophy immediately. Okay, so bring up the optic nerve, which is all thickened here, and then dissect it from its scarred investments in the orbit. And then the key is now is to remove it from the annulus of Zinn without hurting any of the other nerves, because you want the eye to move normally for her cosmetically. So what I'm doing is I'm dissecting the nerve in the annulus of Zinn, and we'll slip it out from the sleeve of the annulus of Zinn. So there it is. So you got one specimen. So that's the key to do it without giving people a third nerve palsy, if you're interested and if you have experience with the optic nerve gliomas. And I'll leave it at that. Thank you very much.
Thank you, Doctor. Now I would like to invite Dr. Aip sir to felicitate Dr. William Godwell.
Okay, thank you, Dr. Codwell. And my question to you about tips to improve post-operative proptosis.
Yes. To improve the proptosis?
Proptosis, yeah.
So you got to get all the bone out that's thick. And then you remove all the periorbita, because if you leave the periorbita, then it's going to just, the eye won't reduce. You've got to get that thickened periorbita and remove it all. Yeah.
Some of the little bit of extension to the lateral
Yeah, the superorbal approach too. You can do that, but the problem with the superorbal approach, it's great as a skull base approach. It's not a good open approach. It's too tangential. Yes, yeah, and I can show that, but we can fix that over top. You can see.
Yes, yeah, but I actually just wrote a letter to the editor about that, because Ted Schwartz was the one who said, but they gave people 600 balls. So if you come down the lateral aspect, it's also you get the same exposure in the middle process, but you don't put intraorbital structures. It's just think about it. Okay. We modify the whole topic to leave the lateral wall so we don't injure the nerve.
So thank you, sir. Thank you.
Now I'd like to invite Dr. Archarian to felicitate Dr. Louis Borba. Louis Borba, sir, please.
Now, we would like to start our next section. So I would like to call upon the next chairpersons. Let me call Dr. Selva Pandian, Dr. Charles Teo, Dr. Kodishwaran, and Dr. Samaya Elmorsi. Please be seated. Once again, I would like to invite Dr. Selva Pandian, Dr. Charles Teo, Dr. Kodishwaran, and Dr. Samaya Elmorsi. Please be seated. Charles Teo. Now, I would like to call upon the first speaker, Dr. Kuntal Kanti Das, to talk on the topic Onco-microneurosurgery in insular gliomas and optimization of technique and technology. Please, sir.
Good afternoon. So after skull base, let us come back to inside the brain again. So I'm going to talk to you about oncomicroneurosurgery in the insular glioma. The term may appear slightly confusing, but what I'm going to emphasize to you is that to deal with these lesions, we have to blend our previously learned techniques with the newer gadgets and technologies that are prevalent in modern day neuro-oncological surgery. So as glioma surgeons, our goals are sometimes contrasting. We have to take the tumor out completely as maximally as possible because that is what determines patient's survival. But at the same time, we have to preserve the function as well, because if we are not able to preserve the function, any additional deficit can not only impair the quality of life, but can also negatively affect the eventual outcome. So we have to strike a balance, and this is what we call as maximal safe resection. So when we talk about gliomas in general, let us see what are the things that hamper this goal. One is tumor extension, particularly into eloquent areas. In those areas, if we do aggressive resection, the patient can have deficit. Then sometimes poor borders can be a problem. As we know, glioma has a very poor, difficult to identify borders with the normal brain. And if the tumor is already irregular on preoperative imaging, the difficulty can increase. And lastly, if there are very important neurovascular structures around the tumor, a given tumor, then this goal also decreases. We are not able to remove these tumors completely. So all these difficulties are exemplified by this peculiar location of gliomas, which we call as the insular gliomas. As you see, the insula has certain inherent challenges. First and foremost, it's not coming there. So as you see, the insula is located deep inside. It is covered by the sylvian fissure, and all the important operculi are covering the insula. So in order to expose this tumor, we have to either open the sylvian fissure very widely, for which we require microneurosurgical skills, or we have to resect the operculum, knowing that this operculum can have very important functions, particularly on the dominant side. So accessing this tumors becomes problem. Number two, if you see, the insular glioma has very intimate relationship with the middle cerebral artery, the M2 segment, as well as the perforators. In particular, the lenticular-striate perforators arising from M1 segment, as you see here, it forms the medial boundary of the tumor. And these are very difficult to be saved unless you have exceptional microneurosurgical skills. So this intricate arterial anatomy makes it more of a vascular neurosurgery than an oncological surgery in true sense. And as Dr. Avida rightly mentioned, as you go deeper, we encounter very, very important white matter tracts, the dorsal and the ventral language stream. And I must emphasize to you all here that cortical injuries can be taken well by the patient in the form of compensation plasticity. But subcortical white matter injury, it fares very poorly because plasticity potential is negligible. So we have to do whatever possible at our end to preserve the deep white matter tracts. So from this discussion, it is quite apparent to you that successful insular glioma surgery requires you to have good microneurosurgical skills, good handling of the MC and its perforators, and at the same time utilize whatever gadgets are available nowadays to ensure a good outcome. Now, if you look at the insular glioma literature, what you see is that there has been a gradual change from the time of Professor Yasargil. Professor Yasargil, he described the trans-sylvian approach and the microsurgical approach to this insular gliomas resections. But over the years, what has happened is, due to the improvement in gadgets, awake craniotomies, mapping, and whatnot, what has happened is this microneurosurgical approach to insular glioma has given away to an oncological approach. As a result of this, we see much less number of transcortical approaches being done for insular gliomas rather than the trans-sylvian approaches. And there is a lot of reliance now on the adjuncts and less on the microneurosurgical technique. Now, my take on this is that while advancement in science is very much essential, it is also important not to unlearn what we have already learned. So the need of the hour is to retain whatever we have learned from our ancestors and modify it accordingly with the current technologies. And this is what I call as a oncomicroneurosurgery. In oncomicroneurosurgery, what we do is we fuse the time-tested microneurosurgical skills with a modern-day oncological concept in order to utilize the best of both worlds. And this technique is maximally relevant in an area like the insula because it is, in my understanding, an interface of glioma surgery and microneurosurgery. And both these techniques have a complementary role. I have been utilizing this technique in the last 10 years or so, and I've operated roughly 70 cases so far. I'll show you two examples just to give you an idea of what this blending is. You see here, this is a 36-year-old female with seizures. There is right-sided insular glioma. The glioma is very much well defined by the anterior and the posterior perinsular sulci. Yes, these are the posterior perinsular sulci and this is the anterior perinsular sulci. Immediately we see this is the internal capsule and the basal ganglia here. On sagittal sections, we can see that the tumor is well demarcated and most of it is in the insula, not much of opercular extension. And there is not much of paralimbic extension as well. So this tumor is fairly well confined inside the insula. And it is apparently also opening up the sylvian fissure here as well, if you can see. So this is a situation where microneurosurgical trans-sylvian approach would be very much useful and we do not have to go for extensive opercular resection. So in this patient, it started with the right frontotemporal incision. We can see the exophytic part of the tumor. The distal part of the sylvian fissure was opened to get into the depth of the tumor. The pia usually covers the tumor and the pia is removed from the top of the tumor. We go now to the proximal end of the sylvian fissure. We can see the middle cerebral artery. Now, definition of the middle cerebral artery, particularly the M1 segment, is pretty important because in the later part of the surgery, this will guide us in estimating the location of the lenticular striates. We do an ultrasound here. We have the basic ultrasound, but it suffices. As you see, the tumor is very much well defined. We see the falx as well as the ventricle as normal landmarks. And we open the pia and start removing this exophytic part. This exophytic part has actually acted to our advantage. It has created a space on its own. Here you can see that we are elevating the sylvian vein subpially and we are resecting the tumor. The key to preservation of vessel, be it artery or vein, is to respect the pia. As you see, as we are going deeper in the tumor base, we see that the color is changing. We can see the posterior or the inferior periinsular sulcus. Now, definition of the sulcus is very, very important because it establishes your resection margins. The glioma doesn't go across the pia, it goes deeper into the white matter. So we know now that we have reached the posterior limit of the tumor. We have reached the posterior insular point. This is very important because the commonest area where the tumor residue remains is zone 2. But if you follow these anatomical landmarks, it is possible for you to take out tumor even from these zones. Now here you see that I'm using subcortical stimulation. In my understanding, subcortical stimulation is very, very important. Here we see the surgical cavity and we see some hyperechoic shadows in front, which is the residual tumor. This is the residual tumor. So this intraoperative ultrasound tells me where to chase the residual tumor. Posteriorly, we have reached our limit. We are doing subcortical stimulation here. Now, as the intraoperative ultrasound showed, some amount of tumor was located on the frontal side. This tumor is dissected and brought into the field and sucked into the suction. Ultrasonic aspirator is a very important tool in controlled resection of these tumors. As you see, as we go towards the periphery, the border between the tumor and the normal vein, it vanishes. And this is where you need to apply your experience. So the key is that we remove the tumor from different corridors in between the middle cerebral artery on the surface. And on the deeper side, we'll have the lenticular striates. So this is the area of the insular apex. The preserving the pia actually preserves the middle cerebral artery, which is running on the insula. So the tumor resection has to be in the same plane and the deeper margin has to be confirmed with monopolar subcortical stimulation. Now, as I said, this is where the sylvian dissection helps. We can see the lenticular striate perforator extrapially. So once it enters the brain, it is very difficult to know the location, but you can approximately guess where it is moving. And once you have known that you have removed most of the tumor, you bring in the ultrasound again, and you verify that the tumor that you wanted to resect has been removed, as we see here. And we can see the skeletonization of the MC. And most importantly, you can see that the upper column are very healthy. And we have been able to resect this tumor by going through the sylvian fissure. Post-operative scans in comparison to the pre-op shows gross total tumor resection, and diffusion weighted images show there are no infarcts. Coming to the second case, this is also right-sided insular glioma, but in comparison to the previous case, you see here that the tumor has opercular extension on the frontal side, but there are no extension onto the temporal side, minimal extension to the superior temporal gyrus. But most of the tumor is in the insula and in the frontal operculum. The patient presented with seizures, and with video image, we localize the focus to be in the frontal area. So this is the right frontotemporal exposure. We can see that this is the frontal lobe, temporal lobe. We can see some tumor here. So the sylvian fissure with all its rami are seen, and we are able to localize that the tumor has actually expanded just beneath the pars orbitalis. So herein what we do is we do cortical stimulation, because here our plan is to go for transcortical approach, but we did not find any functional areas. The surgery was being done under general anesthesia, so we wanted to look for motor areas, because language area cannot be found on general surgery under general anesthesia. Similar to the previous case, this exophytic part of the tumor is initially removed. And what is very important you see here is that you have to respect the pia. The sylvian vein protection is ensured only by respecting the pia. This is on the deeper side. Now we see that the exophytic part was in the zone 4 and zone 1 is still there. And we have to go for resection of this tumor based on our intraoperative estimation as well as intraoperative ultrasound. Now, what I want to emphasize is that opening of the distal part of the Sylvian fissure is very, very important in a case like this because it establishes control on the zone 2. As we know, the posterior superior part of the insular cortex remains hidden by this important operculum, and opening the distal Sylvian fissure, a microsurgical technique can actually improve exposure to this area. In my initial cases, I used to have a lot of residual tumor in the posterior superior part. But with the adoption of these techniques, particularly opening the distal fissure, I found that exposure of this area is very good. And so once you are able to expose it, you can see some the area that I was talking about. This is the top of the insula. So this exposure becomes easy after you open the distal Sylvian fissure. Again, a microneurosurgical technique. And what we do is we resect the tumor on either side of the Sylvian fissure and eventually connect the two cavities below the MCA. So this is what a transcortical approach is. Here you do the same job, but you don't open the Sylvian fissure widely. Rather, you work below the MCA. Now, what I want to show you here is, you see very carefully that subpially we are resecting this portion of the tumor. And you'll soon see the lenticular striate artery perforators. As you see here, these are lenticular striate artery perforators. So skeletonization of this perforator is very, very important. It requires microneurosurgical skills. And when you see these arteries, lenticular striate arteries, you know that the medial extent of resection has been achieved. And adhering to your microneurosurgical techniques and visualization of the artery is the only way of preserving it. No amount of monitoring can preserve this. And the rest of the surgery is standard. Here I've shown you the importance of skeletonization of the lenticular striate arteries. And eventually you do subcortical stimulation like the previous patient, because the location of the corticospinal tract is only known with the help of a monopolar subcortical stimulation. And as I said, both the surgical resection cavities are connected below the Sylvian vein and MCA. And here you see a nutmeg appearance of the basal ganglia. This is very characteristic. And after having done a few cases, you will realize that you have reached the basal ganglia. And this is your medial tumor resection limit. Inferiorly, the lenticular striate perforators, and superiorly is your the basal ganglia, the resection cavity you see here. Postoperatively, the patient had recovered without any deficit. The MRI is scheduled up to 6 weeks. Postoperative CT scan, which was done immediately, shows satisfactory tumor resection. However, the amount of residue, if there is any, will only be known with MRI. So to conclude, I would like to say that insular glioma surgery is challenging, but we can reduce the challenge to a great extent by not forgetting the microneurosurgical techniques that have already been developed. We can blend this with the modern gadgets and other techniques that are available at our disposal right now. Now, this amalgamation of approach is particularly important in settings like ours, where these gadgets may not be available in every center. And the three important points for me in insular glioma resection are a wide exposure, management of the MC and its perforators, and subcortical monopolar motor mapping. Thank you.
So nice presentation, thank you. I think you underscored the most important part of insular surgery, and that is the medial aspect. And a good way of identifying how medial you have to go is to see the LSAs, the lenticular striates coming off the M1 branch. And that gives you some idea of how medial you can go. And then, of course, identifying the nutmeg appearance of the basal ganglia. And the other way, of course, is to, when you get into the frontal horn of the lateral ventricle, you can see the caudate nucleus.
Yes.
And so, every study on insular glioma surgery has shown that risk is all about the medial extension. And so you did a very good job of telling us how to identify that medial extent. Very nice. Is there any change in your technique when you do malignant gliomas versus low-grade gliomas, or it's the same technique, the same approach?
Sir, I've actually analyzed the insular gliomas, and we have published also in British Journal of Neurosurgery. We have seen that the postoperative complications in high-grade gliomas, preoperatively identified with contrast enhancement, the postoperative complications are quite high if we adopt the same kind of technique in high-grade gliomas. So in high-grade gliomas, I have become more conservative. I would take a transcortical approach because it is very difficult to identify the tumor vessels from the normal vessels because it tends to bleed a lot. So I'd rather go through a transcortical approach, do as much safe dissection as decompression as possible, And I'll leave it at that because whatever you do, they tend to do not that great. And if you add a complication, it can actually impair the quality of the remaining life. So high-grade glioma is a different proposition.
You have highlighted operative findings very well. Can you tell us a little bit about clinical features as well as imaging features, which will help you to decide for gross total resection or decompression?
Sir, as I said, most of these patients, they would present with seizures. Insular glioma, it is one of the common cause of seizures in adults. Apart from that, these patients may present with, if their tumor is high grade, they may present with raised ICP, they can present with hemiparesis, apart from seizures. So if the clinical presentation is suggestive of high grade lesion, so this is one thing that strikes me that I cannot be very aggressive in this patient. Whereas a patient presenting with seizures is likely to be low grade and can probably tolerate a radical resection. That is number one. Number two, as far as the imaging is concerned, as I said, I'd like to see not only the tumor extension, I'd like to see the tumor borders, particularly the medial border. If the medial border is not sharp, if it is irregular, then the chances of complication if you go for radical resection are very high. Secondly, whether the tumor is enhancing or not. As I said, that if the tumor is enhancing with a clinical profile suggestive of high-grade lesion, a combination of this, it has a very high risk of intraoperative complication. So this is another situation where I'll go rather conservative than a radical resection. So intraoperatively, we generally get to know what kind of pathology we are dealing with. But if there is doubt, we can go for that. But practically, I have not required that till now. The look of the tumor, preoperative imaging, the behavior of the tumor on table generally tells us that we are dealing with a high-grade lesion.
I just want to add one point. At NIMHANS, we have done a study of using intraoperative ultrasound and intraoperative MRI. And we found that there's a very high correlation. Whatever is showing, except I think it's a series of about 35 cases, except one or two. In all the 33, there's a concordance. I think.
Yes, sir. Ultrasound is a very good tool.
Yeah, everybody can.
Ultrasound is a common man's MRI.
Yeah.
It's very effective. We don't have to go for MRI, I think.
Yeah, thank you.
Thank
On recurrence.
So I have yet to analyze my series so far, but what I can tell you from my OPD experience is generally low-grade gliomas in our setting, it tends to recur at around 5 to 6 years from surgery. And you can add maybe a couple of years of more survival. So somewhere around 7.5 to maybe 8 years of survival is what I'm seeing. I've not yet analyzed it, but I've seen some patients consistently in that range in the OPD. And I think in our settings, I think 8 to 10 years is 10 years is what we're looking at.
Added few years compared to previous data.
Sorry, sir, I could not get you.
No, it's adding few more years, lifespan of total, you are saying.
Yes. Low grades. High grades we have already published. The median survival is 7 months. The publication is there in British Journal of Neurosurgery. 7 months. In low grades, maybe 5 to 7 years. 7 years maybe, but I'm yet to analyze that.
How will you confirm the total resection, complete resection?
Complete resection in low-grade gliomas, particularly in an area like the insula, is very difficult. The only definitive way of knowing it is doing a post-operative MRI. So the problem of post-operative MRI, we have analyzed and the manuscript has been accepted in Neurology India, is that if you do a very early MRI post-operative, which is recommended within 2 to 3 days, you see a lot of artifacts. And the radiologist has to be dedicated. He has to give a lot of time in manually subtracting those doubtful areas and give you a percentage of tumor resection. Or the more practical way of doing it is doing it around 6 weeks to 8 weeks time. So an MRI at that point, preferably if it is done in a volumetric fashion, can actually tell you the what percent of tumor has been removed. But if you go across the literature, insular glioma resection, anything more than 90% is considered to be a very good extent of resection. Unlike a polar glioma or a temporal polar glioma, where probably you can go beyond the margin of the tumor. You can go for supramarginal.
You advise adjuvant therapies along with your surgery or only follow?
Sir, I generally follow the RTOG guideline, which says that if the tumor is completely removed, there is no residue in the postoperative MRI and the patient is less than 40 years of age, then you can probably withhold the adjuvant therapy. But in a location like insula, you will have some residual tumor if you look at the imaging carefully and if you are very honest with yourself. And most of these patients are in that zone only, 35 to 40. And if you add some tumor molecular features like say IDH mutation, MGMT status, and the other new markers that are available now. So I think a combination of this would make most of our patients high risk. So I generally give radiation to these patients. Unless the tumor is grade 1 and the resection is very satisfactory on my part, I'd like to follow up. But it is better in our situation to give radiation because many of these patients will not even come for follow-up until they have developed a recurrence. So more practical way, I think, is that.
Excellent presentation, Doctor.
I think he has to.
Thank you, Doctor. Now I would like to call upon the second speaker, Dr. Amit Upadhyay.
You're talking about intraoperative assessment of extensive resection. You're correct. You're correct. See, probably, yes. You're telling something? No, yeah. Yeah. So as I showed in the imaging, if the glioma is confined to insula, the peculiarity of insula is it is surrounded by sulci, peri-insular sulci, almost all around except the Lyman area, insulae area. So if the tumor is inside the insula, and if you have seen the plane all around, the sulci, so lateral borders are removed. The only thing that needs to be determined is the medial border. That is what I've shown in the second patient. If you're able to skeletonize the lenticular artery, and if you're able to see the nutmeg appearance of the basal ganglia, you know that there is no tumor left medially. And you have gone for the sulci all around. So that is what I'm saying. If the tumor is confined to insula, an experienced surgeon can reasonably be sure that he has removed the tumor completely. The problem arises only when the tumor has gone beyond the insula into the in the paralimbic zones, and if the borders are irregular. In that situation, postoperative MRI is necessary. And glioma being a malignant disease, as we all know, even if it is low grade, it is pre-malignant. So we have to rely on the postoperative MRI rather than a surgeon's intraoperative assessment, because studies have shown that it does not correlate all the time, even with the best of surgeons. Yeah, it is very good. But still, I would say, as you saw probably, at the end of the resection, because of blood and surgicel, assessment becomes very difficult. Yeah. Yes, it is a handy tool.
Thank you. Thank you, Doctor. We'll call the next speaker.
Now I would like to call upon the next speaker, Dr. Amit Upadhyay, who is going to speak on the topic unusual presentation of a CP angle epidermoid. If anybody
Thank you, dear chairpersons and audience. Special thanks to Debu for inviting me here. I'll be presenting on an unusual presentation of CP angle epidermoid. As we all know that intracranial epidermoid cyst is rare, slow-growing extraaxial embryonal tumor of ectodermal origin, accounting only 1% of all intracranial tumor. CP angle is most favored location of epidermoid tumor. The cyst of the epidermoid cyst grows due to accumulation of keratin and cholesterol from desquamated epithelial cells and fills the cavity and expand further and grows in crevices. And it often attains very large size before the presentation. How it presents at like headache, cranial nerve dysfunction, cerebellar and brainstem dysfunction, hydrocephalus and raised ICP features. If we see the pathophysiology, how it affects the cranial nerves, it can directly compress the cranial nerves is due to stretching, bending, kinking of the nerves and interferes the axonal growth. Cis capsule and content often irritates the nerve sheath, inducing chemical meningitis and causes irritative symptoms like hyperactive symptoms. Small epidermoids is often present due to these symptoms, these pathophysiology. Another is capsule strangling mechanism where blood flow to the nerve is hampered. If you see this case, in my case is 26 years old male without any previous medical comorbidities or any drug history. He presented with acute onset, sustained and repeated painful spasm of neck muscle on right side with turning of head towards left side, lasting for about 30 seconds to 1 minute for 2 months duration. There were multiple episodes per day, around 20-25 episodes, and in between the episodes, patient is absolutely all right. On examination, patient is conscious and alert. In cranial examination, if you see only mild decrease in sensation of pain and temperature, and right half of the face in the V2V3 distribution, no cerebellar signs, and in between the episodes, patient is absolutely normal. This is video of the patient where there is sustained contraction of sternocleidomastoid and deviation of head towards the left side. Patient is conscious and in between the episodes, patient is absolutely normal. So based on this history and this examination, what is the clinical diagnosis? Was it seizures? Was it painful cervicofacial dystonia? Patient was already on Eptoin, anti-epileptic treatment started from a local practitioner considering it seizures, but patient was refractory to it. EEG was also done, it was normal. So then patient was evaluated with MRI, which was suggestive of a small lesion in right CP angle, which was T1 hyperintense and T2 hyperintense. Diffusion restriction was there. So imaging finding was consistent with epidermoid tumor. If we see in thinner section, you can see that tumor was there from lower cranial nerves and above till fifth nerve. So based on clinical and radiological concordance, we proceeded with right retromastoid craniotomy and gross total decompression. Complete tumor was decompressed between fifth nerve and seventh nerve, and then between seventh nerve and lower cranial nerves. Post-op period was patient tolerated the procedure well, developed some lower cranial nerve symptoms which were managed conservatively, and it gradually resolved within a week. And surprisingly, there was complete relief from the cervical dystonia in the immediate post-op period. Post-op scan also showed complete excision of the tumor. MRI after 3 months, this diffusion weighted MRI showed there was no residual tumor. This T2. T1 and T2. This 3 months after the surgery. Histopathology is epidermal. So if you see, there are various reported unusual presentation of CP angle epidermoid like contralateral trigeminal neuralgia, hemifacial spasm and tinnitus in the same patient, bleeding in epidermoids, and malignant transformation also. But no such case was reported. So there was diagnostic dilemma whether it is cervical dystonia, or the lesion. This symptom is due to cervical or CP angle epidermoid. There was doubt in the management whether the patient will improve after surgery or not, because no such case was reported. So that's why I presented this case here. Thank you.
You will not believe this.
No.
I have had an exact patient. I had a young girl and she was treated like a psychiatry patient for a year because she had this terrible posture and she couldn't sit up. So her boyfriend would have to push her around in a wheelchair and her head was on a pillow. She had a dermoid, not an epidermoid. Took out the dermoid, pain disappeared. Isn't that crazy? Yeah, I should have reported it, but yeah, it was irritation of the trigeminal nerve. It was very close to the trigeminal nerve, and like you said in your preliminary slides, I think some of the symptoms are from irritation. Yeah. Very nice. Very nice.
Thank you.
We'll move next topic.
Thank you, sir. Now I would call upon the next speaker, Dr. Puneet Rana, to speak on the topic minimally invasive thoracolumbar corpectomy, a novel approach for thoracolumbar fractures.
And, thanks for having given a chance to me to speak and present my presentation. Now on to a bit of spine, a topic very close to my heart, the thoracolumbar fractures. I'm presenting a minimal invasive thoracolumbar partial corpectomy, a novel approach. No, not the video, the presentation. Yeah, no, it's okay. It's okay. Minimal invasive thoracolumbar partial corpectomy, a novel surgical approach. Minimal invasive spine surgeries have evolved in the recent past, and the prognosis have gone up, largely because the advent in the science, the skills, and the cadaveric dissections. Thoracolumbar region is involved in almost 90% of the spinal injuries. They are divisible into the compression, dislocation, burst, and the distraction fractures, seatbelt fractures. The basic mechanism remains the same: thoracolumbar fracture, the vertical compression, the antiflexion. The management of the thoracolumbar burst fractures should effectively correct the deformity, induce the neurological recovery, allow the early mobilization, but most importantly, it should provide the direct decompression. According to Dennis, there are three types of instability: mechanical, neurological, and combined. The instability is having a lot of definitions, but mainly it should include the middle and or the two column failures. The other things which are going to contribute the instability are the loss of the integrity of the posterior ligamentous complex, decrease of the 50% the anterior vertebral body height, the interspinal process widening, and kyphosis more than 30%, 30 degrees. The operative indications, remain controversial after all these years, and the plethora of the cases, involved in the thoracolumbar fractures. However, for the patient with the neurological deficits, especially incomplete neurological recovery, it is generally accepted that surgical treatment has significant advantages in mobilization, pain relief, and pulmonary function and general well-being. The main goal of surgical treatment is to decompress, realign, and provide the long-term stability. The progressive neurological deterioration generally accepted as absolute indication. The relative indications include the associated non-spinal injuries and the patient nursing or comorbidities involved. Now the armamentarium, of the surgeries, the first shot of the armamentarium is the balloon calfplasty. The indications are that there is no retropulsion, PLL is intact, and the superior and inferior end plates are intact. Classical calfplasty. or operative. Now this is something we call as impossible kyphoplasty. You can see that the minimum, superior inferior length is around 2.5 mm. Even the superior, I mean the anterior and posterior part, they are having a fractures in between. And you know that the Jamshidi needle is having a maximum thickness of around 2.5 mm. So you can see absolutely no leak of the cement, controlled dilatation of the fractures, the incisions. The second shot in the armamentarium is a thoracolumbar corpectomy. When you are having absolute comminution of the body and superior and inferior end plates are, they are broken and there is a retropulsion. The radiological result of the thoracolumbar corpectomy, the cosmetic result, this patient improved. He came to me after 1 year and the bowel and the bladder improved, post 1 year. So there is a third shot in the armamentarium, that is what we call as partial corpectomy. It is to fill the vacuum between the kyphoplasty and thoracolumbar corpectomy. There are cases in which the kyphoplasty cannot be done because there is a retropulsion and complete corpectomy is going to be an overkill. So if the posterior ligamentous if the PLL is intact, we do a kyphoplasty. If the posterior ligament is ruptured and there is a significant comminution, you do a complete corpectomy. But in the cases in which the ligament is ruptured, there is some, a retropulsion and it is threatening to go inside the conus medullaris. And, if you do a complete corpectomy in that, it will be an overkill. So these are the cases in which the partial corpectomy is involved. This is a classical case. You can see some kyphosis. The anterior part of the body is around 50% reduced as compared to the posterior part. There's a fragment which is threatening to go inside the conus medullaris. It's a classical case. So the surgical technique is prone patient, incision around 4.5. We started at 4.5. Now we have reduced it to around 4 centimeter. The laterality of the incision will depend upon the level. The more we go lower down, because the pedicular angle, we will have to go more lateral, the incision. These are the incisions comparison of the partial corpectomy and the complete corpectomy. The lateral one is the complete corpectomy because of the line of the attack is more lateral. And the partial corpectomy is just outside the pedicular line. So the surgical technique is divide the bony structures of the vertebra, mark the outline of the pedicle using the C-arm fluoroscopy and use the high-speed drill for that. So we have, drilled out the margins of the pedicle and we have to define the line of the attack of the pedicle. I have to align my microscope in the pedicular line. So partial corpectomy per se is taking out a part of the corpus, leaving a thin eggshell medially in the pedicle to prevent the herniation of the already compromised cord under the pressure. So you can see that I have taken my drill inside, the diamond drill, and this is the length, anterior posteriorly that will be doing the partial corpectomy. If the fragment, which is incriminating to go inside, threatening to go inside, is superior, we do the partial corpectomy superiorly. And if it is inferior, then we have to do it, accordingly. The second step is partial laminectomy to find out a plane to push the fragment and finally take down the medial border of the pedicle. So this is the area in which to the partial laminectomy. In the last stage, we take down the impacted fragment into the partial corpectomy cavity, giving rise to the decompression of the neural structures and simultaneously provide the autograft at the same time. This is the territory in which the partial corpectomy takes place. You can see that the medial border of the pedicle is intact. We take this much of the bone out, around 20%, 25%. You still have 75 to 80% bone intact. The next step is aligning the sagittal balance. The sagittal balance finding is better in the case of partial corpectomy as compared to the complete corpectomy, especially in the cases in which there is a lot of kyphosis. The last step is putting, percutaneous screws superiorly and inferiorly. You can see the pre-op images as I showed the CT scan. You can see the post-op, even the anterior and posterior, lines are almost equal, which was almost half the size before the surgery. Sagittal balance is maintained. There is absolutely no fragment which is threatening to go inside. The incisions, you can see even the lordosis which is maintained. Happy patient. So this is not only the surgery. There are various ramifications of partial corpectomy. The first ramification is, as taught to me by my teacher, Dr. Sudhir Dubey, a legend of MIS surgery. He said that complete corpectomy has to be done from D10 to L2. But partial corpectomy can go above that because the line of attack is more medial. So in the region where the scapula is there, D7 and above, you can do, partial corpectomy. You cannot even think of complete corpectomy. We have gone maximum till the D4. It can be used in very selective cases to do, controlled osteotomies. This is the case in which the kyphotic angle is around 75 degrees. You can see this surgery was done by bipedicular approach. 180-degree cuts were done from both the sides. And this case was operated by MISS. You can see the body language confidence of the patient post-operatively. He was, discharged 4th post-operative day. Partial corpectomy, not only it can go up, it can go down also. In the complete corpectomies, you cannot do the L5 corpectomies. The general teaching is you can do only up till L2. We have gone up till L4. L5 you cannot do because the end plate of the L4 and S1, you cannot put a cage, inside. Maximum what you can do is that you have to go anteriorly, put a 3D imprinted implant over there. But you have to be ready for the devastating complications that can occur. In partial corpectomy, all you have to do is that you have to put that autograft inside. You have to fix superiorly and inferiorly. The patient is good to go. In the country like us where the TB load is very high, you can use that pedicular collar. Pedicular collar, and you can reach whatever space you want to reach. Epidurally, you can reach the disc, you can reach the body, you can take the infective load outside, and you can fix superiorly and inferiorly. And the patient is good to go. This is one of the cases you can see that the body is damaged. This was having the abscess epidurally, and also the abscess adjacent to the part of the disc. This patient was decompressed using the MISS method and fixed superiorly and inferiorly. He was good. Then the other ramification is there are cases in which there are multiple fractures, not only one fracture, multiple fractures, contiguous, discontiguous, on the left side, on the right side, the same patient. So in this case, there's a discontiguous fracture. There is a compression on one side from the right side, and the other side, it is on the left side. So what we do is that we do the partial corpectomy on both the sides. We, fix superiorly, we fix intervening segment. We fix, inferior segment, and the patient was good to go the next day. So there is another ramification. If you are having a tumor or a metastasis in which the outline of the body is intact, what you can do is that you can go inside the pedicle, you can curate out the tumor, and you can fill that cavity with either the bone pieces or the bone cement, and you may or may not choose to fix it depending upon where the tumor is, and the patient will be good. The take-home message is partial thoracolumbar corpectomy is a novel approach which helps to provide a new, decisive way of classifying the management of the thoracolumbar fractures. Partial thoracolumbar corpectomy provides a potent weapon in the armamentarium of a spine surgeon, which has multiple derivations, ramifications, and uses which can help the said clinician in a multitude of pathologies and in the surgically difficult anatomical locations with very limited chance of surgical complications with reproducible and favorable results. I'll be showing you a small video. It's 5 minutes, but I'll be, shortening it down to, around 1 minute, which will be showing a 270-degree or 300 degrees, decompression of the segment where the fracture is there. This, can you help me with the video, please? Just open this video. It's really nice. Yeah. So, shuru karo isko. So this is a D12 fracture that we operated a few days back. You can see this is outlining the margins of the pedicle using a high-speed drill, cutting drill. As I go inside the body, I use a diamond drill. So you can see it is absolutely compressed, the nervous components. Below it is epidural veins along with the fracture. I'm going inside the body. I'm just decompressing it out. I will be forwarding it. As we keep decompressing, you can see that the neural components become more and more prominent. The angle is along with the pedicular line. So I'm not going in a straight line. I'm going below the dura. And right now the drills are available which are curved. So we can do almost 180-degree decompression. Anteriorly. We can do 90-degree decompression superiorly, posteriorly. and we can cut a spinal lamellar line and the spine below the spine, that area, and we can go to the opposite side. So it's possible to do almost 330 degrees decompression in these cases. I'm using a serial dilator of the MISS to just push the fragment inside the operating cavity, giving rise to decompression. You can see the dura becoming more prominent. Extending the laminectomy. This is almost the end result where I have done the hemilaminectomy on the ipsilateral side. I can choose to drill below the spinous process, go on the opposite side, and take this decompression to almost 330 degrees. So this patient had no deficits. He went home a few days after.
Excellent presentation, Dr. Anand. What is the advantage of this partial corpectomy compared to traditional methods?
Partial corpectomy as compared to the general I mean, when I was undergoing MCH, I saw one case done by our professor in which there was a 45 centimeter incision. It was a hockey stick incision. It was around a D11 fracture, if I'm not wrong. So the single lung ventilation was done, and 45 centimeter incision. It was an open procedure, and the patient had to undergo the ICDs. He was in the ICU for many days. So the general trend previously was anterolateral approach in the thoracolumbar region. Then as the time passed, it became lateral, and then it became posterolateral, and then it became more posterior. So partial corpectomy as compared to the complete corpectomy, which is still a very advanced procedure, it gives you an advantage that it is going through an area which is not having any vital structures. The MISS gives you an advantage that you will have to do very less muscle dissection. The blood loss will be very less. The incision, we started around 4.5 centimeter. Now we can do this surgery in 3.5 centimeters. So if the patient is having his neurological status intact, the patient will be effectively walking the next day. No catheter. Catheter is removed the next day. The patient is walking to the bathroom by its own. The pain is reduced. The basic thing is the pain, whenever it happens, there's a periosteum around the corpus. So whenever there is a disintegration of that line, cortical bone line, the periosteum, it is broken. So by each movement, the periosteum is rubbing against each other and there is a pain. So when you are in the decompression and the fixation, that pain goes away. There's a fixation, there's a decompression, there's a realignment, sagittal balance is better, kyphosis is gone. The patient gets as close to a physiological spine as possible because the fragment that you have, decompressed and put as an autograft, it helps in making a neocorpus. So that is why the partial corpectomy is the need of the hour in the thoracolumbar fractures.
But if you are leaving fragments intact, for example, you are not removing completely, the fragments are left inside.
Yeah.
You doesn't know how cleared you are.
See, what happens is two things. One thing is fracture is not having a smooth outline. It's having a zigzag outline. So when you press it hard against it, it sticks. Number two thing is on the fragment, there is a bone part which is cortical, which is abutting the dura. So it is not fully broken. It is attached to the corpus from that side. So it is the fragment will never go inside the dural cavity. It will stick over there. And as you just hammer it down, it never comes out, sir. In my experience, it has never come out.
Most of the thoracolumbar fractures, mostly L1 or all of their lumbar fractures, or the D12, we started doing lateral oblique lateral LLIF, which is lateral oblique decompressions. We do a retroswas. Retroorbital, we achieve a complete decompression of the bone and then go back, put down the percute screws, which are, because sometimes we feel that by pedicle approach, like 30 degrees, not complete, but still, and the decompression of the cord is not complete. So I think we've done a couple, and one patient will walk back also with a lateral transverse, retroswas approach, not transverse.
Yeah.
And whatever your corpectomies here, we've done like a few oblique corpectomies for myelopathic also. Good.
See, this is a more direct approach. Only in a normal average person, 3.5 to 4 centimeter, you're on the incriminating fragment and absolutely no vital structure. So I think
we have achieved till the cervical, but here I feel that we should achieve a complete decompression. I mean, bipedicular also, we're not, I think so. Swas, retro swas it's just directly go up to the disc or directly go up to the broken body, remove the body, put the cage or whatever, and not extra cage. So, retro swas. L1 up to D12, we can go with all below the number. Above D12, yeah, it's extra cavity, not extra cavity, lateral. Yes, sir.
See, what we can do is that, there is a paper which shows that by the unipedicular approach, you can take almost 70% of the.
Yeah, but still not 100. We want to achieve complete.
Let me complete.
Yeah.
There are specific instruments which we call as hockey stick impactor.
So that is to take out those.
You can take them, between the dura and the incriminating fragment to the opposite side, and you can just hammer it down. It's possible.
Yeah, but still, I feel that it takes time, and the vision for the lateral oblique is direct. We just open it, I think, dozen half an hour. Directly, we can just dissect the retroperitoneum on the. And for, it's a very basic. I mean, for other cases also, like for metastasis multiple, where we need more or correction of deformities, where we need more decompression, lateral will be the field will come up.
One thing you have mentioned very nicely. Many cases of you have mentioned about the tubercular spine. We have seen many cases of tubercular spine affecting 2-3 level vertebra. So in that case, how you want to address the situation?
Yeah.
Few cases you have seen.
That's a very good question.
2-3 levels of vertebra are conglomerated into a single lump. And that lump is compressing over the dura and patient is paraplegic.
See, that's a very good question. If you are having contiguous levels, what do you do? See, what happens is that when we are doing the MISS, the rods that are available, they can go maximum 6 levels. So if you are having up to 2 contiguous levels, you can go 2 above, 2 below, you'll be having a rod. But if you are having more than that level, if you have to cover 7 levels, for example, you are having 3 levels. So if you are getting 2 levels up, 1 level below, you can still do MISS. But if you are, planning to join 2 levels up and 2 levels below, total 7 levels, you will have to go open. This surgery can be fashioned into an open approach. You can go transpedicularly. You can use that corridor to go into any corridor that you want. Epidurally, you want to go to the disc, you want to go to the body, you can go anywhere. It just provides you an option to go in any corridor that you want, wherever the incriminating fragments is there.
Regarding the cage placement anteriorly, for a 3 level,
you have to go anterior. You will have to go anterior. If you are having 1 level,
anterolateral.
See, if you are having 1 level, you can do the corpectomy in that. If you are having more than 1 level, you will have to abandon this because there will be a nerve in between. You cannot take the cage. Either you have to go anterior or you have to go anterior lateral, that area. So in TB, I think what happens is that if the patient is responsive to the drugs, you do the decompression, the infective fragments, you take them out, you fix it, and if the HT is responding, the patient responds. That is the idea of using in an infective etiology the MISS fixation. In the other infective etiologies, you cannot do that. Thank you.
Thank you, Dr. Rana. Now I would like to invite the next speaker, Dr. Deboshi Chatterjee, to speak on the topic post-ventricular tumors. Kindly join us, sir.
Okay, so good afternoon, everyone. This is a rather simpler topic than all the difficult topics that were presented today. So I'd like to present as a beginner my perspective on the fourth ventricular tumors, some of the fourth ventricular tumors that I've come across. I come from Institute of Neurosciences, Kolkata, which is a neurology and neurosurgery hospital, one of its kind. So the pathologies that we commonly see in the fourth ventricle are as follows. Most commonly, we see ependymomas, also medulloblastomas, epidermoids, hemangioblastomas, and choroid plexus papillomas. Pilocytic estromas are also quite common in children, and sometimes you also see cavernous exophytic malformations. So, what are the challenges of fourth ventricular tumors? First is the difficult anatomy, that it is limited anteriorly by the floor of the fourth ventricle. When you position the patient, it is uncomfortable one for the patient himself or herself, because you need to get adequate opening up of the CV junction. And for the surgeon, it's sometimes strenuous on the back. The craniotomy is another challenge where you have to be very careful of the transverse sinus and the foramen magnum. And often in children with the occipital sinus, we can get into trouble. The approaches are mainly two: either the transvermium, where you split the lower end of the vermis, or you do a telovelar approach, cut the tela choroidea between the brainstem, between the floor of the fourth ventricle and the tonsil. You have to be careful of the pica and its course and its branches. And sometimes the vascularity of the tumor may be so high that you have to abandon the surgery in the middle of the procedure. And obviously the floor of the fourth ventricle, which contains all the cranial nerve nuclei, have to be respected. So from my small practice, I want to show two case vignettes. This is an 8-year-old girl child who came with history of headache and vomiting of 3 weeks duration. She had undergone a shunt for hydrocephalus in a different hospital in a different state. And then she was given a date for elective surgery. And while she was waiting for elective surgery, the shunt malfunctioned and she came to the hospital in the middle of the night with headache and recurrence of vomiting. So this was the scan when she was first diagnosed with headache and vomiting. This was a CT scan done at that time, followed by the MRI. And thereafter, she came to us with a shunt in situ. And when we did the new scans, the hydrocephalus had increased. So we took her up for surgery. And this is opening of the arachnoid after the craniotomy was done. And you can see that the cerebellum is very full and almost bulging out, but it somewhat relaxes after releasing CSF from the cisterna magna. And because in the initial part of the surgery, there is very little space to manipulate because the cerebellum is swollen and the shunt is not working well. So through that very small corridor, I try to identify the floor first, and then fortunately, I'm able to have a glimpse of the pica on one side. And through that small window, I start debulking the tumor with Pusa. And as you can see, it is not completely avascular, but there is also, it bleeds not very torrentially, but there is substantial bleed. However, the tumor is suckable. So that was one advantage of having it there. And as the tumor is decompressed, I get more relaxation of the brain. And then I work superior to the loop of the pica that I had identified. I've coagulated some of the side branches from the pica which were going into the tumor. And because the tumor is suckable and not, and once I coagulate the side branches, it becomes relatively avascular. So I'm able to deliver the tumor, most of it, and that's the floor of the fourth ventricle with the calamus scriptorius being seen. And that's the stria medullaris again. And obviously, there's no attachment at the floor of the fourth ventricle. So that's probably a medulloblastoma, and that's the CSF coming from the aqueduct of Sylvius. And that is the closure. So cerebellums are relaxed nicely, and that is the post-op CT scan. I did a post-op MRI and there's a small bit of tumor left near the right pica, which I could not separate from there. And this is the child after 3 months of surgery, post-radiation. Gait is relatively well balanced. And as expected, the histopathology came out to be medulloblastoma grade 4, and this is the child at 2 years of follow-up. Another case, I think a little more difficult than the previous one. A 25-year-old gentleman who worked in one of the airline companies came with headache and suboccipital neck pain of 6 months duration, and there was incessant vomiting for the last 3 weeks. And on examination, he had headache, some features of raised ICP, but mainly he was having difficulty in walking because of ataxia. And this is the scan which was there in the which he came with to us. And you can see a very heterogeneous lesion with either some flow voids or calcification. So this is the surgery again after a midline suboccipital craniotomy. You can see that the tumor was going right up to the C1. So we've also taken the C1 lamina along with the suboccipital craniotomy, and I cut the arachnoid over the tumor. And following this, some arachnoid stitches are taken to open up the tumor window. After initial biopsy, I start to debulk it. But as you can see that this is a relatively more vascular tumor. But like it has been described that you use the CUSA, debulk it in one corner. So I kept following that principle, and you are able to feel from your tactile sensation that you are pulling at tumor and probably not at the brainstem. After doing a number of cases, you are able to identify that. So I already saw the upper pole of the tumor, and this is the lower pole of the tumor. You can see the underlying C1 spinal cord at that level. And the good part was that I was able to roll off the tumor from where it was occupying the space up to a certain point. And these are probably some dentate ligaments which were going either into the tumor, or they were trying to, or it was because I was trying to trace them. Yeah, so probably it is going around the tumor, and then it is going to the attachment in the spinal cord, and it is draped by the arachnoid all around it. And that's the first view of the lower cranial nerves, probably fibers of the 11th. Again, dissecting it from the dentate ligament around it, and I can see some branches of the pica there. This is on the right side, on the left side of the patient. So once you see CSF here, it gives you a little more courage. And then in the similar fashion, taking it off from near the obex. And I'm rolling the tumor from inferior to superior. Just in similar fashion. And here I start seeing the pica on the left side of the patient. And fortunately, I'm able to remove most of the tumor from the pica just by suction. And if you can see that, though in the upper part of the screen, you can see the part of the tumor which has been covered by patties. But on the left side, I can remove part of it. And here I thought that I had injured the pica in some way. So I put a patty there, and I just wait and go to the other part of the tumor. But then I see the pica on the other side. That's the tonsillar loop. And fortunately, it just peels off. Those are the lower cranial nerves again on the other side. And when I explored that part, it's fortunately a side branch of the pica, which was going into the tumor. So I'm able to take care of the hemostasis, and then as I'm pulling the tumor off, after it has been sufficiently debugged, I can see that part of it is coming from the floor. Honestly, I could not find any calcification inside the tumor. And that is the floor on the right side of the patient. That is the vertebral and the pica coming out on the right side of the patient. I'd already seen the superior part. And there's a part of the tumor which I could not find any plane. So a very thin sheet was left behind. And this I check again on the left side. And the superior part I'd already seen before. So this is the, again, post-op scan. This is the post-op MRI that shows that thin layer of tumor which was left behind on the floor because I could not find any plane there. So histopathology came as anaplastic ependymoma WHO grade 3. This was the follow-up at 1 month after surgery. And thereafter he went for radiation, but I have no follow-up. So thank you very much for the opportunity. Any questions and comments?
Excellent presentation, Doctor. Do you use CUSA or not?
Yeah, CUSA, yes, sir. We CUSA.
Because we are mobilizing the tumor, no?
Yes, yes.
Instead of that, we can decompress with CUSA and it will be easy, no?
Yeah, actually, sir, those parts I have edited because this is almost, I think I took around 4 or 5 hours to the second one.
Any questions?
Do you use any intraoperative neuromonitoring? Because
yes, at this point we did not have. This is, I think, almost 2 years back. But we have the intraoperative neuromonitoring for the last 1.5 years. So after that, we have ventured into intraaxial brainstem lesions also. But at this time, we didn't have.
This is also one point that if you exercise the C1 arch, actually you will get the base very quickly. Then you go down like this and then pull out the tumor.
Yeah.
Because sometimes pica, you have an extended so it's always better to exercise the C1 arch and make the incision down and see the tumor this way from inferior to superior. That means that you see a normal plane and then you go.
Well, congratulations. How many years out of training are you?
I'm now 8 years, little more than 8 years.
Okay. And have you done many fourth ventricular tumors?
I think I've reached now about between 15 and 20.
That's very good. Yeah. No, you've got good technique. I'd just like to make a couple of comments about ependymoma. Just remember, I'd just like to remind everyone that ependymoma is the most surgical tumor that we know. They are typically radio resistant and chemo resistant, and every study, bar none, has shown the importance of a gross total resection for ependymoma. So I wouldn't have done that. I would have, if I had left some tumor behind, I would have consented the patient. I would have sat them down and spoken to them very seriously about a second look surgery, resecting the rest of the ependymoma, knowing that you're going to be possibly damaging the brainstem and possibly leaving him with a neurological deficit. But I would rather have a neurological deficit and a complete resection of ependymoma than have radiation. Radiation is almost like a waste of time. And even with anaplastic ependymoma, it's surgical resection that is paramount. It is the most important prognosticator when it comes to ependymoma. So that's just my approach. The second thing is that there were times there that I wanted you to have a stronger sucker. If you had had a stronger sucker with a sucker regulator, as you were lifting the tumor with your sucker, it was sort of falling down again. But if you had a strong sucker, you could have sucked it all up and it would have made the operation a whole lot nicer and probably a little bit quicker. There are suckers you can get now where they will enhance the suction of the wall sucker. So wall suckers are typically not very strong. But in my operating room, I don't know what it's called, but I have another suction machine that is really strong. And then I have the Esculap sucker regulator. So, and with the sucker regulator, you can get your assistant to put the finger on the hole of the regulator and it gives you full suction, sucks up the tumor. And if you catch a blood vessel or some nervous structure in it, quickly take your finger off and it quickly gets rid of the suction. Not dissimilar to the Fukushima suction, on and off sort of thing. So just a technical point that I think would have made your surgery a little bit more economical.
The suckers I'm using are actually the Fukushima suckers, which have that keyhole.
Yeah.
But I think as I build more experience, I'll get more courage to do that.
Yes, you'll get more courage to do that. Yeah.
Sir, one thing for Professor Teo, your comment which you have made makes me more courageous that if a tumor is attached to the brainstem and not clearly, the plane is not discernible, generally what happens, we leave the tumor to the brainstem. But what your comment is that you will produce neurological deficit and remove the tumor completely. That's a completely different idea. And from the patient perspective of view, that gives a complete remission of the tumor. Although that will be criticized by what I feel in my hospital, if I take that strategy, I will be criticized by my colleagues and everybody in and around me. But in the long run, the patient will be benefited. So, very godly idea you have told.
No, it's a very good point, but I feel very strongly about it. So, okay, so I was, you don't know, but there was a chap called Alex Sanford. And Alex Sanford was the chief of neurosurgery at St. Jude's in Memphis, Tennessee. Lifelong experience, a very experienced man, called a spade. And I will never forget when he got up and gave a talk on ependymoma. He said, look, in my last 30 years, ependymoma is just the one tumor that's really challenged me. And so he said the most important thing about ependymoma is to speak to the family about the two approaches, your approach and my approach. And so your approach is, if it's invading the brainstem, leave it, because if you try and take it out, you'll give them neurological deficit. But you must also tell them in the same breath that if you leave tumor behind, they will die from their ependymoma. So if you follow your patients long enough, ependymomas, they all die. They all get recurrence and they all die. And you don't know because you're too young. But me, at 67 years of age, 40 years of pediatric neurosurgery, I can tell you now that all those patients where you leave a little bit of tumor behind, they all die. Sure, it might be 10 years later, maybe 15 years later, but they die from their tumor. So it's well and good to say to your patient, look, I'm going to leave tumor behind because if I'm too aggressive, I'm going to hurt you. But as long as you also tell them in the same breath that they will die, your first operation is probably your only operation of curative resection. And so Alex Sanford used to say exactly the opposite. I'm going to sit the family down and say, if you want me to cure your child, this operation is my only chance of curing your child. And I may cause deficit. I may cause facial weakness. I may cause paralysis. I may cause disturbance of balance. But I would rather do that than leave tumor behind. And again, I can tell you now that the whole concept of invasion of brainstem, it's bullshit. It invades the ependymoma, but it doesn't go into the brainstem. So I can show you so many cases where I suck off the ependymoma from the brainstem and there's a nice plane. So please don't be fearful of that. You will find a nice plane, and in most cases, you will not get a deficit. I've got one patient where I did 163 tumors in one sitting endoscopically. So 163, he had, multiple ependymomas spread all through his ventricles. And I spent 6 hours with the endoscope shaving off the ependymomas from the brainstem, from the ventricular walls, and just shaving it off with the sucker, coagulation a little bit, no deficits from 163 tumors. So that whole, when you read the textbooks say, don't, if it's invading the brainstem, leave it alone. You can take that ependymoma off the brainstem, especially virgin cases, and not get a deficit. So I feel very, very strong. I've had just 2 patients die in the last week. And both of them were operated on by another surgeon, left tumor behind, came and saw me. I took the tumor out completely, but it's useless. You can be as aggressive as you like with the second, the third, the fourth surgery, but if you leave tumor behind the first operation, they will spread. They get ependymal spread everywhere, and they die. This boy that I died last week, I bought him 20 years of life. I operated on him when he was 4 years old. He's now 24. He died at 24. And if I had operated on him the first time and achieved a complete resection, he'd be alive. He wouldn't. I know it. I know it. I've got patients from Little Rock, Arkansas that I operated on 40 years ago, and anaplastic ependymoma, invasion of the brainstem, but I took it all, and they send me Christmas cards every year. You've just got to trust me on this one. And you're absolutely right. I've written articles on ependymoma. I've written letters, and I've been criticized widely by oncologists and radiation doctors. Oh, that's ridiculous. You know, they respond to radiation. They respond to chemotherapy. Bullshit. They respond for a few years, maybe. Their progression-free survival is increased. Their overall survival is increased, but they still die. You follow your ependymoma patients long enough, and they will die. Promise you. So yes, you're absolutely right. Your approach is the standard approach. You know, if it invades the brainstem, leave it, and give them radiation and chemotherapy.
Charlie, the issue is, the technique the technique you learn and then you execute that. And you set the line of demarcation and where you can go in. And that is where, I think probably that is where the issue comes. Because
you don't know at what point to stop.
That's what he says. He's 40 years of his experience. He asked you the first question, how many years? 8 years. So there's a big difference, right? Now, because we also see the same thing, like when you keep going, then you realize at some point of time that you don't get the plane. And I have listened to your lectures that, the suction makes different noise. Now, I use QSA quite a bit, QSA. But then sometimes I feel the suction gives a better proprioception rather than the QSA. The QSA does not give the proprioceptive feeling, but whereas the suction gives the proprioceptive feeling. I think probably that point is more important in this discussion.
Yeah.
That's what I feel, that because ependymomas, we feel that there is going to be plane, and then you can boldly go ahead to the floor and then dissect it very meticulously. I think probably that is the point he's trying to make.
Yeah, I would not use the CUSA doing an ependymoma. I don't use the CUSA at all, but certainly with ependymoma, I would never use the CUSA. You're absolutely right. If you have good subtle suction and variable suction, you can just suck it off, shave it off. Even if it's digging into the brainstem, you will still find a plane.
Yeah, that's
Not with the CUSA, but with the suction and bipolar. Oh my God, you've got to trust me on this one. You've just got to trust me. I can show you all the videos. I've got them there on my computer now. I promise you. I'll show you the videos of me shaving off ependymomas off the ependymoma, off the floor of the fourth ventricle, and you're holding your breath and go, ooh. It's very frightening, but I promise you see a plane, and in most cases you don't cause a deficit. And yet when you read all the books and they say, oh, if it invades the brainstem, it worsens the prognosis, and don't chase it in the brainstem. No, I've chased it in the brainstem, even if it digs into the brainstem. It's like, digging into the brainstem.
Thank you, Doctor.
Thank you very much, sir, for your comments.
Now, I would like to call upon the next speaker, Dr. JKBC Parthiban, sir, to speak on the topic optic nerve monitoring in suprasellar lesions. Kindly join us, sir.
Thank you very much. I think we are very late in the evening, but then this is a topic which I really wanted to bring to the conference. Intraoperative neuromonitoring is becoming now routine in most of the centers in our country. And we use it very regularly for all spinal cord tumors and of course acoustic neurinomas most of the time. But then I started thinking about it, why we commonly do the pituitary tumors and craniopharyngiomas at suprasellar regions. And we often see the optic nerve, but we never monitor that. We never monitor it and we have no clue about it. So we tried, we thought we have to start monitoring it and see what is happening and how much it is going to help us in the outcome. So that was my idea of this particular my talk. So visual evoked potential was taken initially, but there are a lot of technical problems which I found it because they have to put this goggle, they connect it, and then there are the wires which receive these signals, and then we get this P100 peak. So the P100 peak is the one says that your optic nerve is very good. The moment the amplitude is not good or there is going to be a problem in the latency, that is going to be a trouble for you. So I made it a point that I wanted to use it in all my pituitaries, all my whatever the sellar and suprasellar regions to try to see how it is. So I have done nearly about some 28 cases now, but some of the cases, so big and they are already lost the vision on one side, and it was not very happy. But then when there is a partial visual field defects and then the partial visual defects, those cases, then we start thinking about it, how we can, it's useful to us for two reasons. One is controlling our techniques, number one. Number two is the outcome, post-operatively, how this patient is doing well. So here is a tuberculum cellular meningioma, and this was the size of the tumor more on the left side. And this is the post-operatively, we could able to reasonably remove this. I'll show you the video. I think the video is going on. Yeah, it's going. Yeah, so as usual, that is the base where you take out the blood supply and then start using the QSA. I use the QSA quite a bit, very liberal in my practice. And then this is after complete excision, you can see the pituitary stalk. This left optic nerve, right optic nerve, and then lateral to the this optic nerve, carotid artery, and so we are trying to work out how our surgery is going. During this time, the visual evoked potential is on, and we keep communicating with our technologists, and so see that do you find any change? Is that if there's any change in your the P100 peak? So that was my idea. While we do all the surgeries, that was my idea, and this is on the left side, and this is on the right side, and this side is the right side, this side is the left side, and you don't find P100 here. The waves are not good. In fact, that I have to learn quite a bit from this, the physiologists and the technology people. And on the right side, it is good. Obviously, the tumor was more focused towards the left side, and the view to the left frontotemporal. In the post decompression, you find the P100 is improved. So that means that I can predict a good amount of improvement in their outcome, which I found it. In fact, two ways we do is the one is we subjectively we ask the patient, how do you feel, that how is your vision? But I find it that except in the pituitaries where we do from transpenial, which is very small, very few people say that immediately I'm doing well. It will take some time for them to say, yes, I'm better now. So this improvement in this P100 was giving me much encouragement to prognosticate how the patient will do well. That I correlate with my surgical technique as well. So this is the improvement. In this case, there was an improvement. This is the another, I think this is the same. This is another patient. You can see here, there is a small meningioma here. And this is just very close to the anterior clinoid on the left side. And there was a defect of vision, partial defect. In this case, also we did the same taking frontotemporal, and then we completely removed this tumor. Yeah, these are the pictures. As you can see the tumor, the same technique. I'll show you the video here. Yeah, this tumor though look very small, but then the way the optic nerve stretched is more than what we saw in the previous one, and we could able to dissect and remove this tumor very safely. But if you look at my suction tube, it always keeps on the side of the optic nerve and keeps the optic nerve. Suction tube is helped as a source of retractor, and so we just retract it. The more technical point is here, either you do a clinoidectomy and then remove this, or you can always do different techniques to remove the tumor below into the canal in this region. So this is the time I keep asking my to find anything change going on. The reason for that is when we do the acoustic tumor, we get some noise. When you see the seventh nerve is that tuck tuck tuck. So but here in optic nerve we do not have anything. Actually, you find. So this tumor was. See, you look at this stretch. In the process, the focus is here, but in the process, optic nerve. So what is the endurance of the optic nerve? That's also my point. How much the optic nerve? Can it just go away like that when I do retraction? So this is after the excision of the tumor here. So I was very happy. Then I saw the vasculature, everything is good. There's not much of, the so-called the angry or, unhappy optic nerve. Optic nerve color is good. Everything is fine. Now I wanted to check my visual level potentials. I went back and I asked them, you can see that post-operatively there is a mild reduction in the amplitude. So this made me a little bit skeptical. This presentation is, I do not know, I have not listened to any VEP presentation so far on this subject. So this made me a little bit skeptical how the patient will fare in the post-op period. So I went and asked the patient. The patient was good. In fact, the patient said, I'm okay and I'm fine. Now, so this reduction in the amplitude, should I take it as a how can I say that, whether it is a false positive or false negative, I do not know. So I was a bit skeptical, but I kept it in my mind because I had to do large number of cases to understand it or to go through the literature again and again. But this patient went out well. And this is a huge macro invasive pituitary adenoma, another case, a very large one. I told them two things, very invasive. But I'm not a very great, tumor surgeons like Charlie or something. I'm a very moderate but good neurosurgeon. So I try to do in two stages. One is through the cranial and then through the transnasal. So I approach this one. It's a huge one. You look at this, but here the optic nerve is not very much. It looks as if it is compressed, but it is not. But this patient had a kind of a visual impairment of bitemporal hemianopia, more on the left and then on the right. But you saw the other optic nerve, which was, very short, but it was very angulate. But this fellow is very straight long, and you have a very, very long, that is post, the chiasm is pushed to the posterior. You had a huge area and also created by this. And you can see this with the video. Yeah, you can see this optic nerve was good. The chiasm was here. I was able to excise, but as majority of this pituitary tumors, it doesn't look like they are having a very soft capsule. In fact, the capsules are very hard. They are not that easy to cut at this region, particularly at the at where the dura comes in. This is not very good. And this is into the cella. I try to remove as much as from the cella, as much as cella. My aim was to decompress the chiasm first. Because in macroadenoma, the thing is that try to do maximum and decompress and then pack that cellular region for hemostasis. Yeah, this is the capsule here. You try to excise the capsule and go as posterior as possible to see the pituitary stalk. And we were trying here in this region posteriorly as much. Again, because I use, as I said, no, I have avoided using this pulling business in my practice totally. No pulling at all. Particularly after CUSA came, my views of brain tumors have changed completely. And this is the posterior wall again. So with all these movements, when I'm doing all these movements, I'm pretty much asking with my VP guys, let me know please in case if you, because 50% of reduction in amplitude is considered as very serious, you stop it in spinal cord tumors. Okay, so whether that principle here, you can watch here, this is the point I wanted to, maybe I think Charlie can comment on that. Sorry, how to go back. Yeah, I'm sorry, I'm just, this particular place, this, yeah, there's a bit of tumor which was very much adherent to the anterior cerebral vessels here. Yeah, look at this place. I was very skeptical here. Skeptical to dissect as good as I'm not very sure. And so that little part, I left it. I did try to pull it out. I left it. I have to tell what I've done. And in this case, you can see here and pre-op and post-op, left looks the same P100 and the left side is slightly reduced. In fact, slightly reduced. In the post-op, you find on the right side is good. Right side is also slightly reduced, I can say. So visual work potentials, whether it is going to really give us a complete one, I have to think and see. This case is another case which we did through transsphenoidal. We were able to remove the partial, but then we were able to decompress the chiasm. Decompress the chiasm very well. And you look at these waves here. These waves are the same during and intraoperative. They were the same. There was not much change in this case. But then in postoperatively, after some time, there's a phenomenal improvement. P100 has come back very beautifully. P100 waves, it is a reversely printed one. P100s have come back very beautifully. So that means that these patients will improve. So this patient also had a very good postoperative outcome. So this is my presentation is over, but then the final conclusion is, I'm still not able to really understand the P100 waves. But I'm using at present right now is to, as a policeman, you tell me if it is reduced, I'll stop it or something like that. But if I'm not getting the P100, the waves at all, I am blind. Bit blind, and we have to be technically very careful. It's not like acoustic neurinoma. I'm trying to say this way. In acoustic neurinoma, you know that because you get the noise, then you know where it is. Or in spinal cord tumors, then the amplitude is coming down more than 50%. You get a policeman guidance. But here, still not it. I don't know. I like to know about others' experience if we have. Thank you very much.
All right. Well, I like your idea because in my brain tumor lifetime, I've caused more blind eyes than I've caused deaf ears or any other neurological problem. Because if the optic nerve is very compromised preoperatively and they have poor vision preoperatively, my opinion is all you've got to do is look at the optic nerve or touch it, and you're going to worsen their vision.
Yeah.
So if there's any means or any monitoring that would tell me to stop early, then I would use it for sure. So it's a great concept. I commend you on this preliminary pilot study, and I would like to hear from you in maybe 5 years' time when you've got maybe 20, 30 tumors under your belt to tell me if it is actually a worthwhile venture. There's only one comment I'd like to make, and that is Yashigal taught me that anytime you operate around the optic nerve, just open the falciform ligament. I notice you haven't done that on your cases. Just open it. Even if the vision's good, open the falciform ligament, and any manipulation of the optic nerve is you get a little bit more freedom. So that's the first thing I do. Open the falciform ligament, and then I manipulate the optic nerve as gently as I can.
Thank you. It was a new idea, sir. Actually, I had one experience. One patient who was treated by an ophthalmologist with total loss of vision. They were treating him as neuromyelitis optica. And without doing any imaging, after some time they did imaging, the patient was referred to me. After that, I did imaging. It was a huge tumor, totally compromised the optic nerve. The pre-evaluation, they had this negative, P100 was negative. So I was also had an opinion that the vision was totally lost. So I was very confident in handling optic nerves during surgery. It was a meningioma. We excised in total. Surprisingly, the vision started improving immediately after surgery.
That's the point.
So within 2 years of time, he recovered complete 6/6 vision. Initially, it was 0/60. In the course of 3 months, almost 3/60. And surprisingly, recovered total vision of 6/6 within 2 years. So maybe this tool can be considered during intraop, whether the optic nerve compression was really compromised the optic nerve, or it is totally damaged, or it is recovering. Maybe it's a new innovative idea.
Yeah. How I got this idea was because 3 years ago, the Association of Intraoperative Neuromonitoring was started.
Yes.
I was there. I was there in Chennai.
Yeah.
In fact, I was pushing this guy, Sandeep Chatterjee, to go and take the presidency and go ahead. And that day, one lady technologist, she presented this. And I asked her, and where to get these goggles first? But then I realized that all the things were there in my hospital. It was there in the kit. Oh my goodness. So that means that it was there and we have not used it. Now I made it as a routine. You like it or not, use every patient, including transplant order, we are doing it. I have a good number, as Charlie said, let me go through that. I have given this topic as a thesis for my postgraduate also. I have to see how we come out with some ideas.
Any comments?
So I have a question.
George.
We are also using it for monitoring the posterior optic, that is the pathway, that is the optic radiation during epilepsy surgery. So we are also exactly in the same stage as that you are. We did a pilot study. So we have done it both under anesthesia and also in awake surgery. So we usually use it for occipital gliosis or occipital lobe lesions for drug-resistant epilepsy. And we have been using VEP and recording it the same way. What we look for is a loss of latency or a delay of latency. And the moment we get a delay of latency or loss of latency, then we try to be a little more conservative in our resections, because most of these lesions are not well-defined tumors. They are gliotic scars, or they might be focal cortical dysplasia. So we have very little experience about just about a few patients, about I think 4 patients. But then there is some meaning which is coming out of it. And we are also perhaps in the same stage as you are, but we are using it for monitoring the optic radiation, the posterior optic pathway.
Exactly. See, we should know what latency means, what it happens, what amplitude means, what it happens. How does it, help us in guiding us? That's why I asked the previous speaker, Dr. Devashi, I asked you, why you didn't use Bera? Because 4 days ago, I operated a similar case. Like he said that fourth ventricle tumor, I operated a very huge one, which with a cystic and then solid component. I think probably it is not ependymoma, it may be something else. It was pretty adherent to the at the floor at few levels. I could not remove that. In fact, maybe I was using the hues are there, but then I was monitoring the BERA all the time because I'm a bit worried about outcomes. Yeah.
And an additional thing that we have been able to do in awake patients is that you can have a reverse stimulation, that you stimulate the occipital cortex and you have photopsia flashes of light. So some of the awake patients will actually report that. So that is an additional finding that we have, but we've not been able to theoretically put all the pieces together and make meaning out of it.
Thank you. Thank you very much.
So even I have a question. So these are little technical questions as I'm an electrophysiologist. Sir, you mentioned about the frequency. How frequently are you using throughout? Whether it is intermittent or it is continuous?
No, my boys are using continuously.
Continuously.
See, this is what I asked them. I asked the same question to my technicians that the blink, the blink they give, I think they can give, if you want, you can stimulate, or if you want, they can stop it. See, for example, you are not very close to the optic nerve. Why do you need to? When you are in somewhere else, when you are doing that, so this is a team. So it has to be. The best thing is that to continuously operate, continuously to monitor when we are very close to the optic nerve. That is the one thing. If you are in some other part of the tumor, no issue.
Another point, you mentioned that when we compare with the facial nerve, we see some irritation. But have you seen anything in the?
No, see, that is it. That is the reason. See, in the facial nerve, we ask our technologists, please give me, I want to hear the noise. The moment I am close to the seventh nerve, I just wanted to hear.
Okay.
I just want to hear something so that, I know. Because sometimes they will say that, sir, please.
Yes, yes.
Sir, please. I said that, no, you give me a noise so that we can wait. But in optic now, it is not so. So we don't get it.
Okay. Sir, one more thing. As you said in the starting, putting the goggle is challenges. Any tips for that, sir?
There was some problem initially. We had problem with the draping. First putting that in draping and all those things, we had some issue. On top of that, we also sometimes use the navigation.
Yeah.
So
registration.
we had problems.
That is challenge, yes, sir.
When we put the navigation tools here and then the one coming here and this fellow is there, it's something like the way the patient looks is something different for us. So we had some technical problem.
Okay.
But my technicians are now mastering that glimpses that part.
So one more question. So this hemi-field VP is new technique. So do you think that will add anything in future? Hemi-field visual lever potentials.
No, I don't know which one.
Okay.
You tell me what is that?
So this is advanced technique in VEP. What we are doing for the retinal and nasal fibers, sir. This is more advanced in VEP, sir.
All right.
This is in research level still.
That's good, but we like to know about it. Yeah.
Okay.
Thank you. Thank you very much.
Thank you, sir.
Thank you.
Thank you, doctor. Now I would like to call upon the last speaker of today's session, Dr. Ramesh Nair, to speak on the topic cranial avidural fistulas, its anatomy and surgical management. Kindly join us, sir.
Thank God it's the final talk. Probably we are very past the time. 5:20 now? You can go the video with it. Should be possible, no? So slightly different topic. I'll be talking on the cranial AV dural fistulas. Most of these cranial AV dural fistulas are treated by our endovascular colleagues. But there are some cases where we have to do surgical intervention, which may be the ideal option for such patients. So I'll go through some of these cases. Most of these cranial AV dural fistulas, they may be asymptomatic, but some patient may come with very common symptoms like tinnitus. This is a lady who was in her 50s, 55. In 2019, she went to the ENT specialist with the tinnitus. And so something was noted. I don't think this, something was noted around here by the radiologist and was recommended to have another further vascular imaging such as CTA. But then she was subsequently lost follow-up. So the symptoms can be varying. Many of them are asymptomatic, and the average incidence of these fistulas are about 10 to 15%. In general fistulas, they have about 10% chance of everything, having hemorrhage or having mortality and things like that. But some of them can involute spontaneously as well. So just like meningiomas, we talk about meningiomas according to the location. Similarly, for fistulas, they can come around the transverse sigmoid sinus area. That's the majority of fistulas. And along the superior sagittal sinus or the cavernous sinus and tendorium. And some of these fistulas come at the level of anterior fossa from the ethmoidal artery. And sometimes we can classify not only on the location, but also depending on their arterial supply. So this is the lady who had this tinnitus, came back again with persistent tinnitus a few years later. That's 2019, now 2021. And then she's got this MRI scan, which you can see there is increased vascularity around the petrous bone here. So she's got this petrous apex kind of fistula. And she was then sent to the clinic. So after discussion, we then proceeded to have further angiograms. You can see many of these meningiomas, many of these fistulas get supplied by the internal carotid artery through the meningiohypophyseal trunk. You can see the fistula supply here and the draining veins here. But also they get supplied through the external carotid system, middle meningeal artery over here. And you can see the draining veins, which are slightly dilated. So these are concerning findings on a patient with the dural fistula. When you have a cortical venous reflux, there is a high risk of hemorrhage in the long term. So we would always recommend treatment for such patients. And endovascular treatment option was the first options thought about this case. You can see the veins were dilated. And this was a cornea type 4. The classification of fistulas are a few classifications starting from Maryland and then evolved into different classification. Common ones are like this, Borden classification, where you have a type 1, where the venous drainage is into the dual venous sinus or the meningeal vein, but it's an anterograde flow. It flows naturally into the vein and doesn't reflect, doesn't go back into the vein. But sometimes it can reflect back into the venous sinus. So that will build up the pressure within the sinus, or it can go directly into the vein. So this is the Borden classification, very simple classification, very practical classification. But then there are other classification, which is also very useful practically, from 1 to 4, where depending on their flow, we can classify into 1 or 2 and 3 and 4. 2 again can classify depending on their flow, andrograde or retrograde. So I will not elaborate much on this classification. You can see, just to explain this final figure here, this is a type 1 where we have the artery coming in and then supplying the wall of the sinus, then blood flows and the arterial blood flows into the sinus, then gets drained down to the jugular bulb. In the type 2, you have some block and maybe thrombosis, and there is reflex back into it. So the whole arterial venous system is pressurized. Eventually it reflects back onto the vein as well. That's when it becomes a cortical venous reflex. In this case, the fistula is directly into the vein rather than sinus. That's the type 3. So again, these two classification can be correlated and depending on the flow and the location of the fistula. So this lady then underwent endovascular embolization first. These endovascular embolization didn't go well because during the attempt to embolize the middle meningeal artery, the accessory meningeal artery, some of the embolic material got into the accessory meningeal foramen and eventually reflects onto the arterial supply to the facial nerve. So I can see that some of the facial nerve gets applied by the stylomastoid artery and the middle meningeal artery, and the whole thing is supplied by various branches. Sometimes when you get embolic material going into the artery, it can lead to an infarction of the artery. So that is what happened in this case. She woke up with the facial nerve palsy, which is a terrible, and she was really upset, not surprisingly, and they had a CT scan which has confirmed the embolic material in her stylomastoid foramen and the accessory meningeal foramen. So she never went back, even though she was offered another attempt to embolize the fistula. The fistula persisted. So then she came for a surgical consideration. This is the typical appearance of a uterus fistula. You can see that the vein is very turgid. This is the typical location of a petrosal vein. We don't take veins, but these veins are useless veins. They contain high pressure arterial blood, and you always take them. And the main intention for dural fistula management surgically is that you disconnect the fistula's point. You don't have to take out all the arterial feeders into it. You disconnect the vein that is connecting into this fistula's point, and then you achieve your aim of your operation. And so surgically is not a technically challenging operation. Many of these locations, you can access them easily, they can disconnect it. But the main thing is that you have to make sure that you take out the correct vein. This location, you don't see anything else. You don't have to worry about anything else. Once you see an arterialized vein, you take it. That is not a useful artery. But in some location, it can be more confused, especially in the CV junction, when you are around the spinal cord, when you are around the anterior spinal artery, you have to be really careful with this surgery. So we will move on to she had a follow-up DSA which confirmed the disconnection of the fistula. There's no further cortical venous reflex. And she did have persistent facial weakness. And this is another case. A man in his late 50s came with a bleed, acute surgical emergency in the middle of the night. And this was after 2 weeks after his COVID vaccination. Possibly some thrombosis may have happened to the draining vein and he bled and eventually underwent emergency clot evacuation. Nothing was done for the fistula at that time, which was picked up later on. So why do patients get a fistula? You can get it mostly acquired. The theory is that there are some micro shunts on the walls of the sinuses. They open up with some insult, maybe some pressure, or maybe some thrombosis. And also, in addition to that, when there is high pressure, we can get ischemic, venous ischemia, which will promote angiogenesis through vascular endothelial growth factors. And any anomaly of the venous system, thrombosis, trauma even, sometimes even surgery can lead on to fistula's point. We have seen some cases like that. And pupular changes in the puparium can lead to. And some of the cases like tumors can lead to an associated dural fistula. This is one case we had. So a large tumor, highly vascular tumor around the posterior occipital area with thinning of bone and near the transverse sinus. And there was significant venous fistulation there. So this is a case which I showed you before who bled. And there was this venous channel here. The clot was evacuated, subsequently had a CT angiogram, and the fistula was coming from the anterior fossa floor, right from the ethmoidal artery. So the ophthalmic artery supplies this fistula through the ethmoidal foramen and the ethmoidal artery. So this is the angiogram. You can see this is the appearance of the ophthalmic artery here. The fistula is around here and this weak venous varix, so had to be operated. Most of this ophthalmic supply for fistula, they're not ideal for endovascular treatment because the endovascular surgeons are not very keen to go through that ophthalmic artery. Here, during the operation, the fistula ruptured, torrential bleed had to be controlled. And then the second step is to go down to the anterior fossa floor to find the fistula. Here, the fistula is being cauterized at the base of the anterior fossa. And then there was a concern about bilateral supply. I had to open the the forks to get into the other side to disconnect the feeder from the other side. So they are not that challenging. So just opening up the forks there through the Krishna. So this is the man who had this craniotomy done. He was very unwell after the operation, but eventually did some recovery. He was sent to a nursing home. 8 months later, he was still in the nursing home, but able to do video calls with his family. So these patients do get better, but can have devastating complications from dural fistulas. So what is the natural history? If you have 100 patients and if you follow them up, what will happen? What's the natural history? If there is no reflex, many of them can get better. Some of them can improve spontaneously, but many of this 100 patients, 55 didn't have any treatment. 55 didn't have any reflex, and many of them were not treated. So after of those patients who were not treated, many of them improved on their own. Those who were treated with the reflex, some of them didn't get treatment. So they had about 20% chance of a hemorrhage per year. That's the risk of dural fistulas. And a few more studies are there. Roughly the incidence of hemorrhage is about 10%. And there are other complications from fistula as well, not hemorrhagic, but like seizures or visual problems and things like that. What are the treatment options? Obviously, we can leave them alone. And if you treat it with endovascular option, which is often given the first priority if you have arterial access or venous access, not possible in all cases. Can be embolized with a particular matter or blue or onyx or combination of procedures. And because there is a concern about venous stenosis and venous pressure, venous stenting is also a proposed technique for this. But surgery clearly has a chance and a role. And often in some cases, you may have to do multiple procedures, including radio surgery as well. Let's look at this one. This is a lady who was in, most of them, these are females, had some proptosis and the suspected eye disease. There was no significant dilation of the ophthalmic vein, but she had proptosis. Eventually, she was found to have a fistula in the posterior cavernous sinus here, and went on to have attempted treatment. After this is the angiogram. You can see it's the indirect carotid cavernous fistula from the external supply and also from the contralateral carotid artery. And most of these carotid cavernous fistulas can be treated endovascularly, but not all of them, because there was an isolated cavernous segment. They were not able to get into the cavernous sinus with a lot of approaches, a lot of attempts, and significantly dilated cortical vein. This is a typical drainage vein through the Sylvian fissure through the phenoparatal sinus. So this is she was waiting for surgery at that time when I presented, but just before coming here, I operated her. So these are a standard operation for such tumors. You know where this fistula is. It's on the sphenoparietal sinus coming from the superficial mid-cerebral vein. You see I just wanted to show you this area because you see the arterial blood, this site is under high pressure. Then you open up and you find out the superficial mid-cerebral vein. This is the temporal lobe, frontal lobe. This is the phenol ridge. So you find out the area where the superficial mid-cerebral vein is connecting into the sphenoparietal sinus, and then you disconnect it. And you know the anatomy around this region very well, so that you don't have to worry about taking out any arteries. Any artery that is normally arteries do not come from the dural surface or from the bone, so you can safely take them if you're in confusion. You don't want to leave a remnant. So this is the whole stump of the fistula. The intention of the operation is to disconnect the fistulous component, not to really cure the arterial or the actual fistulous point. So this is the vein is being cut. And when I was exposing the cavernous sinus, which is here, I found another tumor here in this lady, which was not seen on the MRI scan. So she had a clinoid meningium, which had to be taken out. So that is the third nerve and the temporal edge. So let's see some of these patients who had other symptoms like trigeminal neuropathy on the left side. There was some venous engorgement around this area, but she was waiting for further workup and then bled in the meantime. She had an initial diagnosis in July. She bled in November. Subarachnoid hemorrhage and found to have a fistula around the V2, V3, V4 level. And these would require like a lateral, bilateral approach. You can see the left side, and the spinal cord is here, and the medulla is here. The fistula is coming from the side of the root here. This is a spinal accessory nerve. That's the ligamentum dentatum. So intention is to disconnect this arterial vein. And this is the area where you have to be absolutely certain that you're not damaging any normal vessels, which can be a disaster in these sort of locations. So this is the so this is the disconnection is quite easy. This is supposed to have scanned a few months later, and then a year later, no recurrence. This is another lady, tinnitus, but this is a tendoral meningioma. You can see the meningeal enhancement and the veins are on the tendorium, on the surface of the petrous bone. There's no infratendoral component, but the supratendoral component. So here, again, they can only attempt to coagulate the occipital artery supply. The middle meningeal artery supply could not be cauterized. Here we can see there's the cortical venous reflex, but supratendorially. So the way to approach this lesion will be like a small so she had an attempt to embolization, a repeat embolization show persistent flow along the veins. So this is the approach. The standard small incision above the pinna and the small flap. And these are fairly straightforward operation. You don't have to really struggle to, sorry. Once you know where the fistula is, you can easily get the fistulous compound. This is the base of the temporal lobe here on the left side. This is the fistulous area. You can see the whole venous system is engorged by the fistula coming from the tendorium. And the intraoperative fluorescein is quite useful because you get an arterialized flow immediately after the injection. The veins come a bit later on. And then disconnecting them is quite a straightforward operation. So this is removed in a very straightforward manner. So that so that's all disconnected, and then the final angiogram confirms that there is no more further flow and no recurrence. So this is the case which came with a young man, came with a large tumor around the occipital area. You can see that a lot of flow around the transverse sinus. The tumor was very vascular, maybe similar to the case that's shown in the morning. This was embolized to some extent, but the fistula component was quite big. Again, underwent, this is the MRI scan. You can see the vascular tumor with a lot of venous channels around the transverse sinus. The channels are quite open there. And then went on to have craniotomy. Embolization did help in this case, and eventually went on to have surgical excision. So ideally, this case would need another angiogram after the surgery, which we haven't done yet. So this is one more case I will show. This is a 66-year-old female, came with lower limb symptoms. So you can have a lower limb problem from a cranial or craniospinal fistula. MRI was done, nothing was found, scanned upwards. All you could see was some increased vascularity around the dorsal spinal cord. Then scanned upwards, you could see the cord is congested throughout, vascularity around the cord, and then flow voids around the upper medulla. You can see the angiogram, which shows significant supply fistula around the upper spinal cord and the medulla with cortical venous reflex all along the spinal cord. So these are not really ideally suitable for endovascular technique, given the concern about the origin from the ascending meningeal artery and the relationship to the angiospinal artery. So these are fistula can be treated eminently. This is a paralateral approach. Not much of condyle resection was needed. Here, all you need to find out is whether it is coming from the dura or not. once you find that the vessel is, because you don't know where this is a normal artery or a vein, this is a thing you have to find out. So this is the vessel which is attached to the surface. So here you can see, I'm just trying to find out where it's originating from. You can see finally, once you untangle the venous loops, you can see the whole thing is coming from the dural surface. So that is the fistulous point, and then disconnecting them is quite straightforward. So this is a follow-up angiogram. And there's one more case I'll show you. The final case is a young man with occipital infarction and stroke and incidental finding of a fistula from the anterenal fossa floor. This fistula is just behind the frontal air sinus and coming from the ophthalmic artery, but also it had a hybrid supply from the superficial temporal artery. So see, the scalp artery can supply it, and then he had an internal supply as well. This was the internal supply was treated endovascularly. So you don't need a big operation to disconnect the superficial artery, superficial temporal artery feeder. All you need is an incision over the forehead, just where the superficial temporal artery is traveling. You can see it is behind the frontal air sinus. That's the embolic material behind it. You can see the superficial temporal artery is going all the way there and then connecting into the fistula. So all you need to do is a scalp incision to block it. So I just wanted to conclude that the fistulas can vary from very benign course to very aggressive course. And they have a higher morbidity and mortality than most of the AVMs and aneurysms we treat. And the best way of management is often by collaborative work with endovascular surgeons and neurosurgeons. Thank you.
Excellent presentation, sir.
Thank you. So I would like to coagulate. The coagulation has a technique. These are all arterialized veins. They're not proper arteries. They're still friable. So coagulation should be very gentle, the lower setting, and use irrigation so that you coagulate bit by bit, and then finally use the scissors to cut it once you have occluded most of that segment of the artery. And you don't cut near the sinus or you don't cut near the brain, you cut in the middle, so you have a stump. And preferably, I would like to avoid using clips, because once you put a clip, sometimes they can be artifacts in the MRIs or even in the CT angiogram. So unless you have a big venous channel, ideally you can coagulate it rather than using clips.
You want to use Liga clips?
Liga clips, I've used it, but I don't think I have the AVM Liga clips. I find that their closing force is not very good. Sometimes they just fall off without you really touching it. So I don't believe.
Produce artifacts. That is also produce artifacts.
Yeah, they are smaller, and yeah, so you can use Liga clips if you want.
Thank you, sir.
Thanks.
Thank you, everyone. Now I would like to invite Dr. Sarvapandian sir to felicitate Dr. J.K. Basi Parthiban sir. Kindly please join. And I would like to invite all the chairpersons to join them. Now, I would like to invite Dr. Ramesh Nair, sir, to receive the token of appreciation. Cadaver decisions are simultaneously going on in the labs. Those who are interested can join them. All right, everyone, we are coming to the end of our session today. I want to thank all of you for the active participation and engagement throughout the time together. Thank you.
ही गोष्ट खरी ठीक आहे जाऊ दे प्रथम उपचार होऊ दे नाही मी आपल्या अजितला सांगितलं क्रांती करायची येणार की स्क्रीन एक मिनिट
कनेक्शन काढगाल करताना तिथे स्क्रीन जाते ओके ठीक आहे मला पण इकडे येत नाही म्हणून मी कनेक्शन हा 2 मिनिट इथे मी केवळ अंदाज व्हिडिओ कुठला कॅमेरा कुठला सिलेक्ट केला
Online now? Okay, so what we want to show is John around? John around here? So what we want to show is that's the second nerve. And that's a carotid, proximal dural ring, cave, distal dural ring. And this is a carotid continuing downwards in the cavernous sinus. Third nerve, fourth nerve, vertical carotid. This is the horizontal carotid, this is vertical carotid. Moving on, we have V1, V2, V3. And medial to V1, we have the sixth nerve. That's the sixth nerve. That. Going into the Doralus canal, I have cut the petrosphenoidal and the petroclinoidal ligament that forms the Gruber's ligament. Now, you come here. This is the petrous carotid. I have drilled a skeletonized the petrous carotid. And that's a pons. That's a pons. This is the anterior pons, medial to the fifth nerve. This is lateral to the fifth nerve. Any cavernomas, anterior pontine, lateral pontine, all this can be taken on this approach. Okay, and this is the petroclival angle. That's the petroclival angle. That's where all the petroclival meningiomas are. Okay.
Trajectory, you have seen the fifth nerve and seventh, eighth complex.
Seventh, eighth complex will be.
How to expose? How will you?
There is no need to expose. I mean, unless you are.
Petroclival meningioma.
Yeah.
Then I have to separate the seventh, eighth complex.
Well, so once you do the, I mean, if you want to expose, you can expose, but there is, when a petroclival meningioma, I mean, have you done a petroclival? Okay, so generally, what you don't need to do is, you don't need to expose too much in that. I mean, generally, the nerves, once you start decompressing the tumor and start pulling the tumor here, you will have the seventh, eighth complex here. Now, if you want to expose, the thing is, the head is extremely you see, it's in a very difficult, this is not the angle that I will keep for. You know, this is not the angle in my theater, but 100%, you know, you need much more turning and much more extension for that. And the thing is, but if you want, we will expose the seventh, eighth complex. So give me the Querison punch. It will be done in a minute, so there's no problem. Okay. Bite. All right. Okay. Now, more. Huh? Okay. Bite. Yeah. Large Querison now. You are already seeing the seventh, eighth nerves now. Can you see? I'll show you. Yeah. Right. Yeah. Yeah, I know. See, this is not the position of the patient in a case. See, can you see the seventh, eighth now? That is the seventh, eighth. Okay? You cannot see?
Actually, this eyepiece is something that there is big. Ah.
Can you see the seventh, eighth, seventh now? That's the seventh now. Okay? That's the seventh now. That is the lateral most limit of this exposure. That's the seventh. Okay? That now.
Yeah.
That's the seventh. Okay? So it's all the way from second to seventh. Now your approach, why don't you show it? Yeah, why don't you take it to the exoscope? You can move this body down and then. Yeah. Vinod, do you have another endoscope? Huh? Legin, do you have another endoscope station here? No, we wanted to show all those, I wanted to show from the open to the, to the endoscopic, can we get the endoscope ones here? No, do you have another endoscope? No, why don't you move it here? Yeah. Move it here. Forget the exoscope, then don't worry about it. Yeah, sure. Yeah, open करेंगे. कर दो. I will wash my hands. Yes. Guys, all the guys gathered here, we will look at the new HRS station also. Paresh. One of the most easiest and one of the best. We have been using it for 4 years. Excellent, man. The quality is much more better. Is it much more costlier than the previous one? Huh?
Yes.
It's much more costlier? Okay. No wonder. The quality is much better. Way better. It's almost maybe better than the Medtronic system S8 that we used. Yeah.
Hello. Hello. Hello.
cut the posterior PPCL, posterior petrosphenoidal ligament, and the PSL, the petrosphenoidal ligament we have cut. So that's a 6 now, going into the Doral's canal. So better now? Yeah. So yes, okay. Yeah, so you can see now that is optic nerve, that's a falciform. This is the distal dural ring. This is the proximal dural ring, which is the roof of the cavernous sinus. This is the intradural carotid, and this is the third nerve, fourth nerve, V1, V2, V3, and that's a sixth nerve going into the Doral's canal, and that is the retrogastrian fifth, and we have drilled the carotid canal, that is the C6 carotid canal, Petrus carotid. We have drilled it here so that you can see the Petrus carotid. See, that's the Petrus carotid. No, the focus is this is the Petrus. Can you see the Petrus carotid there? And there is the superior cerebellar artery. This is pons lateral to the fifth nerve, and this is pons medial, anterior pons. The focus is this is the Petrus. Can you see the Petrus carotid there? And there, if you come onto this side, that's the sixth nerve, and that's vertical carotid. This is the vertical carotid. This is the vertical carotid. This is intracavernous. This is sixth nerve. This is intracavernous. That is a paraclaval carotid. This carotid is a paraclaval carotid. No. This is paraclaval carotid. See, this from here is posterior. I removed the posterior clinoid process here, and up to here is clivus, and all this is inside the cavernous sinus. And then this carotid, because I have completely rerouted the. You are showing this area of carotid. Yeah, this is the What is the structure you are? This sixth nerve. This is the sixth nerve. Yeah.
Below that is you have to see the V2.
V2 is here. V3 is here. V1, V2, V3. So this is.
That segment.
Yeah.
That segment is according to now it is pre-cavernous.
No, this is.
No, there is something called a pre-cavernous. Here is the trigeminal membrane and that is here. That is here shown here.
See that is a pre-cavernous segment. So that is a pre-cavernous. This is intracavernous. Anything because sixth nerve is inside the cavernous segment. So this is pre-cavernous. This is sixth nerve. That is vertical carotid. That is because that is on. This is on the clivus. I have removed the clivus here. So this is the paraclaval segment, and the posterior clinoid process would have come here. That's the bend of the carotid. So this, and this is inside the cavernous sinus. This is pre-cavernous. This is sixth nerve. That is vertical. That is because that is on. This is on the clivus. I have removed the clivus here. So this is the paraclaval segment, and the posterior clinoid process. That's the bend of the carotid. So this, and this is inside the cavernous sinus. No.
What is the paraclaval is the pre-cavernous.
Okay.
That area is Is it just like a proximal and
yeah.
distal ring where it exits the cavernous sinus? There is a free cavernous
So,
membrane there.
okay.
And through it enters the cavernous sinus. So that part which is devoid
No.
of the veins is called a free cavernous.
Now what is happening? Yeah. Right. So this is the sixth now. This. Now, the sixth now is entering the posterior.
That may be the petrolingual ligament. That
The petrolingual ligament is here. This is the petrolingual ligament. No, this is the petrolingual. This is retrogastrian. Fifth nerve is here. And this is the petrolingual ligament. This will be the sphenoid, the lingular process of the sphenoid here. That unless I cut it, I cannot see it. Yes. You want to put, you have an endoscope? This is the petrolingual ligament. Yes, come show me the endoscope now. Fifth nerve is here. And this is the petrolingual ligament. This will be the sphenoid, the lingular process of the sphenoid here. That unless I cut it, I cannot see it. Give me 50-50 view. Yes. Yeah. You want to put, you have an endoscope? Put it on the other side, please, guys. Can you shift it on to the other side? Yeah, 50 endoscope. That's how I do endoscope assisted exoscope surgery. Where's my endoscope? Okay. 50-50 view. Paresh, इस तरफ कर सकता है ये? Put it on the other side, please, guys. Can you shift it on to the other side? Yeah, 50 endoscope. That's how I do endoscope. Yeah, fantastic. Where's my endoscope? Wait. I'm okay. I just have to see this part. Paresh, इस तरफ कर सकता है ये? 0 degree? And it looks like 30, no? 0? Light source? Yeah, fantastic. 30 degree, I'll take it 30 degree later, but light source on? Just have to see this part. Light on? 0 degree? And it looks like 30, no? I'm coming about the I'm coming about the optic nerve now, and then I'll go down. Paresh? Nahi aaya hai, Paresh. But light source on? Just have to see this part. Light on?
Marcio, you declined. Did everyone decline to be in the panel? That's okay. You don't have to go in the panel.
I'm coming about the optic nerve now, and then I'll go down. Paresh? Nahi aaya hai, Paresh. But light source on? Light on?
Declined. Did everyone decline? You're welcome to stay if you don't want to come in the panel. That's no
Okay,
problem.
थोड़ा support करेंगे मेरे को. See, somebody, question. Oh no.
Okay, well, okay.
थोड़ा support करेंगे मेरे को.
Hello, can anybody hear me?
See, somebody, question. Oh no.
Marcio, you declined. Did everyone decline to be in the panel?
See,
That's
optic
okay.
nerve, carotid.
Yeah. What I need to know.
Third nerve.
Working.
Fourth nerve. Support करेंगे मेरे को. It's here, no? No. Ready? Question. Oh no.
Declined. Did everyone decline? You're welcome to stay if you don't want to come in the panel.
That's a basilar tip. That's a basilar tip, absolute basilar. Both P1s there. Both P1s there. That's a basilar tip.
Okay, well,
That's a basilar tip. I'm going along the opposite P1. That's a basilar. Can you see the basilar? That's a basilar tip, absolute basilar. Both P1s there. Both P1s there. That's a basilar tip. That's a basilar tip. Coming lateral, going along the opposite P1. That's a lateral pons. Can you see the basilar? And I'll need to see the 7th, 8th there. Absolute basilar. Both P1s there. Water, I need some water. ഇവിടെ വന്നിട്ടില്ലേ? It will take a lot of sheet to that, that's fine. Yeah, much better now. And I'll need to see the 7th, 8th there. Do you have a 30-degree scope? Can you give me a 30-degree scope without a sheet, please? Water, I need some water. ഇവിടെ വന്നിട്ടില്ലേ? It will take a lot of sheet to that, that's fine. Yeah, much better now. I need to see the 7th, 8th there. Do you have a 30-degree scope? Can you give me a 30-degree scope without a sheet, please? Light source. Take a lot. Much better. Okay. Right. So we're going to look at it. Can you get it right, please? Okay. So, okay. Right. You have third nerve, fourth nerve there. Look at it. I'm going in medial to the third nerve. Get it right, please. Okay. That is the basilar. You have third nerve, fourth nerve there. Get it? I'm going in medial to the third nerve. Retrogastrin, fifth nerve. Coming back. That's the carotid canal. I'm going in medial to the third nerve. That's the carotid canal. There, that's the carotid. I'm going to turn this. Retrogastrin, fifth nerve. Coming back. That's the 7th nerve. Carotid canal. That's the 7th nerve. That's the 7th nerve going into the IAM. Can you see? That's the carotid canal. That is the 7th nerve. Yes. That's the 7th nerve going into the IAM. Yeah, both are seen. That's because I have a 30-degree scope. So that's the lateral pons. That's a carotid canal. This one, that's a carotid. That is a carotid. That's the 7th nerve going. Petrous carotid drilled out. That is the 7th nerve. Yes. That's a retrogastrin 5th nerve. Yeah, both are seen. That's because I have a 30-degree scope. So that's the lateral pons. That's a carotid canal. This one, that's a carotid. That is a carotid. Coming back. Petrous carotid above the third nerve. Coming back above the third nerve. Yeah, both are seen. That's because I have. So that's a carotid cave, optic nerve, carotid cave there, carotid cave. And turning back now. This cable is third nerve. Coming back above the third nerve. No, 1 second. Let me just remove that gauze piece. Can you give me a bayonet, please? That's carotid cave.
How are you doing, Paulo? Can you hear me?
Nerve. Carotid cave there, carotid cave.
Thank you. Okay, good.
Turning back now.
Do you want to test the video or did Dr. Almeta want to test it?
Yeah, I can test while.
So,
we're waiting.
1 second.
Okay.
Let me just remove
Can I
that
share my-
gauze piece.
Yeah,
Can you
go
give me a
ahead.
bayonet, please? Gauze piece again there. So, turning back now.
Do you want to test the video or did Dr. Almeta want to test it?
Yeah, I can test while.
So-
we're waiting.
1 second. Let me just remove
Can I
that
share my-
gauze piece. Can you give me a bayonet, please? Gauze piece again there. So, സ്റ്റാബിൽ ഉണ്ടിടണേ നിങ്ങൾ നോക്കട്ടെ നിങ്ങൾ ആ റിട്രോ മറ്റേ this is thing beautifully seen. Third nerve, fourth nerve, V1, and that is the region we have to look into.
Dr. Al-Mufti, test it.
Yeah, I can test while we are waiting for him.
Okay,
Can I share my?
yeah, go ahead.
See, your thing was, your view was like that. From front on, no? From the beautifully seen. Third now, fourth now, V1, and that view is the front. Your view is from the front. My view is from the side.
Yeah, I can test while we are waiting for him.
Okay.
Can I
Yeah,
share
you can
my-
see the third now going into the interpedanculars now. Your thing was, your view was like that. From front on, no? From the beautifully seen. Third now, fourth now, that view is front. Your view is from the front. My view is from the side. So retrogressive fifth. Petrous apex. You can see the third now going into true Petrous apex. Carotid. From front on, no? From the front. My view is from the side. So retrogressive fifth. Okay. Petrous apex. No, it's good enough. It's good. Can you give me the 0 degree now? So now, okay. No need. Yeah. No, it's good. It's good. Can you give me the 0 degree now? Yeah. So now, no need. Yeah. So let's have a panorama.
Okay,
Yeah. What are you? So third now, fourth now, and this is where I want to enter. That is a 6 now. And that's a horizontal part. That's a C4. That's a vertical part. What are you? And that's a 6 nerve. Third nerve. The Dorellos canal is that part is cut. That is a 6 nerve. This is the petrolingual ligament is here, lateral to the 6. There. That's a vertical part. Yeah. And that's a 6 nerve. The petrolingual ligament, let me show you. Petrolingual ligament will be here. This is the 6 nerve. And I go medial to the 6 nerve. This is the petrolingual ligament. This. No. Just lateral to the carotid. Just lateral to the. See, yeah, just lateral to the carotid. So, see the carotid, trace the carotid. That is a petrolingual. No, lateral. That is a petrolingual ligament. That is a vertical carotid, and that's a petrolingual ligament. Go medial to the 6th nerve. So if I have to cut, I have to go medial to the 5th nerve, retrogressive in 5th nerve. Just lateral to the carotid. Just lateral to the. Yeah, that's a 6th. Lateral to the carotid. So, see the carotid? Yes. So that is a 6th nerve going behind the vertical carotid. That is a petrolingual ligament. That is a petrolingual ligament. Petrolingual ligament goes all the way. I'm going anterior to the carotid now. This is the vertical carotid. See, that's a petrolingual. You can see the ligament clearly now. Yeah, that's a petrolingual ligament. Okay, that's a petrolingual ligament. That is the 6th now going behind the vertical carotid. That is a petrolingual ligament. Petrolingual ligament goes all the way. It is, yeah. This is the vertical carotid. The channels, we have cut everything, no? We have cut all the channels to make things clear. So unless you cut all the channels, all these 6 nerve cores, everything is not clear, right?
We have this governance segment.
Yeah. Yeah. So earlier we used to, but now we bypass. We have cut all the channels to make things clear. So unless you can easily clip it. But then when you clip it, the problem is the 6th nerve. The 6th nerve is going to get added. You understand? The 6th nerve is going to get added. So that's the problem. You can easily, with this view, you can easily, you have exposed the Peters, you have proximal control, and then you can go and clip it. But if it is laterally directed, you can't clip it. You can clip it medial to the sixth nerve also. No problem. But better to, just trap and bypass. Understand? The sixth nerve is going to get added. So that's the problem. You can easily, with this view, you can easily, you have exposed the Peters, you have control, and then you can go and clip it. But if it is laterally directed, you can't clip it. You can clip it medial to the sixth nerve. Oh, you have the seventh nerve. Beautiful, man. Just trap and bypass. Get added. That's the problem. That's IAM, right? You can easily, you have exposed the Peters, you have, and then you can go and clip it. But yeah. Yeah. No, that is C7. Beautiful, man. C7. This is what I exposed is C5. C7 is parapharyngeal. This is parapharyngeal. The vertical Peters. So vertical Peters, what I exposed is the horizontal Peters. Yeah. The horizontal yeah, it is just turning there. That is all. Yeah. But I exposed the distal horizontal Peters. So what you're seeing is a C7. What is becoming is C6. The vertical Peters, what I expose is the horizontal Peters. Yeah. The horizontal yeah, it is just but I exposed the distal horizontal Peters. What you're seeing is a C7. What is becoming is C6.
Mastoid segment of the facial nerve going right away. And cochlear is here.
Thank you.
The vertical Peters turning into horizontal. This and open the CP angle. What you're seeing is the acoustical bundle.
Hi, Dr. Alma. Hold on, did you get everything?
Your
Hi, John. How are you?
Yeah.
I see you.
Yes, sir.
Good, okay.
Yeah, you must understand that is always the seventh nerve is anterior, right?
Okay, we can't hear you.
We can't hear him.
Can you hear me?
You're seeing from posterior. So what is anterior is always the seventh nerve. Junction.
Sixth nerve.
Yeah.
Thank you, John.
Going,
Yes, sir.
it is getting into the inferior petrosal sinus, and then it will go up.
Probably the ICA.
Yeah, it's ICA. Yeah.
Basilar artery. That's the sixth nerve. Vertebrobasilar junction. Then lower cranial nerve. Ninth and
Yeah. That's the vertebral. That's a contralateral 9th, 10th, 11th there. Yeah. No, inga.
This one.
Yeah. There is 9th, 10th, 11th there. Excellent. Arachnoid bands. Yeah, the contralateral 9th, 10th, 11th. That is a.
You can say 12 also, I think. No, sir. This is the 9th and 11th.
That is 9th and this is 12, no?
9th and 11th.
No. 9th and this is 12. 12 is always multi.
Multi. That is 9th.
Where is 12 now?
But it's like.
I'm not getting oriented from this picture.
9th and 11th complex.
Maybe that is a 7, 8 then, huh?
7, 8.
Okay, 7, 8, 9.
That is below is the.
You are on the contralateral side, boss.
Below you'll see the 12 then.
Yeah.
It's on the contralateral side.
It's on the contralateral side.
It is because I am pushing it.
Sir,
Okay, good. Excellent. Fantastic. Yeah. Ajit, fantastic dissection, guys. Very good dissection then.
this is the cochlea.
Ah.
This is the cochlea. If we
Ah.
drill the cochlea and we this thing.
Ah. Yeah. Yeah, I saw. It's beautiful. Very beautiful. Thank you, guys. Yep. Sure. Watching. Amazing. Okay, guys.
चला झालं झालं चला जाऊया आपण